that is happening in patients who had transplantation is a major problem, not only for the transplant surgeons, but also to the endoscopist, and it affects the morbidity and mortality of the patients who had transplant. So we'll look at first a patient who was referred to me at Amrita when I was there. This was a 55-year-old male who presented with itching and jaundice, and as you can see the lab, he had a bilirubin of 19, alkaline phosphatase of 424, and he had LDLT done at Amrita 4 years ago. And his MRC showed an anastomotic stricture. And Dr. Sudhindran called me when I came there. This was in 2014 when I joined Amrita, and told me, "Sir, I have a case. Please take care of this patient. He had a transplant 4 years ago, and he's presenting with jaundice, and he has a stricture." So I was excited, as many of the therapeutic endoscopists are, as I have done a number of cases of DDLT cases, which are common in the United States. So I did an ERCP, and I documented, delineated the stricture, and I attempted to place an endoprosthesis, and I failed. I was disappointed, and the patient was sent for PTBD, and they tried, they failed. So we'll proceed and see. I'll let you know what happened to this patient. So what is post-transplant biliary stricture? How are they classified? What is the incidence and risk factors, the diagnosis, endoscopic management, and some concluding remarks. Post-transplant stricture can be defined as a stricture or narrowing which is demonstrated by clinical symptoms, biochemical findings in the absence of other causes of cholestasis, and sometimes you may require liver biopsy. They are classified into anastomotic stricture, which are usually extrahepatic, as you can see in this case, and they are more common, and they have generally a better outcome, and they are associated with multiple pathogenesis factors. This is a non-anastomotic stricture, which are usually intrahepatic. They are less common. The multiple ducts are involved, generally have poor outcome, and they may have an ischemic etiology. As you can see or understand that the cholangiocytes are very shy cells. They are dependent on oxygenation. So as soon as the oxygen is deprived, they die, and they end up in stricture formation in the bile duct. Now, we look at the incidence. The incidence varies from 10 to 25%. You can see it's somewhere there. In 2017, our publication, our series from Amrita, we had incidence of 10% of the patients who develop stricture, which is not bad, thanks to Surendran sir. And this is the classification that is seen. The stricture can be classified into anastomotic stricture. They are more common, 10 to 25%, and non-anastomotic strictures, 5 to 10%. Now, if you look at the anatomy of post-transplant strictures, these anatomical various, the regeneration of the liver influence the anatomy or the morphology of the stricture. So they conform to contortions of the bile duct, which gives you this bizarre appearance, sometimes described as the crane neck deformity, as you can see in this case. Now, the difference between DDLT and LDLT morphology is different. DDLT, they are long, elongated strictures. As you can see in this picture, multiple bile ducts may be involved in the ischemic non-anastomotic strictures. They are often associated with ischemia. Now, there are multiple risk factors. Age has been documented. The older the donor is, these are the donor factors. There is more likelihood of stricture formation. Another important factor that you will see in some of the pictures is the discrepancy or the disproportionate diameter of the bile duct of the donor and the recipient. And then steatosis, we are paying more attention. Nowadays, there is defattening technique of the donor liver, which will affect the macrovesicular steatosis, can influence the sinusoidal anatomy, which can slow the blood flow and can lead to oxidative stress and stricture formation. So there are also donor-specific alloantibodies. As we follow the footsteps of kidney transplant, we have been studying the alloantibodies associated with certain donors. Then the risk factors for the recipients are shown here. Most importantly, the ischemia, infection, and bile leak and the MEL store plays major role. Now, these are some of the publications on looking at the risk factors. You can see our own publication that hepatic artery thrombosis was associated with the worst form of stricture that we encountered. Clinical features, the stricture may present between 3 months and 12 months and can present up to 11 years, as in our case, which I presented to you. Usually they present with cholestatic jaundice, and the diagnosis, you should do an ultrasound and Doppler studies looking for ischemia, and MRC is the gold standard for diagnosis, followed by ERCP and intervention. And this is a picture that is a stricture documented by the MRC. You can see the location for intrahepatic ducts. Delineation of the anatomy is very good using MRC. And what will you do as an endoscopist in a patient with post-biliary stricture? You go ahead with the ERC to delineate the anatomy, which is extremely important, as Professor Peter Gordon has taught me several times, to see where the stricture is located and where you are going. Traverse the stricture with a guide wire. Endoscopic sphincterotomy is a controversial procedure, but we usually do it, followed by catheter or balloon dilatation, and followed by endoprosthesis. Plastic versus covered SEMS. I'll show you some data, and then repeat the ERCP to size up stent so you can dilate. On the left side of the screen, you can see a stricture, and the right side, you can see a nicely dilated stricture with beautiful results done at Amrita by us. Now, the protocol of stent therapy includes repeated ERCP at 2 to 3 months interval, especially if you are using plastic stent. And the duration of stent placement is between 6 months to a year. Now, modified stents have been the stent placing inside the duct. There are some reports by Tuzino and colleagues from Japan showed that it can prevent the duodenal bile duct reflux. And there are several studies where SEMS have been used in the management of LDLT strictures. We also have used in some patients, and I will show you this is the overall results of SEMS versus multiple stents. You can see the people carrying multiple stents on your head on the cartoon. And it has been shown that if you use multiple stents as followed by the protocol of Scotia Magna, you can get good results, comparable results with metallic stents. And even the recurrence are less if you use multiple metallic stents. And Who will benefit from endotherapy? You have to look at some of the problems which is shown in the right side of the graph here, table here. Duration of stent therapy is important. Aggressive stent management, especially if you are using plastic stents, and initial response to ERCP. When to intervene? This is very important that sometimes transplant surgeons are scared to send patients to us, but earlier the stent is identified, the better. As in the case of the patient, which I will talk to you in a minute, the more you delay, more after 12 months, the recurrence chance is high. High-grade biliary strictures, I'll spend a minute, is defined as contrast delineates only the recipient duct, unable to traverse stricture with guide wire. Contrast delineate recipient duct can traverse with an 0.18 inch guide wire, unable to pass dilators. There are some management options that were attempted: cholangioscope-aided guide wire manipulation, cholangioscopy and steroid injections. And this is a study which we published in high-grade stricture. As you can see, the management was basically do endoscopic sphincterotomy and pass the guide wire and use a Sohendra stent retriever for dilatation and stent placement. This is a case that we have done at Amrita. You can see an 18 guide wire that is passed and the Sohendra is screwed up into the duct, followed by stent placement. This is some of the data. This is from the same paper which we published. You can see we had 20 patients. We had very good results in most of them. So post-transplant medial stricture, this is the ASG guidelines which was published in 2023. MRC is the diagnostic modality of choice, followed by ERCP. The guideline does not recommend PTBD, and they look specifically at that. And antibiotics when proximal duct is not drained, and the guideline also recommends use C-cells. So I will not go into this in view of the short time set. And this was my patient, who ultimately we happened to place a stent in that patient, and he invited actually to his home in Kutanad, where I come from, and we had a beautiful ride in his boat, and this was the most wonderful experience I ever had. And he is still living after 12 years of transplant and doing everything that he wants in his life. Thank you very much.
Any questions from audience? Sir, I have a couple of questions, sir. Sir, we surgeons, when we do, sir.
Sir, on the stage.
Yes. Sir, we surgeons many times come across very difficult biliary anastomosis during LDLT. And we know that, okay, this is likely to stricture or result in early bile leak. So is there any role for preemptive ERCP stenting in such cases before patient develop symptoms?
Not really. I don't think preemptive ERCP will be helpful, and it may be problematic. You know that there was a lot of cases with infection which has been reported from Seattle. That's why, as Professor Peter Cotton mentioned yesterday, the idea of using disposable endoscopes. So there is no need to document it doing before and after. You document, nowadays you document the stricture. That's where I had some data on the definition of stricture. You have to be careful. If a post-transplant patient presents with cholestasis, it doesn't necessarily mean that the patient has a stricture and you have to go in. So it's a very tricky situation to handle. So we have to clinically evaluate, biochemically, and as you know, very well know, in some cases liver biopsy is needed.
And second, in a case of early bile leak, sir.
Yes.
In a case of early bile leak, what should be the timing like? Is it okay to go for ERCP in the first couple of weeks, or do we need to wait till the anastomotic lines almost has got a reasonable healing before going for ERCP?
It depends upon the volume of bile leak or the gravity of the situation. If there is significant bile leak, that has to be addressed as early as possible in my own experience at Amrita and also in Chicago. If you have a lot of bile that is gushing out, we have had cases like that. Compared to the anastomotic leak, then it is better to go and take care of it as early as possible, and we can do it without major problems.
Thank you.
Sir,
Yes.
sir, just one question.
Yes.
Sir, in high-grade strictures where
Yeah.
there is complete cutoff, there's some data on placing magnets in the recipient, I mean, in the proximal as well as the distal part of the stricture. So, your views on that?
I personally don't have an experience with the magnet. That has been tried. You are absolutely right. And if it works, it works. As in my case, you have seen that one of the take-home message in that patient who is still living, he had HCC, is that the stricture was diagnosed later, and 4 years after. That's very critical. If you have a stricture, a post-transplant stricture, and that the data, overwhelming data, if you diagnose it early and if you intervene, then the prognosis is good. In difficult stricture cases, there are certain techniques which we use, which most of the time work. And in that case, although the initial PTPD did not work, and also the initial ERCP did not work, ultimately we could pass an 18 guide where, with the help of both sides, the radiologist, interventionalist, as well as our own help, and finally we could manage him very well.
Thank you, Doctor.
Thank you,
Thank
sir.
you for your time.
Thank you.
I request the presence of the next speaker, Dr. Sudhir Pargewar, to talk about PTBD in a non-dilated system, how I do it.
Good morning, everyone. First of all, I would like to thank Dr. Agustin and Dr. Sachidan and Rajesh for giving me an opportunity to share my experience of PTBD in a non-dilated biliary systems. So now we need to know what defines a non-dilated biliary system. What are the causes of the non-dilated biliary system which prompts an intervention? What are the hardwares required for these interventions? What are the techniques and strategies that need to be inculcated for puncturing a non-dilated biliary system, and what are the complications associated with these procedures? So first of all, what defines a non-dilated biliary system? So any second order intrahepatic biliary radical which is less than 2 millimeter in diameter, or its diameter is it's more than 40% of the adjacent portal vein radical, this constitutes a non-dilated biliary system. So we have some signs on ultrasonography like parallel channel sign, or also called as double barrel shotgun sign. If we have these signs, we say that there is a presence of intrahepatic biliary radical dilatation. If this is absent, we can surely say that this is a non-dilated biliary system. So what are the causes of this non-dilated biliary system which prompts an intervention? These are the patients who are predominantly post-transplant with anastomotic site strictures or the bile leaks. Some are iatrogenic or traumatic bile duct injuries with bile leaks. Some of the patients are patients with cholangitis in biliary enteric anastomosis or duodenal stump syndrome. So these are the risk factors which have been dealt with in the previous talk. To name some of them, the risk factors are the advanced donor and the recipient age, multiple anastomosis, narrow caliber ducts, long cold and warm ischemia times, hepatic artery thrombosis, and improper surgical technique. If you see into the literature, these biliary complications remain a major morbidity and mortality cause, ranging from 10 to 15% in LDLTs and in DDLTs, and the incidence increases to 15 to 30% in living donor liver transplants. So do we really need to intervene in these non-dilated biliary systems? So what we have found out, that the absence of the biliary dilatation has not been a reliable indicator of adequate biliary drainage. There is significant lack of correlation between the ductal dilatation on ultrasound and the clinical picture. The size of the duct has not been found to be a reliable indicator of following up these patients or assessing the response to the treatment. The degree of proportion of the biliary dilatation compared to the degree of anastomotic stricture in post-transplant patients, it do not correlate. The cause is unclear, whether it's a denervation injury, whether it's a ischemic reperfusion injury, or it's a preservation injury. The variable degree of biliary fibrosis subsequent to these injuries make the bile ducts less pliable, so they are less dilated as compared to the other patients. So before tackling these non-dilated biliary systems, we need to know what we are dealing with, what is the hardware in the interventional radiology which is available. So we have different things. If we want to kill a zombie, we know we need to have a cricket bat, whether we need to have an axe, or whether we grab anything in nearby to you and kill the zombie. So these are the different hardwares which are required for interventions in non-dilated biliary system. The heart of the hardware is the percutaneous access set. I will come to it later. Another hardwares are the diagnostic catheters, the hydrophilic guide wires, the stiff guide wires, the facial dilators, and different types of biliary drainage catheters available in the market. So as I said earlier, the heart of the non-dilated biliary system intervention is this hardware, that's the percutaneous access set. Predominantly, many are available in the market, but the three main available in the market are the NEF percutaneous access set, it's manufactured by Cook, acoustic introducer set by Boston Scientific, and the Acura kit by the Blue Nin. All these systems basically has three components. One is the Chiba needle, second is the overnight cope mandrel wire, the third is a sheet with the dilator and the metal stiffener. This is how they look. This is the Chiba needle, this is the sheet with the dilator and the stiffener, and this is the cope mandrel wire. It is predominantly a nitinol wire with a platinum tip. The difference between the NEF set, acoustic, and the Acura kit is the NEF set has a 21 gauge Chiba needle, where the rest of the sets has a 22 gauge Chiba needle. The internal diameter of the sheath in NEF set and the Acura kit is 4 French, while in the Boston Scientific acoustic, it's 4.5 French, which allows the double stick buddy wire technology, that's O18 and O35 guide wires adjacent to each other through the same channel. So this is how it looks. So there are the different strategies and techniques which are required for puncturing a non-dilated biliary system. That's the peripheral portal vein oriented bile duct puncture, PTBD assisted by virtual sonography, also called as fusion imaging. The central duct puncture with cholangiogram followed by fluoroscopic or the balloon assisted puncture of a peripheral duct, also called as two-stick technique. The first technique is a portal vein oriented technique. We can see that this is an example. There's a 1.9 mm duct adjacent to the portal radical. If we target the portal radical, we can have a duct adjacent to it. The second technique is the fusion imaging, in which we feed into the ultrasound unit the CT or the MR data available with us. It gives us the 3D imaging in the oblique views, the fusion image, and we can puncture the duct. The third technique is a two-stick technique, in which we puncture the central duct, we opacify it with a contrast, and once the peripheral ducts are opacified, we puncture it with another Chiba needle. That's the two-stick technique. Another important strategy is the angle of entry into the bile duct. The ideal angle of entry into the bile duct is 30 to 45 degrees. Anything greater than 45 degrees causes a problem of negotiation of O18 wire into the biliary system. So this is an example. This is Nakamura type 4 biliary anatomy, iatrogenic bile duct injury. The MRCP showing isolated anterior ductal prominence with a bilioma. Once I punctured into the duct, this is what has happened. The angle is greater than 95 degrees, and look at this. How difficult it has been for me to direct the O18 guide wire into the biliary system towards the hilar plate. As opposed to this, if I puncture with an angle approximately 45 or less than 45 degrees, Look how easy it has been to negotiate the guide wire towards the anastomosis into the biliary system. The third thing which we need to know is the MRCP anatomy before puncturing a non-dilated system. It gives us an idea about the path of entry, the number of anastomosis, the presence or absence of the bile leaks, cholangular abscess, the number of ducts which we need to be negotiated, which need to be dealt. So how I do it? We give the antibiotic prophylaxis prior to the procedure as per the institutional protocol. We keep NBM for 2 to 4 hours. We pain drape the skin with chlorhexidine solution, local anesthesia with a 2% lignocaine, and the pain management with the help of fentanyl and mild sedation if required with midazolam. The first thing we need to do is know the patient's coagulation profile, PT, INR, and platelet. At our institute, the cutoff is 1.5 for the INR, and for the platelet count, it's more than 50,000. Cutoff is 50,000. Surgical details, what surgery has been done, what is the site of anastomosis, number of anastomosis, detailed anatomy of the graft liver, including the orientation of the portal radicals, and the 3D MRCP. Antibiotic profile of the patient during or the peri-transplant period is very important because that's the antibiotic we choose to give it to the patient during the PTBD. Screen on ultrasound for ascites, collections, cysts, abscesses, and approach to the puncture. Keep the required hardware handy and with alternative options to it. So this is a case in which I can see a non-anastomotic narrowing. It may be a bile cast, 2 anastomosis, both have anastomotic stricture. There is the presence of the bile leak adjacent to the anastomosis, anterior and posterior ducts separated from each other. So good local anesthesia is the key. This is how I give the local anesthesia till the capsule and a small fluid pocket adjacent to the capsule. Once done, I predominantly use a portal vein directed puncture. Nowadays, the ultrasound machines have so good resolution that we can see a bile duct adjacent to the portal vein. So this is how I target. My personal best thing is the NEF set. It has a 21 gauge Chiba needle, can be very well directed towards the portal vein, and adjacent to it we can puncture the bile duct. So after puncturing the bile duct, we do a cholangiogram with a diluted contrast, 50-50%. Sometimes while injecting cholangiogram, we can see a portal venogram by the brisk outflow, and the needle can be redirected and entered into the bile duct, and we can do a good cholangiogram. So once into the bile duct, we insert a overhead cope mandrel wire, followed by the insertion of sheath introducer stiffener assembly. The ideal point of puncture into the bile duct, if you take the long axis, the 3/4 and 1/4 junction, this is the ideal point of punctures in the non-dilated system because it helps in further manipulation during crossing the strictures. I personally avoid puncturing the bile ducts adjacent to the cut edge of the graft liver because the further manipulation with the guide wires is difficult. So once into the biliary system with the sheath assembly, we negotiate the stricture. If the 6 French introducer sheath can go through, we use that to pass across the anastomotic stricture. Sometimes it's very difficult to pass the 6 French guide wire. So we use, I use a 4 French sheath or a 6 French sheath, pass a 4 French diagnostic catheter and a 035 guide wire into the biliary system and negotiate the stricture. If I use a acoustic or a 4.5 French internal diameter introducer sheath, I have the liberty of a double wire technique and negotiate across the anastomosis. Sometimes I use lateral views. MRCP guides me for using it. Look at this, on the lateral, the bile duct is common bile duct is very well opacified. And I can, personally, sometimes I have to use 025 guide wire to negotiate across the stricture into the CBD. Once into the bile duct, I cross the ampulla with the help of the guide wire, exchange it for a stiff guide wire, and insert internal external biliary drainage catheters. All this is further complicated by the presence of the bile leaks, by the presence of the bile casts, and intrabiliary sludge. The overall complication rates between the non-dilated and dilated system PTBD, there is no significant difference. Only thing is bleeding risk is for a little bit higher. In my experience, till date from 2017, we did 92 patients, of which 122 procedures, failed internalizations in 13% of the procedures, and to look, there is no significant bleeds in any of the patients, no hemothorax, no significant hemoperitoneum in these 92 patients. So the take-home message is, know your patient properly, know the surgical details, study the MRCP and USG properly for the anatomy, choose a proper angle of puncture, choose a proper technique to target a non-dilated system, know your hardware properly, use ultrasound and fluoroscopy very well, achieve adequate biliary drainage, the number of ducts to be intervened, we need to know from the start, and do not forget that there is no significant difference in the complication rates between the dilated and the non-dilated biliary system PTBD. Thank you.
Any questions from the audience? It was excellent talk, Dr. Sudhir.
Thank you.
I have one doubt. In a sense, the bile duct will be in close relation to the vessels.
Yes.
Are there any specific techniques you use to avoid the vascular injury, or what is the incidence of hemophilia? Or
Yeah. So to be frank, I predominantly use a 21 gauge Chiba needle. Even if we enter the portal radical or an artery, and if we see that I have punctured it, if the coagulation profile of the patient is good, we can retarget, enter into the bile duct, and if we enter a point which is 3/4, 1/4 length across, there is minimal chance of hemophilia. I had just 2 patients with hemophilia that tackled after the insertion of the internal external catheter. In these 92 patients, just 2 patients had this problem, but none of them had a significant hematomas, neither of them have significant bleeds.
The initial problem, many years down the line or months down the line, run into biliary problems and they need a regraft for that reason. So they're serious problems. So the basic principles of dealing with hepatic artery stenosis or thrombosis are, first of all, if it's a long-standing problem, if you've seen this stricture for many, many weeks or months, there's no point trying to fix it. The problem has occurred, the biliary radicals will have been interfered with, and it was due to ischemia, and that patient will survive for some months, but they will run into biliary complications and almost certainly will need a regraft. So long strictures do badly. If on a CT you see a very long stricture, try not to intervene. You can often make things worse rather than better. So it's very important to know when to go in and when not to go in. So short strictures can be treated, and there's evidence of if embolizing splenic arteries or the GDA, you can actually divert some of the flow to the hepatic artery and keep that liver going. And there are reports of long-term patency in excess of 2.5 years. So first of all, in arterial complications, you must know your anatomy. So the CT is important, but also just clearly open discussion with the surgeons. Here's an example. We could have spent hours looking for the celiac axis, but they'd actually plumbed it in to the SMA. So you must know your anatomy, and there'll be a few examples of this coming up. So and the other thing, the important thing, if you get post-transplant collections, so in this case it's abscess stroke biloma that's clearly obvious and easily drainable, that's fine. But you must see also the hepatic artery is thrombosed. So that always look, if you've got bilomas or biliary complications, look for the arterial problem. And it's also, like I said, they cause biliary strictures, and they all need to be dealt with separately as well. So here's a patient who had a long-standing biliary hepatic artery thrombosis. We knew that. We'd already put an internal external drain in, but the patient presented with recurrent episodes of melena. So we did an angiogram to look for what's happening here. Is the hepatic artery recanalizing or through side branches or anything? And we couldn't find anything, and we left it alone. But the melena persisted, so we came back, and this patient had actually was bleeding from a side branch of the SMA, totally unrelated to the transplant. So that's one other thing to remember. Whilst we view patients with post-transplant as post-transplant patients, they also can have normal run-of-the-mill problems. So don't forget those things on the side. And that was easy enough to embolize and stop that bleeder there. Here's an interesting lady, 20-year-old. She had a living-related transplant on the 1st of August, 5 years ago, and then developed a bile leak 19 days later, which was easily drained. As I said, any biliary problem, think hepatic arterial problem as well in a post-transplant patient. And so we did a CT, and then we went on to do an angiogram, and you can see there a very long stricture of the hepatic artery leading up to the anastomosis. But there is some inflow into the hepatic arterial branches, but not great. It's not a great flow, but there is flow. So this was a stenosis, and this was an acute presentation and likely some thrombosis. And what we did is leave a Kragniger catheter across this point and left some thrombolysis running for 24 hours and bring her back. Thrombolysis, I will say, you have to bear in mind, this is 19 days post-transplant. Thrombolysis, whilst it has its uses, it also has many, many risks involved. There's a systemic dose, and they are at risk of bleeding into their brain and elsewhere. And also, there's the 19 days post-transplant intra-abdominal bleeding should be borne in mind. So use it, but use it with caution. Anyway, 24 hours is what our sort of protocol is to run it. And after 24 hours, she came back, and essentially it looked exactly the same. There was no change whatsoever. So at that point, one of my colleagues decided we'd need to try and cross this and get a stent in, because it's still fairly early days post-transplant, and especially because there is some intrahepatic arterial flow across the stricture, there's a chance that we may be able to, that the bile duct damage is not that severe at this point. So my colleague tried to cross this, but unfortunately ran into causing this pseudoaneurysm, dissection at the origin. This dissection, however, he was lucky enough to cross a dissection in the celiac axis or hepatic artery proper at this stage is very dangerous because it's an antegrade dissection, and hence the flow of the blood will make it worse once you come out, and you will essentially occlude that system. So you're duty bound to try and cross that anastomotic dissection at that point, which he managed to do and get up into the intrahepatic arterial tree, and then he placed some non-covered stents across that, and everything looked wonderful. And the patient was doing fine, went home. But 18 months later, she came back with recurrent episodes of some minor melena and everything. We did a CT and we did an angiogram, and what you can see is that she's formed a pseudoaneurysm around where that dissection site was, and also smaller pseudoaneurysms intrahepatically as a result of the difficult manipulation during the stenting. So what we did is we went back in and we managed to go through the side holes of the small stent and get a microcatheter in, and we put a load of coils into that first pseudoaneurysm sac. So we dealt with that problem, the large pseudoaneurysm there. But then all the distal pseudoaneurysms that you can see here are still filling, and the only way to really treat that, and we made a decision, was we're going to have to sacrifice, it was this branch that was going to be sacrificed, and we're going to try and put a covered stent to occlude all of these vessels, which we managed to do. And we got good flow. We occluded all those pseudoaneurysms, and to date she's doing well, but the last I heard, she was starting to get her biliary strictures. So these are now a few years down the line, they start to get their biliary strictures. It's inevitable. Here's another very complex case, this 58-year-old lady who'd had 3 living-related donor transplants. And she was running out of relatives, and the first 2 had failed 4 hepatic arterial complications over the course of 10 years, and each one had lasted 5. She'd had biliary complications, another graft, hepatic arterial complication, another graft, and this was the 3rd and final family member she could get a graft from a compatibility point of view. And lo and behold, she ran back into arterial complications. But this time of a slightly different nature. We weren't expecting this. So when we did the CT, she had developed this pseudoaneurysm with this sort of abscess cavity around it. And this actually, it was aspirated by our EUS people, and it came back as a mycotic aneurysm. And she was clearly very unwell, and also the hepatic arterial flow was not great. The hepatic artery had actually been plumbed, as you can see from that top right picture, directly from the aorta to this graft, and there was a pseudoaneurysm just coming off the side of that as well. So a lot of problems this lady was in. So what we decided to do, and there's obviously no textbooks on this stuff, it's sort of making it up as you go along. We put a covered stent graft through the aorta with a fenestration to get into the hepatic artery, which we managed to do. We've obviously preserved the renal arteries and the SMA and the SMA and the renal arteries. But once we got across into the hepatic artery anastomosis, we then had to put covered stents to occlude that second pseudoaneurysm. We're fully aware that these are infected aneurysms and these stents are at very, very high risk of getting infected. But obviously with a large pseudoaneurysm like that, the risk of sudden rupture and death is obviously present. So, but she did fairly well. This was a few years ago. She did last for about 3 years, unfortunately. As we anticipated, she didn't. She just made it past the age of 60, but she'd run out of options. It's the old surgical saying, the operation was a success, because these remained patent all their life, but the patient died. So I'll leave that with you. So in conclusion, post-transplant hepatic arterial problems are not uncommon. Generally, the rule is deal with them early, because the biliary complications from the ischemia start to happen immediately, but they need to be treated in specialist transplant centers and in consultation with the whole team. IR clearly has a very important role to play, but it's, as in all games of transplantation, it's very, very much a team game. Thank you very much.
Any questions from the audience?
Thank you, Dr. Kamaljeet. Very nice lecture. I would like to ask one question. In one of the cases, you have shown that you have run a thrombolysis 19-day post-transplant. Yeah. What's your experience with coiling of the GDA? Because most of the thrombolysis sometimes runs off into the GDA and goes into the systemic circulation more and more. So do you routinely do the thrombolysis without the coiling of the GDA, or you coil the GDA during the thrombolysis?
Okay. I would not coil the GDA, and the reason for that is certainly in that case, you saw some intrahepatic arterial filling. Whilst at that stage, it has to be coming from the anastomosis and across, but in future, the liver, if it survives, may start to recruit arterial supply from the GDA, and for that reason alone, I would try and preserve it. And even if you do occlude it to give the thrombolysis, with the aim that it's going further into the hepatic artery rather than elsewhere, there's still going to be backflow and all the rest of it. I don't think there's any way of proving you get more thrombolytic agent into the hepatic artery at that point by starting to occlude other avenues. And on that note, there are people who advocate give systemic thrombolytics because the actual dose delivered is similar and you don't risk damaging the artery locally by leaving a catheter there for 24 hours.
Sir, I have a doubt, sir. So, regarding your anticoagulation or antiplatelet use, how long we should use and how to anticoagulate the patient post-stenting?
Sorry, I didn't hear that. Sorry.
So, post-stenting, what is your strategy in anticoagulation and antiplatelets?
Okay. Generally, we will give anticoagulation in the form of oral anticoagulation. It can be as simple as aspirin. Now, again, if you look at the evidence, there's no real studies out there comparing whether you can or cannot. So I do always wonder, are we treating ourselves or are we treating the patient? But it would seem logical that if you've got very small stents, some of these are 2-3 millimeter diameter stents, that you would increase patency by giving some anticoagulation orally.
Just I have a question. So, what kind of stents you suggest for like medicated stents or non-medicated stents? And another question is like, what is your thrombolytic protocol? How you adjust the thrombolytic protocol for a post-transplant settings?
Sorry, I didn't hear I'll answer the first question in terms of the stents. So we use basically bare metal stents, but as I said, showed in that specific case with the pseudoaneurysms, it is necessary sometimes to use covered stents, but obviously you want to keep the possibility of collateralization open as much as possible. Hence, I tend to avoid covered stents unless they're absolutely essential. Sorry, I didn't hear the second question.
My question was the medicated stents versus non-medicated stents.
It's very hard to hear. Sorry, what stents?
Medicated and non-medicated stents.
Oh, I've never used medicated stents. I have no experience of that, but these small stents, as far as I'm aware, bare metal has always been adequate. I don't have any experience of medicated stents.
So what is your protocol for thrombolysis in case of post-transplant settings? Like, how do you adjust the dose?
Okay. First of all, it's done very much on a case-by-case basis. There is no one recipe for everyone. The patient's weight and size, especially in the pediatric population, becomes of great importance. We tend to use TPA because it's got a shorter half-life, and if they have complications, you can turn it off and very quickly. Some people give a bolus dose. I generally do not. I leave an infusion running over 24 hours of a small amount, and it's titrated very much based on the patient's weight and overall size.
Thank you.
Thank you, Doctor.
Yeah, thank you.
I request the presence of the next speaker, Dr. Ravindran R., to talk about outflow complications of liver transplant. Doctor, please.
So good morning one and all. At the outset, I would like to thank Rajesh sir and the organizing committee for giving me this opportunity. So today I will be talking about outflow complications in liver transplant. So in a liver transplant setting, incidence outflow complications are much less when compared to the inflow, that is the arterial and the portal venous complication. When we look into the historical data, the incidence of outflow complications in adults varied greatly, ranging somewhere between 1 to 13%. But with improvements in surgical techniques and immunosuppression drugs, the incidence has now reduced to somewhere between 1 to 4%. Also, when we compare adult versus pediatric liver transplantation, the frequency of outflow complications are a bit higher in pediatric population because majority of the pediatric donors are adults, and that usually tends to be a size mismatch between the donor and the recipient veins. Also, when we compare among different types of liver transplants, the frequency of outflow complication is bit higher in split transplants, followed by LDLT and least in DDLT. So this slide shows the surgical techniques that is used for outflow reconstruction in DDLT versus LDLT. In case of DDLT, the donor liver is removed en bloc along with the segment of the retrohepatic IVC. This IVC is closed at the cranial and caudal end and is then anastomosed to the recipient IVC in a side-to-side fashion. This is called as piggyback technique. Whereas in case of LDLT, in case of a right lobe graft, the right hepatic vein of the donor liver is anastomosed to the right hepatic vein ostium of the recipient liver. And also in LDLT, there is something called as neo-MHV, which is nothing but a PTFE graft or cadaveric iliac vein graft that connects some of the segment 5 and segment 8 tributaries of the donor liver to the recipient IVCs. Since the number of anastomosis is multiple and complex in LDLT as compared to the single anastomosis in DDLT, the outflow complications tends to be higher in LDLT as compared to DDLTs. So regarding the classification of outflow obstructions are classified into early and late. Early is something which occurs within 28 days of surgery, and late is beyond 4 weeks of surgery. The causes of early outflow obstructions are most often due to technical issues like a tight anastomotic suture, or the graft liver tends to be more mobile in case of a transplant setting because it loses its normal points of fixation unlike the native liver such as the coronary ligaments and the falciform ligaments. So the graft tends to rotate around the vascular pedicle and this can result in the kinking or the twisting of the outflow tracts. Some early outflow obstruction can also be due to anastomotic compression from the graft edema or it can be from the adjacent fluid collections. Whereas when we look at the causes of late outflow obstruction, it includes a neointimal hyperplasia, or it can be due to perianastomotic fibrosis due to inflammation, or it can be due to anastomotic compression due to graft maturation. So going on to the clinical features, the most common clinical feature associated with outflow obstruction is ascites, which in the early post-operative period generally manifests as increasing drain output. So other clinical features includes increasing pleural effusion, bilateral pedal edema in case of IVC stenosis, abdominal pain with tender hepatomegaly, elevated liver enzymes, renal dysfunction, intestinal congestion, fulminant graft dysfunction, hypotension, and multi-organ failure. So going on to the imaging diagnosis, ultrasound is always used as an initial screening tool because it's widely available and can be easily performed as a bedside procedure. Doppler ultrasound findings in outflow obstruction includes a monophasic flow with loss of respiratory phasicity as you could see here, or if there is a complete obstruction, then a Doppler does not show any flows. If Doppler findings are inconclusive, then it is always beneficial to do CECT or contrast enhanced MRI because CECT has got better sensitivity and specificity in diagnosing outflow obstructions when compared to the Doppler ultrasounds. So going on to hepatic venography, hepatic venography is the gold standard for diagnosing outflow obstructions. Every case suspected to have an outflow obstruction based on ultrasound or CT should always undergo hepatic venography to confirm the diagnosis. The advantages of hepatic venography includes it can assess the degree of stenosis, it can show the flow dynamics, presence of venovenal collaterals, it allows measurement of pressure gradient across the stenosis. We can also perform transjugular rival biopsy where the histopathological specimen often shows features of congestion, hemorrhage, zone 2 or zone 3 coagulation necrosis, and it also allows for therapeutic intervention. Though measuring pressure gradient can support the diagnosis of outflow obstruction, there is no validated threshold gradient above which the outflow obstruction is considered to be significant. Some of the studies say that anything which is more than 10 mm of Hg to be significant, but certain studies say that in a symptomatic individual, anything more than 3 mm is considered significant and needs appropriate treatment. So the commonest route of access is usually a transjugular access followed by the transfemoral access. Management of outflow obstructions are primarily endovascular and because surgery has got its own technical difficulties and generally requires a clamping of the portal vein and IVC, which further complicates the clinical scenario. Among the endovascular approaches, balloon angioplasty is the preferred first line of treatment. Though angioplasty has got high initial patency rates, outflow obstruction tends to recur following angioplasty, and it usually requires serial sessions of balloon dilatation or stent placement. Cubo et al. Described primary patency rate of around 60% and assisted patency rate of 100% at the end of 5 years following balloon angioplasty, with restenosis in 55% of the individuals. They have also showed that around 76 to 79% of patients with restenosis required not more than 2 to 3 sessions of balloon dilatation. So stenting is generally deferred in a case of primary stenting is generally deferred in case of primary stenting is not usually done because stenting itself is inherently thrombogenic. It can induce neointimal hyperplasia, and its presence itself can complicate future surgical interventions or retransplantation. So stenting is generally reserved for cases which are refractory to serial balloon dilatation or in cases where there is immediate elastic recoiling following balloon angioplasty. However, there is an emerging data which highlights the role of primary stenting in the setting of early outflow obstruction. This early outflow obstruction is a unique scenario because performing a balloon angioplasty in early outflow obstruction can theoretically increase the risk of rupture in a newly created anastomosis. And also, some of the early causes of outflow obstruction like kinking or graft compression, anastomotic compression due to graft edema cannot be addressed by balloon angioplasty alone. And in such cases, the primary stenting would be beneficial. So this slide shows some of the studies that highlights the role of primary stenting in early outflow obstruction. A study by Ko and its group from Asan Medical Center, Korea, has treated 170 cases with primary stenting and has shown a 5-year patency rate of around 70% with recurrence rate of just 13%. Similar studies by Chu and Jang from Korea showed a 5-year patency rate of 94 and 88%. However, a recent literature by Kim and its group from Samsung Medical Center, Korea, has showed a very low 5-year patency rate of just 46% and a recurrence rate of 40%. In this study, they attributed their findings predominantly due to that a majority of their outflow obstructions were due to kinking rather than stenosis, and the stenting were not able to address the cause of kinking. So regarding the choice of stents, both balloon-mounted and self-expanding stents are found to be equally effective. Comparison between the balloon-mounted and self-expanding stents in the setting of outflow obstruction is yet to be determined. Wang and its group has used a short balloon-mounted stents and has reported a 1-year patency rate of around 92%, whereas a Korean group has used a self-expanding stent and has reported a 5-year patency rate of 72 and 94%. So the choice of stent is primarily operator dependent and has to be decided based on individual case-based scenarios. Regarding a stenting in pediatric cases, it always needs a careful approach because what was appropriately placed stent at the time of intervention might turn into a fixed stenosis as the child and the graft grows. So stenting is generally delayed in a pediatric individual until they attain maturity. If stenting has to be done, generally a large self-expanding stents are generally preferred because these stents tends to expand as the child grows and it prevents future instant restenosis or a graft migration. So the complications following endovascular treatment of outflow obstructions are usually rare, and it includes a disruption of venous anastomosis, transient hypotension when we do prolonged inflation in IVC, arrhythmias can occur when the balloons prolapse into the right atrium, and the last but not least, sustained migration can occur. The majority of the studies have showed major complication of rates of usually less than only 3%. So this is one of the 4-year-old male child who underwent LDLT for Wilson's disease. This child presented with increasing ascites 3 months post LDLT, and the Doppler ultrasound showed a monophasic flow with loss of respiratory phasicity. Hence, this child was taken for hepatic venography, which showed an anastomotic stricture in the left hepatic vein. So this stricture was crossed with a wire and was balloon dilated with a 640 non-compliant balloon. So post dilatation, we could see a good flow across the site with no residual stenosis. So this child luckily done well with a single episode of balloon angioplasty, and no further intervention required in this case. So this case I borrowed from Dr. Rajesh sir. This is a 50-year-old gentleman who underwent LDLT for ethanol-related CLD. On day 16, this patient had a suddenly increasing brain output with elevated liver enzymes. The Doppler ultrasound here showed no flow in the segment 8 part of the right hepatic vein. Segment 8 vein, which is actually was anastomosed directly to the middle hepatic vein. So CT was done on day 16, which showed there is a thrombosis of the segment 8 vein. This is the day 11 CT, which showed segment 8 was patent and was directly anastomosed to the IVC. So this is the venography run, which shows occlusive thrombus at the proximal, at the anastomotic site with patent distal segments. So this was treated with a balloon-mounted stent, 940 balloon-mounted stent. Post-stenting, we could see a good flow across the stenosis, and this is a post-stenting Doppler study where we could see a good flow in the IV vein with good triphase, with good respiratory variations. So to conclude, outflow obstructions or infrequent complications of liver transplantation, it can be classified as early or late, and endovascular management remains the mainstay of treatment. Balloon angioplasty remains the first line of treatment, especially in cases of late outflow obstruction, but primary stenting might be needed in certain cases of early outflow obstructions. So thank you.
Any questions from audience? A very nice talk. So what is your preferred anticoagulation policy after stenting, especially in pediatric patients?
In our institute, we give Eliquis and low-dose aspirin. Eliquis 2.5 mg OD and low-dose aspirin we give for 6 months.
Sorry?
Then we do a
Okay, okay, yeah.
repeat Doppler. If it is a good flow is there, then we stop it.
Is there any role of covered stents in hepatic?
So covered stents will block the tributaries of the hepatic veins. So especially in post-transplant setting, these tributaries are very important. When we cover these tributaries, it might lead to congestion and cause further graft damage.
So your approach to this stenosis is always transjugular?
So I couldn't hear you.
The approach to the narrowing is always through the transjugular, or do you
Sir,
have percutaneous?
in some cases of DDLT where there is a piggyback technique, sometimes the transfemoral route will be more easier. But so far I don't have any personal experience. I've heard from my colleague.
Transhepatic route? Any experience with transhepatic route?
That's all. I don't have any experience, personal experience on transfemoral route.
Thank you, doctors. We move on to the next session. The next session is about distal biliary malignancy, and I request the presence of the chairpersons, Dr. Sunil Kematai, Dr. Jeffrey George, Dr. Venugopal B, Dr. Praveen Keshav, and Dr. Pulkit Rangar on stage. I also request the presence of the speaker, Dr. Gavrav Muktesh, to talk about endotherapy of distal biliary malignancy. What are the options?
Good morning, everyone. I'll be talking about the endotherapy of distal biliary malignancy. What are the options? And this is going to be the outline of my talk. Well, if I go about talking about the endotherapy, it will be a 1-hour session in itself. I'll be trying to focus upon the emerging modalities, the role of EUS, and how we have moved forward from the conventional ways. Talking about the ERCP, we know it's been the time-tested modality for over 2 to 3 decades now. And the standard modality of palliation for diagnosis, for cannulation, has stood ERCP. One can do a biliary stenting, one can do a brush cytology, as one can see in this case, where we can see a stricture in the distal bile duct, and one can do a cholangioscopy, a spyglass, where one can take stricture biopsies, one can do a selective cannulation of bile duct, especially in type 3A, 3B strictures. However, we have moved a long way from just the diagnostic ERCP part. We know that we are successful in about 90% cases, but we fail as well. And the problems can be upper gastrointestinal obstruction because of the malignancy. It can be surgically altered anatomy. There can be a periampullary tumor infiltration. And this is when the role of EUS comes in. One can see here there is a large periampullary diverticulum. The cannulation becomes challenging. You keep fiddling at the ampulla, and one knows that the more time you spend at the ampulla, more time you get with normal ERCP, higher is the risk of pancreatitis. The moment your duration of time for ERCP goes beyond 10 minutes, the risk of pancreatitis goes up manifold more. Similarly, in Billroth 2 anatomy, in patients who have Roux-en-Y gastric bypass, getting to the very site of ampulla becomes a challenge. This is where the role of EUS-guided biliary drainage comes in. How exactly do you do EUS-guided biliary drainage and how it's transformed the care over the last few years? We have transluminal biliary drainage strategies, which include the choledochordinostomy, the hepaticogastrostomy, and then when you're trying to do a normal ERCP by getting a guide wire to the ampulla, by doing a EUS-guided rendezvous procedure, the EUS-guided anterograde approach, and when nothing works, you can actually just drain the gallbladder and get a EUS-guided gallbladder drainage. This is what transluminal biliary drainage strategies are. Hepatogastrostomy for the unversed is just a communication between stomach and the left lobe of liver. The choledochordinostomy, you're trying to create a fistula between the first part of duodenum and the bile duct. And the indication has traditionally been unresectable biliary malignancy with duodenal obstruction. The safety and the adverse effects of EUS-guided biliary drainage procedures has varied from about 10 to 25%, including bleeding, bile leak, pneumoperitoneum, the stent migration, cholangitis, and peritonitis. However, the serious complications like perforation and sepsis are less than 1%. Now, this is exactly how you're doing a EUS-guided rendezvous procedure. You identify the bile duct, you try and pull back your scope, you puncture the bile duct, and you negotiate a guide wire down into the duodenum, and using the same axis, you try and cannulate and get a bile duct cannulated using the usual ERCP scope. This is a EUS video, just a demonstration of how a EUS-guided rendezvous procedure is performed when you're failing with the ERCP. One can see the bile duct here into the picture. The cannulation has failed. Using a 19-gauge needle, you're trying to get a best possible window. And you make a puncture inside the bile duct. You negotiate your guide wire. And once your guide wire has come out of the ampulla, the procedure is just like a usual ERCP. You can see the wire is called in the ampulla. And then subsequently, from this exit side, you can get back into the bile duct. This is what exactly the technique that I was talking about. So how exactly would you do a EUS-guided rendezvous procedure? You can do an intrahepatic puncture, you can do an extrahepatic puncture. And again, extrahepatic puncture can be using a long scope position or a short scope position. My personal preference is usually a short scope position because you're puncturing the bile duct from the first part of duodenum, and you can negotiate your guide wire very easily through the ampulla, which makes the job much simpler. The most challenging part about the rendezvous procedure is getting the wire across the ampulla. So the shorter the distance, better the outcomes. You can see in the intrahepatic puncture, the scope position is straight. This is the long scope position, and this is the position that I was talking about, where your scope is in a shorter position and you're negotiating the guide wire across the ampulla. Now, talking about hepatogastrostomy, which you can again do in carcinoma, head of pancreas, periampullary cancers, liver mets, duodenal cancers, and duodenal infiltration. You can see there is a blockage here. You're creating a permanent fistula between the left lobe of liver and the stomach by negotiating a guide wire through the left lobe of liver, getting the guide wire to call inside the bile duct, taking a cystotome, creating a fistula, and putting a metal stent. You can see this is a hepatogastrostomy. For the want of time, I'm not showing the entire video, but this entire communication of the stent is from the left lobe of liver into the stomach. Talking about choledochordonostomy. Now, it involves a slightly different procedure. You're trying to create a fistula between the first part of duodenum and the bile duct. And this is a short video demonstrating the same procedure in a patient with periampullary cancer. I tried a lot. We could not get inside the ampulla. We kept persisting, but sooner we realized that you can possibly see the bile duct in entirety using the EUS procedure. You focus the bile duct, make sure that there are no intervening vessels. This is the position of the scope. So you're actually looking at the hilums in the first part of duodenum, and you get your needle out. You can puncture the bile duct, and subsequently you can see the wire is, the contrast is going into the bile duct. The wire has been negotiated, and then you subsequently dilate your tract with a cystotome. So you need to dilate with 6 French cystotome to make sure that your metal stent goes through. And I'm inserting a fully covered metal stent, 6 centimeter here. One can even use a Lamb's Axios stent when the bile duct is adequately dilated. And one can see after putting a metal stent, I'm gradually putting a plastic stent through the same communication that I've created between the bile duct and the first part of duodenum to prevent stent migration. Anterograde biliary drainage, again, you're negotiating the guide wire. You see puncturing the left lobe of the liver, getting the guide wire across, getting a cystotome, identifying the site of communication between the bile duct, and putting a stent across the biliary communication, which is actually, bypasses the duodenum, which you would actually be needing when you're doing a usual ERCP. So talking about ERCP versus EUS, we know ERCP has been the standard of care for the past 2 decades. We get about 7 to 20% patients where in distal biliary malignancy, the duodenum is infiltrated. You cannot get to the ampulla. And in the series where we're talking about the success rates of ERCP, they have excluded patients who have a duodenal stenosis. That has inflated the rates of success of ERCP, which might actually be much, much lower if you're actually including those subset of patients. The more time you're giving with the ampulla, higher the risk of ERCP-related complications, including pancreatitis. And EUS gives you a single-stop solution. So you look at the bile duct, you take the tissue, you get the diagnosis. If you have a pathologist at site, he tells you it's a malignancy, major vessels are involved, you can go ahead with biliary drainage procedure at the same time. You can do a celiac plexus neurolysis at the same time. So it saves time, it saves resources, and it's immensely helpful. Now talking about data, where do we stand here? We had retrospective studies coming earlier, and now I'm going to be talking only about the randomized control trial and the meta-analysis, which are high-quality trials when we're comparing EUS with ERCP. This was a multi-center trial that came in American Journal of Gastroenterology. You see the duration of procedure is much shorter with the EUS-guided biliary drainage procedure. The adverse events are much lesser with the EUS-guided drainage. And if you look at the pancreatitis, there's practically no pancreatitis with EUS-guided drainage procedure. The reason for that is you're not playing with the ampulla. And that's where the pancreatic duct is located. That is a big, big advantage of EUS over ERCP, and including the reintervention rates, which are much, much lesser. This was a randomized controlled trial by the Shams group from Florida, and one can see that there has been actually no difference between the EUS and the ERCP in drainage of biliary ductal procedures. Now, this is again a randomized controlled trial, multi-center, that has just recently been published, and I'm going to just show the relevant points here. So these are patients who are potentially resectable. So we're moving from times when we thought it's only a palliative procedure to times when we know this is actually a therapeutic procedure in patients who have potentially resectable malignancies as well. The conclusions are EUS choledochordanostomy is not inferior to ERCP-guided metal stenting. It's a same-session therapy. You can use it in patients who are potentially resectable as well. So surgeons had no difference in their surgery. There was no difference in the rates of chemotherapy that both the groups received. And it's applicable to operators with limited experience because the median number of procedures of choledochordanostomy by the operators that were performed in the study were just 2. This is just the first study that says so. I'm just going to rush through the meta-analysis, which says, although there is no difference in technical and clinical success rates, the rates of reintervention are much lesser in US-guided drainage procedures. The reason is being you're not actually going through the malignancy, you're not going through the mass. So when you're bypassing the site of block, your stent patency rates are much, much higher. This is a systematic review and meta-analysis which says, if you look at the pancreatitis rates, much lesser with the EUS-guided biliary drainage procedure. So the data tells us some very clear indications. This is the way we are going forward. Technical, clinical success rates, so far we don't have any difference. However, if you include the patients with the blockage of duodenum, maybe the USBD would score much, much higher. Adverse effects are largely similar. However, the pancreatitis rates with EUS-guided biliary drainage are much lesser. The procedure duration with EUSBD is much shorter. The stent patency is much longer. The reintervention rates are lesser. However, you do need training before you actually advocate it. This is about EUS-guided drainage procedures versus PTBD. I'm sure my colleague would be talking about it. So far, the evidence says that as compared to the PTBD, EUS scores in terms of reintervention rates, the technical success rates, and the clinical success rates as well. This is the cost analysis. If we include the metal stent into analysis, we see that the 3 procedures are costing approximately the same in our Indian setup. If you look at the cost of the guide wire, the cost of the catheter, the needles, and the metal stent, there would be no significant difference. However, the rates of reintervention in PTBD, so far data says, are much, much higher. So what is the proposed algorithm for US-guided biliary drainage after successful ERCP? You identify a distal stricture. If you have a distal stricture, you do a choledochordanostomy, you do a hepatogastrostomy, or you can do an anterograde drainage. However, if the papilla is accessible, you can go for a rendezvous technique, which can be extrahepatic or transhepatic. This was from a multi-institutional consensus on how do we perform a US-guided biliary drainage. We're still looking for certain answers. Do we have US-guided drainage procedures up front? Are we ready for it yet? The data looks very, very promising. ERCP-guided rescue, that is a needle knife or a double guide wire technique versus US, we're still looking for answers. Endoscopic experience and head-to-head RCTs are limiting factors, and we're still looking at certain points. So ERCP has been the standard of care for decades. Biliary drainage, palliation, preoperative biliary drainage, US-guided drainage has an immense role. Post-surgical anatomy, possibly US-guided drainage, is a first-line modality. We know that the reintervention rates as compared to PTBD are much lesser. However, it should be carried out only at centers of experience, at tertiary care centers with good radiology and surgery backup. Expert operators are warranted. Can it replace the ERCP? I would say no, they're thriving together, but in certain situations, there's no point wasting time fiddling with the ampulla. Thank you.
Thank you, Dheeraj. We'll finish Dheeraj's talks and get back to you. Dr. Dheeraj?
I request the presence of the speaker, Dr. Dheeraj Tiwari, on stage to talk about current role of the interventional radiologist.
morning, everyone. I'm Dr. Dheeraj. I'll be speaking about current role of interventional radiology in distal biliary malignancies. As we all know about the etiologies in the clinical presentations, I'll be skipping these slides because the time is very short. So these are the areas where we work for the biliary malignancies, like percutaneous endobiliary biopsy, portal vein embolization. Of course, not very much common in the distal biliary, but if there is a coexisting disease in the liver segment, then we can go for embolization, percutaneous transhepatic drainage, role in operable lesions, and hepaticogastrostomies, cholecystostomies, and endobiliary RFA. So these are the factors as we all know, in the proximal malignancies, near the hilar, PTBD is preferred, and the distal occlusions, we prefer endoscopic drainages. This is a slide of portal vein embolization. It is usually done as a two-stage procedure. First, we do the biliary drainage, followed by the affected lobe embolization using glue, particles, or coils. I prefer glue, 15 to 20% glue, by puncturing the ipsilateral portal vein and embolizing the ipsilateral portal veins. That induces hypertrophy of the contralateral liver lobes to achieve satisfactory residual percentage of the liver parenchyma. Coming to PTBD, the most important part before doing any PTBD is planning. So we should assess the duct which has to be punctured. There are multiple, it depends upon the operator whether to puncture the right duct, left duct, anterior segmental, posterior segmental, but my preferred duct usually is the posterior segmental duct because it's usually not through the portal vein in ultrasound guidance. Second, the chances of going transpleural are very less in the posterior segmental duct. So these are the indications: cholangitis, failed ERCP, and reintervention. And of course in brachytherapy, administering brachytherapy. So this is a meta-analysis done by Zoe et al. They compared PTBD versus endoscopic drainages, and they revealed that there was better therapeutic success rate in the PTBD as compared to endoscopy, and the patient who underwent PTBD were 0.55 times less likely to have cholangitis as compared to the endoscopic biliary drainages. This is another study, another meta-analysis by Duan and Rizzo done in 2017 and 2020, which revealed that there was a lower risk of pancreatitis and cholangitis in PTBD as compared to EBD. However, the stent displacement or bleeding risks were more in percutaneous drainages. Coming to the role of intervention in the operable lesions, of course in the operation the surgeons prefer to not to cross the ampulla because that makes the patient susceptible to develop some infection. So PTBD external drain is considered the best option for that, and that limits cholangitis. At the same time, with the same access, it's very easy to perform a percutaneous punch biopsy, endobiliary punch biopsy. This is a study by Evan et al. Who evaluated the clinical benefits of PTBD for malignant biliary obstruction. And that suggested the median survival was 64 weeks in the patients who received chemotherapy following PTBD. And the best outcome was seen in the patients whose performance status was low, bilirubin was low, and the patient presented with high leukocyte count at the time of procedures. These are the mechanisms by which cholangitis usually develops: retrograde reflux, antegrade through the external drain, or hematogenous, or related to contrast. So, to study the patencies in the advanced malignancies, this is a study done by Yaroslav et al., which compared PTBD, endoscopic drainage, internal-external transpapillary drainage, and bilio-jejunal drain, in which they used a special type of internal-external drain which had holes in the common bile duct and in the jejunal segment. As my picture is showing, there are holes in the biliary segment as well in the jejunal segment, and the in-between segment is devoid of any holes. So that reduces the chances of reflux into the liver parenchyma. So they concluded that this is the Kaplan-Meier curve, which shows that the patients with internal external biliary jejunal drain had a higher survival rate as compared to rest of the modes of treatment. So they suggested that internal external bilio-jejunal drain is currently a cost-effective treatment option, particularly for the patient who have a shorter life expectancy. The biliary stenting, as we all know, can be done percutaneously or endoscopically. Percutaneous is a viable option when the ERCP fails, the patient is having a cholangitis, or especially in the surgical scenarios where different types of biliary and enteric anastomosis is done. So, what are the factors to consider the risk stratification? The high cell count, high CRP, low hemoglobin, and high bilirubin. These are the reliable predictors of complication and morbidity in the patients undergoing different procedures. Role of Bayer stent. Stents, as shown in most of the studies, have a higher patency as compared to the external or internal external drains. The superiority of SEMS over plastic ones is also confirmed in multiple RCTs and meta-analysis. The only challenge with the SEMS is the tumor ingrowth because of the cheese cutting effect or because of various other reasons. Role of covered stent. Covered stent, they usually have a PTFE covering, and the covered stent have shown satisfactory results in multiple RCTs. The challenge with the covered stent is covering of the cystic duct or covering of the pancreatic duct and stent migration. So this is a study done by Sato et al. In Japan, which concluded that the plastic stent, which had compared the plastic versus the metallic stents, and concluded that metallic stents have prolonged patency rates with greater flexibility and minimal foreshortening at the deployment. So stenting can be done as a primary stenting and the secondary stenting. Secondary stenting is usually done in the setup of cholangitis or when there is too much of bleeding inside the ducts. Otherwise, primary stenting should be preferred because that is more efficacious and safer, because the hospital stay for the patients is less, and it is cost effective also because it's done in a single stage. This is a multi-center RCT done by Sakai et al. For uncovered versus covered stent, which revealed that the stent occlusion was significantly higher in the Bayer stents as compared to the covered one, and the median patency of the covered stent group was superior, almost 1.5 times as compared to the Bayer stents. However, there was no significant difference was seen in the median survival. These are another randomized control trials which show different results. The one was done by Lee et al. So Lee et al. Revealed the patency of the Bayer stent was more. Their logic of explaining that was that the stent migration leads to kinking of the stents, that leads to frequent occlusion of the covered stent as compared to the Bayer. However, Tang et al. In 21 have concluded that the Bayer stents have higher dysfunctions as compared to the covered one. This is a study done and recently published in a Korean journal, which had compared the percutaneous biliary metallic stents in the presence of a duodenal stent. So they concluded that if the endobiliary stent, is placed beyond the duodenal stent rather than within it, then the patency rate of that biliary stent was longer. So compared to coming to the RFA, there is still some controversy whether it prolongs the patency or it improves the function of the Bayer stent. So studies have not given a very satisfying result. However, Mizandari and et al. They studied the complications and found that RFA did not add any additional complication when it was done in association with the SEMS. This is a meta-analysis which has included multiple RCTs and non-RCTs and included 420 patients. Pooled overall survival rate analysis favored RFA treatment with stent insertion. However, no significant difference was found in the duration of stent patency in the subgroup. So we are not doing it very frequently, and especially it is preferred in the malignancies which are very soft on touch, and we expect that there will be too much of cheese cutting effect and instant blockage of the Bayer stents. Coming to intraluminal brachytherapy, this is not our slide. I haven't done it. It is just picked up from the internet. And so here for doing intraluminal brachytherapy, usually biliary drainage is done, and then radioactive iodine seed catheter is placed through the bile duct or through the stent. So this is a meta-analysis done by Chen et al. In 2021, which states that the iodine 121 seeds extend the stent patency, and there was no significant difference in the complication rates. So I'll be showing a few cases. So this case was borrowed from Dr. Bajal in Medanta Medicity. So it was a case of small solid lesion in the head of the pancreas with suspicious malignancy. Endoscopy was done with intent to remove and exchange the stent. However, it failed because a stricture was found in the duodenum and there was a large ulcer. So furthermore, the patient went into DIC, two SDPs were transfused, however the platelets did not improve. So that was a factor because of which PTBD was not possible in the same patient. So this is a right hepatic vein access was taken through the internal jugular route, and this is you can see in the first image there is the tips cannula is placed in the IJV, and then the posterior sectoral duct was identified on ultrasound, and the puncture was made using the Roop's needle, puncture needle, and the puncture was made into the posterior duct, and the wire was crossed. So this is a very unique and a rare type of intervention which is done. Only 10-12 cases have been reported so far across the globe, and in this patient a 12 millimeter bare stent was placed across the occlusion. Coming to another case where 69 years old, diagnosed with pancreatic head carcinoma, locally advanced inoperable disease, underwent ERCP with plastic stenting. Then subsequently the stent got occluded. ERCP again was planned to remove in exchange, however ERCP failed. So the patient was sent to us, and with the presence, because the stent got embedded, so posterior duct puncture was done, and you can see using a snare the endoscopic drain was retrieved, and it was crossed, and subsequently a SEMS was placed. So we usually leave the external drain for at least 24 hours to increase the drainage and remove, to get it from the infection if at all it is there. This is another case with failed ERCP, obstructive jaundice CAGB with proximal, so with mid-duodenum and distal obstruction because of the malignancy. So very simple, as I told you, we prefer the posterior sectoral duct to avoid the complications related to transpleural puncture. So it was done, and the crossing rate, believe you me, is so good in PTBD that I don't recall even a single patient in which our crossing ever failed. Almost, I would say, whatever the data says, I agree, there is some 5% failure rate in crossing, but we have never seen that failure. This is another patient. This is an example of advanced disease in which not many options were there. Patient was very poor, so ultimately internal external drain was placed. Thank you.
Thank you. Please have a seat, Gaurav. Two questions to you, Gaurav. You mentioned about the EUS drainage of biliary tract. Situation one, the hepaticogastrostomy stent is migrating. How do you manage that? Two, you're doing an EUS biliary drainage. The guide wire is not able to negotiate. You have already punctured the left hepatic ductal system, and the guide wire is not able to negotiate the distal biliary malignancy. What do you do?
Okay, so starting with the first question, normally whenever hepatogastrostomy stents, usually there are certain modalities by which you ensure that it doesn't happen. It can still happen in some subset of patients, but the technique that I always use is an intra-scope deployment of stent. If you make sure that the stent is being deployed inside the scope, the probability of the stent migration is very, very less. Secondly, the second important thing is you need to leave at least 6-7 centimeters of stent inside the stomach. So when the length of the stent inside the stomach is more, the probability of migration again is less. But this can happen, I agree. In case this happens, the most important thing is never lose your guide wire. Your guide wire is your lifeline. So till I am sure that the stent has correctly been deployed, I would not remove my guide wire. In case it's not in place, you can go over the same guide wire, you can try and get the biopsy forceps to retrieve the stent, you can place another stent, which is like, we call it the bridging technique, another stent which is communicating from the previous stent to this stent as well, but these are rarely needed, if at all. Secondly, I'm sorry, I missed the second question.
You do a EUS puncture of the left ductal system, and the guide wire is not negotiating the distal malignancy.
So in these patients, my technique is always I go with a segment 3 puncture of the biliary system. The reason is, in case I'm talking about an anterograde drain, my guide wire doesn't go through, I know I can do a hepaticogastrostomy, which is not possible if I'm puncturing a segment 2 duct. So that is always a backup option. Whenever I'm doing an anterograde drainage, I have to be prepared that I might not be able to negotiate the guide wire. However, in my personal experience, if the guide wire doesn't go up front, still let the guide wire get coiled inside the bile duct, use a cystotome to dilate the tract, let the tract, the site of puncture be negotiated with a cystotome rather than a needle, which would prevent the needle sharing, and it's much, much simpler for the guide wire to be negotiated as well.
Is there a real risk for tumor seedling along the needle tract, IR, for PTBD?
Sorry, I didn't get your question.
Is there a real risk for tumor seedling along the needle tract? And can it compromise the outcome in a resectable case?
No. Usually the puncture is always done under ultrasound guidance, and we do not cross any malignancy. It's a direct...
So you are dilating the tumor and internalizing tumor seedling is possible.
Into the needle tract you are saying.
Yeah.
You are talking about distal malignancies, right? So in distal, so puncture will be done in segment 6 or right or left portal, left hepatic duct, segment duct. And then the crossing will be done. Tumor settling proximally is it's not possible. It's not possible. The wire exchanges and everything are done over a sheath. So the wire which might be touching the tumor will be pulled out within the sheath only. And about your case, if you are not able to cross it, would you like to give a PTBT and attempt to cross?
Of course. See, we don't never do any of these procedures without having you at our sides and having a surgical backup. So that's a disclaimer. Never do ever an US guided drainage procedure without having an interventional radiologist by your side.
Personally, we have been doing these procedures a lot, but I believe my interventional radiology department has helped us a lot, because the shorter distance is a great way to manipulate the guide wire. When you go through the US, puncture the left ductal system, and the wire doesn't negotiate the lower end, we are sometimes in a situation. But the PTBD has got this advantage of the many catheters which have got this, the biliary manipulatory catheters are available, and many guide wires can be tried. You can go up to 018, you can go up to the smallest guide wires possible. So there is it's a combined advantage of both, has to be tailor-made for the patient. You should discuss your options out with the interventional radiologist prior to just going through the gastroenterology angle of EUS biliary drainage alone. We should discuss with the interventional radiologist, have a good MRCP roadmap prior to embarking on any drainage procedure. That's what we feel.
How do you prevent the bile leak in your US biliary drainage? Have you seen anything? And what's the diameter of the balloon you use to dilate it?
How do I manage?
Bile leak. This is more for the US guided biliary drainage. And what's the balloon you use to dilate?
So my go-to strategy is usually a 6 French cystotome. So that is something that usually is very, very thin, and the possibility of bile leak is very, very minimal. Secondly, my entire staff is highly skilled and adept at knowing when to expedite the exchange strategies. So maximum chances of bile leak happen when taking a lot of time to exchange your accessories, especially when the cystotome is not there or the stent is not there. Otherwise, it's largely a safe procedure. The chances become much, much more if you're needing multiple punctures. You punctured a duct, you've dilated it, you could not do the procedure, you're puncturing another duct. Those kind of situations rarely arise.
Thank you, Gaurav and Dheeraj. That was wonderful. Thank you, chairpersons, for
So just one question. Please. Excuse me, just one question, please. So is there any scope of EUS guided drainage of a non-dilated biliary system?
I'm sorry, I couldn't hear the last part.
Is there any scope of EUS guided biliary drainage in a non-dilated biliary system?
In a non-dilated biliary system. See, usually when you say US guided biliary drainage, it includes US guided rendezvous procedures as well. That is something that we use extensively when we know we are not able to get an intrahepatic puncture.
usually in extrahepatic puncture, when I'm trying to puncture from the first part of duodenum, I do not need, in fact, I punctured a 4 millimeter bile duct as well. You're just puncturing the duct. If you saw the video that I showed, the bile duct was not massively dilated, but we could still manage to pass the guide wire through it. Intrahepatic puncture, yes, can be a challenge if the duct is not massively dilated.
I think we have to close it here. Thank you very much. Both of you have done a good job. And thank you, co-chairpersons.
Thank you,
Bye-bye.
doctors. We have a coffee break for 10 minutes till the next session. The next session will start at 10:50. Thank you. Welcome back. I request everyone to please come back and take your seats. The next session is about to start in a short while. I request everyone to please take your seats. Kindly come back inside. Welcome back to Light Update 2023. This is day 2. We are about to start the next session. It's a case-based discussion. I request the chairpersons, Dr. P.N. Rao, Dr. Abraham Kochi, Dr. Shanid A., Dr. Jijo John, and Dr. Arun Kumar M.L. to please be on stage. I also invite the moderator, Dr. Arun Valsan, and the panelists, Dr. J.C. Garcia Pagan, Dr. Sanjay S. Bajal, Dr. Amar Mukund, Dr. Uday Sakaria, and Dr. Syriac Abby Phillips.
Should we wait for the attendees to join?
No, doctor, we can start the session.
Good morning, everyone. Okay, so we'll have a case-based discussion on tips. So I have an esteemed, expert panelist here with Dr. Carlos Garcia Pagan, Dr. Bajal, Amar Mukund, Dr. Uday, and Abby. So since we have a lot of trainees here, I thought I would give a brief overview of tips, and then we can proceed ahead with the case. So this would be our key objective of the panel discussion. So we would be dealing with tips in refractory ascites. So in cirrhosis, there is increased hepatic resistance, which has a mechanical and a dynamic component, and also there is increased portal inflow, thereby leading to angiogenesis, increased pancreatic vasodilatation, then central arterial underfilling, thereby activating a cascade of events like an activation of the renin-angiotensin-aldosterone system, ultimately leading to the formation of ascites, sodium retention, eventually leading to refractory ascites, hepatorenal syndrome, etc. So TIPS basically bypasses this, and out of the available therapies of diuretics, large volume paracentesis, and TIPS, TIPS is perhaps the only physiological way of controlling ascites. So it reduces portal pressure and thereby reducing the load on the lymphatics to filter out the fluid. So it is seen that the urinary sodium excretion increases and the serum creatinine decreases within days of putting a stent, and the plasma renin activity, plasma aldosterone concentration, and NORAD is normalized after placement of TIPS. And TIPS also has immunological and has a positive impact on nutritional status as well. So here is the case. So we have a 51-year-old gentleman
who's a diabetic for the last 11 years, has systemic hypertension, both are well controlled, or probably the cirrhotic cures the hypertension. He's a teetotaler. His index event was in 2017. His prior decompensations were ascites, upper GI bleed, and one episode of hepatic encephalopathy during that episode of upper GI bleed. So he has a recent OGD. His recent OGD was in December, which showed grade 2 varices and a gave without ooze and mild portal hypertensive gastropathy. Imaging done did not reveal any arterial phase enhancing lesion, and his portal vein and HV are patent, but he has gross ascites. And the issue is that since Jan of 23, he is needing a large volume paracentesis every 5 days despite adequate salt restriction, and he also has intractable muscle cramps. His urine sodium is 21, and he is not losing further weight. So his current status is a CTP of 10 and a MELD sodium of 19. He's not very keen on liver transplant as his daughter's marriage has been planned. So I'll go to Dr. Uday. So in real world, as clinician, we find that most of our patients do not tolerate the diuretic doses prescribed for defining refractory ascites as per EASL or the ASLD criteria. So how do you, or when do you call a person refractory in your practice?
Thank you. I prefer to use the term intractable because intractable is what is more seen in our patients. They are more sarcopenic, so we can never reach the ideal dose of diuretics as is recommended in the West. So most of them end up needing taps much more frequently without reaching the adequate dose of diuretics. So I would say this is definitely refractory or...
Get the opinion of Professor Carlos here. So what is, in your practice at the clinic, do you see your patients tolerating this large amount of diuretics? One, and that'd be the first question. And the second would be, is there any functional or physiological difference in patients who are diuretic intractable and diuretic refractory?
Well, yeah. Actually, probably the definition of refractory ascites many times is achieved because you cannot get the 400 milligrams spironolactone and the 160 milligrams of furosemide because the patient develop renal failure or cramps or hepatic encephalopathy. But we almost try to get it, but actually, usually it's difficult to get it, and then this is one of the definition of refractory ascites. And most of the cases, I think that the problem is not response to this high dose, but the impossibility to achieve that because in side effects. And regarding to your second question, actually, I don't think that nobody has studied pathophysiological differences in these two types as far as I know. But probably what we know is usually refractory ascites because of intolerance to diuretics usually respond better. Usually because probably it's a fact of complication to tips that the real refractory ascites. But this, as far as I know, there are not very good studies, although probably, and I'm not sure if you are going to discuss that during the next part, I think that probably what is more important now is recurrent ascites. That is, I would say that is a step before the real refractory, and probably you are going to mention that, but probably recurrent ascites is what is more important.
We'll come to that question. So, Dr. Abbey, what do you think in this setting, what would be your plan of management for such a patient who's kind of refractory ascites? He's not having a transplant option currently.
So in this particular situation, I mean, as per the standard definitions, he does require an intervention in the next step. But there are certain groups who approach this differently. For example, in Japan, they do add low dose of tolvaptan to improve response to diuretics. And there are multiple centers in Asian countries, especially in India, where they also add midodrine to improve response to diuretics. So I'm not sure if that was tried in this patient, but as per standard guidelines, we are looking at two things. Because he does not have an option for a transplant at the moment and he's not decisive on that, the next step is to, one is to improve his quality of life, and the second is to give him a transplant-free survival. And for that, I would definitely think of a transjugular intrahepatic portosystemic shunting as a next option.
Okay, so we can try midodrine, we can try tolvaptan. These are largely anecdotal, but centers are using that. So, Dr. Uday, do you feel currently he's a candidate for TIPS?
The short answer is yes, but if I think a little more, it's a bit dicey. He's borderline, so his likelihood of having complications is a bit higher. But overall, if I'm asked, the answer is yes.
Okay, so refractory ascites, there is, the TIPS lowers the elevated sinusoidal pressure that contributes to the formation of ascites, and there is increased effective arterial blood volume, which will cause desensitization of the upregulated RAS and causes increased natriuresis. And it's an attractive option in patients who are on wait list or who have significant transplant morbidity, and it improves nutrition, and also probably recent studies show that it can improve survival. So there have been multiple studies on TIPS, and it is proven that TIPS is an effective mode of controlling ascites. And this is a summary slide of the effectiveness of TIPS in refractory ascites. But as you can see, and as Professor Carlos mentioned, the problem is the heterogeneous group of patients. So when they defined refractory ascites, it has been a very heterogeneous group. Some people have included recurrent ascites, some people have included what is known as recidivant ascites, and diuretic intractable ascites and diuretic refractory ascites are all part of this. We have not defined them separately. So that may, cause problems in interpretation of the studies. But there are two studies which had favored large volume paracentesis, and most of the others favor TIPS. And mind you, these studies were done where most of these studies were done when the bare metal stents were in vogue, and we did not have the PTFE stents. So this question I'll pose to Professor Carlos, and then I'll get the opinion of others. So how long do you wait once a patient has hit the roadblock, has become refractory, diuretic intractable or diuretic refractory? So how long, what is your waiting period? Do you go upfront with an option of TIPS? Or, is there a timeline that you see that, oh, this patient is not responding within this timeline, then I would probably suggest TIPS?
I think that the timing, the earliest is the better, and probably the only possibility to wait a little bit if you think that there is something in the liver disease that can improve. If the patient comes and you think with an alcohol-related liver disorder, and that you think that it may become abstinent, and maybe you can wait some weeks because you may think the possibility of a marked improvement, maybe it's the only possibility to wait, because if not, I will not wait, and I think that we should go for a TIPS as soon as possible. As I mentioned before, probably we need to go to an earlier treatment of this patient, because if not, the renal deteriorates, everything deteriorates, the heart deteriorates, and then these patients, the larger time you wait, more possibility to develop heart failure, renal failure, or even a spontaneous SVP, and maybe die because of this very severe complication. Okay. Then the earliest the better.
Okay, so Dr. Abhi and Dr. Uday, do you agree with this approach of early, once a patient hits a roadblock, you go in faster with the option of TIPS when there is no transplant option?
For all clinical practical purposes, I think when you put the patient at the center of everything, I think an early TIPS definitely works, even though we don't have good data to show that before a patient becomes refractory. That is, for example, somebody has recurrent ascites, not classically of refractory definition. Even they do better if you intervene earlier. But we are waiting for that better data to come up. But we do definitely have data on that with respect to variceal bleeding. So I think earlier, definitely the better, instead of wasting precious time for more complications to develop.
Okay. Dr. Uday, please.
No, I agree entirely. This person's quality of life is not good, and he doesn't seem to have a definitive option. So I think in this situation, we should go with TIPS, but he should be aware that there are risk of TIPS complications in him because of the points already mentioned.
So we counsel the patient adequately about the risks involved, and then we go ahead with tips. So these are some of the studies. Most of them have been done in the bare metal era, where lower LVP frequency of less than 6 LVPs, a serum creatinine less than 2.8, and ABIPS, and not wait for organ failures or infections to set in. So next, again, I'll go back to Abhi. Do you use any particular MELD sodium cutoff where we say that, no, I won't do tips, or at this MELD, this is too early for tips? So do you have any, MELD cutoff either that you'd use in your practice?
The short answer to this is no, because I mean, in our practice we don't, and even if you look at the data from published literature, initially there were a lot of studies that showed that should not do tips in refractory ascites patients who have a MELD more than 15 or sometimes even MELD more than 13, earlier studies. But now, recent studies have shown that even up to MELD of 24, you can safely choose to do tips because that improves transplant-free survival and also it improves ascites control. So at the moment, I don't think there is any actual consensus on a MELD cutoff where they specifically say that don't do tips for these patients in refractory ascites. It is a definitely case-by-case basis because it's not just the MELD. We know that even poor outcomes are dictated by other events such as presence of sepsis in the previous 3 to 6 months, which can alter the natural history post-tips in such patients. So MELD per se, no consensus, but even up to 24, we can definitely consider doing tips.
Okay. Professor Carlos, your opinion. So do you follow any MELD cutoff at your clinic where you say that patient is a no-go?
No, the answer, as Philip said, the quick answer is no. I think that the decision needs to be taken in a case-by-case basis. Of course, it's difficult. Everybody agrees that the mortality is much higher in a patient with a MEL of 20 than in a patient with a MEL of 12. But we need also to take into consideration what will be the mortality of this patient without tips or without doing nothing, because of course the mortality is higher. But what will happen without tips? What would be the mortality? And sometimes, and in the very nice study of the individual patient data meta-analysis done by Salerno, he clearly showed that he was able to stratify these patients in 3 risk categories, but in each one of those, not receiving a TIPS was even worse. Of course, if we had a patient with a MEL of 25, we need to be very convinced to do a TIPS in this patient and to discuss very strictly what to do, what are the options, but not a real cutoff that we say, okay, with this cutoff, forget it. Don't discuss the patient. No, I think that the patients need to be discussed in that situation case-by-case basis. And maybe you will discuss that in the next part of the talk, but I think that now we have some refinements in the TIPS procedure that may be applied to these patients. We shouldn't forget that although, as I mentioned before, we will do TIPS as early as possible. It's not as emergent as in a patient with a rescue TIPS for bleeding. And then you have time, and maybe you can play a little bit with the diameter of the stent to see what happens to this patient, and then you have at least weeks. I would say you have weeks, and not that not happens in a rescue TIPS for bleeding.
Okay, thank you. So we are currently going for higher and higher MELD, and probably one of the studies, as I showed here, showed a MELD of more than 26 has got a mortality of 83. Probably that could define futility currently. Next, Dr. Amar, what are the pre-procedure tests that you do to assess candidacy for TIPS? And second part of the question is, do you routinely use antibiotic prophylaxis pre-TIPS? If yes, what is the chosen regimen?
Yeah, so thank you so much. So procedure evaluation definitely would start with imaging if we plan it for technical success. So imaging is definitely there, and imaging would include CT and ultrasound, provided if KFT is good and CT can be done, but many times CT may not be possible, so we suffice with ultrasound. We need to see the anatomy. There is no dysmorphic liver and the tips is feasible, and if not feasible, whether it is feasible from the middle hepatic vein to the left branch of portal vein. So this is how. Apart from it, we need to have the lab parameters. Definitely, we have had a lot of discussion about MELD and CTP. Still, it is better to stratify the patient and counsel the patient accordingly, case-to-case basis. We need to have a cardiac evaluation, look for any cardiac failure, because that would be the most important thing. Apart from it, NT-proBNP is a very good marker which should be done and should be seen. If very high, probably TIPS results are not going to be good, because there are three things which are in continuation: superior mesenteric vein, portal vein, liver parenchyma, and then the heart. If heart is not working well, whatever you transfer to the heart, probably TIPS outcome is not going to be good. So liver, cardiac function and NT-proBNP is probably very, very important. So these are the important things. Apart from it, Indian scenario, age is one important factor which needs to be taken into account. Higher age, poor outcome. So age and
we'll come to that. I think you can answer the second part of the question.
Normally we don't use, because if a patient had a SBP in past, then probably he is in a protocol antibiotic that has to be continued. But otherwise, it is just one shot of antibiotic just prior to TIPS and followed by the antibiotic as per the institutional protocol.
Okay, so there's no, again, consensus here, and the risk of endotipsitis is to the tune of 1.3%. And it has been refined as our radiological skills improve and our antibiotic stewardship improves. So to Dr. Bejal, does this patient had an episode of HE when he had the index bleed? So does that make him a poor overall candidate for TIPS? And second related question would be, do you can you elaborate on any risk scores that can predict post-TIPS hepatic encephalopathy?
So I think, like was discussed, this patient is running out of great options other than a TIPS, and he's moving towards TIPS in a very logical manner. But at the end of it, we also know that any kind of encephalopathy, even if it is of the mildest nature, at that point, when the TIPS is done, predisposes him to running into problems of severer levels of encephalopathy post-TIPS. The past episode of HE, since it was associated specifically with an index bleed, and otherwise he was never spontaneously in encephalopathy, makes me feel more comfortable that this patient would not run into occurs as well. Sarcopenia is one of them, like Amar just mentioned, age is one of them. I think I saw a couple of papers. Somebody, in fact, mentioned a very young age cutoff of 50 years and said more than 50 high risk, but there's some which talk about 70 years as a possible stratification below and above. And then, like you've listed out on the other points, that if you have sarcopenia, hyponatremia, all of these would definitely probably predict a not so good outcome.
Okay, so the take-home message here is that a single episode of precipitated HE, either due to constipation or due to bleed, need not necessarily, preclude the patient from TIPS. And HE in the setting of HYATT is also not a contraindication for TIPS. So one question, this would probably be a googly, I had not put it on the slide, but I can't refrain from asking both Dr. Amar and Dr. Bejal, would the size of liver predict the technical difficulty? If you have a more shrunken liver, would that mean that there'll be more challenging TIPS insertion vis-a-vis a larger liver? This is a clinician's doubt.
So my answer is also going to be in that manner, that difficulty is based on the operator's skill, isn't it? It can't be sort of summarily said that this is difficult and this is less difficult.
Yeah.
For something, it might be difficult for me, but for Amar, it might be a piece of cake. But at the end of it, what I would say is that I think enough skill is now there that it's very odd that for liver morphology, one would come around to say that a TIPS is not doable.
Okay.
What do you say, Amar?
Dr. Amar, you want to add something?
So I'll just quickly answer the thing. Like in most of the patient who have decompensated has a large ascites, liver will always appear small and small. And as soon the ascites is mobilized, suddenly you'll find the liver has increased.
Yeah.
So actually the intra-abdominal pressure plays a huge role in making the liver constrict. So that is one thing. But yes, in all ascites, liver would be small. We do it day in and day out, and almost all the operators across India are doing it day in and day out. So shouldn't be an issue unless until there is a atrophy of a segment. So that has to be taken into.
Okay. So I go back to Dr. Uday. So do you recommend any antiplatelet or anticoagulation post-tips? There's a fear of losing and getting the tips thrombosed. So what's your practice?
So I think the answer would have been easy if this was Budd-Chiari, in which case the answer is yes. But in a non-Budd-Chiari situation, I think it's a case-to-case basis. The things we are worried about is initially we want the stent patent. There was endothelial injury, the type of stent used, maybe even the company. So I would say overall, on a case-to-case basis, we should give short-term anticoagulation, at least till we are sure that the patient is doing well. But which anticoagulation? I would prefer not an antiplatelet agent because it's a venous thing, but which agent, and because of the sarcopenia, how do you titrate the INR or use other techniques is still debatable. So I'm actually keen to see what others have to say.
A quick comment from Abby, and then I'll go to Professor Carlos. So do you use anticoagulation or antiplatelet post-tips?
So in our practice, we don't, except in cases of Budd-Chiari. But routinely, we don't anticoagulate any of our patients post-tips. But there is a lot of data that shows that patients with MASLD, metabolic associated steatotic liver disease, they are more prothrombotic.
Yeah.
So we don't have much data on tips in them. But
our index patient is a NASH cirrhosis.
Yeah.
So
I'm not sure if there is any consensus on that, but we don't usually.
Professor Carlos, for a quick comment, do you recommend anticoagulation or antiplatelet?
No.
Okay.
If there is no portal vein thrombosis, that is not completely solved after TIPS, sometimes we keep it for a short period of time until the TIPS, the increasing blood flow, destroys or makes the thrombus disappear, but not usually. We are using the cover stents, and after the use of cover stents, if the TIPS thrombose is usually a mechanical issue and not related with hypercoagulation.
Okay. Going back to Dr. Bajal, so what are the latest developments or modifications in TIPS, and do you have a personal preference for a particular kind of stent or for T, or do you prefer a particular kind of stent, and what is your usual practice? Do you go at lower diameter and then probably look at increasing the diameter, or what's your practice?
Right. So I think the first question is answered with the development of a controlled expansion stent, where you have the option of deploying a stent at a lesser diameter and then expanding it further basis your clinical outcome of the first procedure. And that makes it the most exciting of the devices and the developments in TIPS. We don't have it yet in India, but we look forward to whenever it comes in. As regards my the second question, which is the kind of stent I prefer, we definitely like a stent which has a bare part and a covered part. We want a stent to have a property of a lesser axial force, but a good radial force, so that it doesn't tend to straighten out and does not start sort of embedding into the walls of the portal veins. And hence, we prefer what at the moment is a dedicated tip stent with a PTFE coating in the proximal part. The PTFE coating should actually ideally be of 2. Regarding the last one, we've been using a 10 millimeter standard tip stent so far.
Okay. Again, going back to Abby, these patients are refractory. So do you probably, as a part of management of a refractory ascites, we discontinue beta blockers. But after TIPS, the patient's beta blocker is there. Do you still continue beta blocker? What is the opinion?
There is no consensus on this again, this particular point, but there is some emerging data. This was presented at ACG last year, where they showed that continuation of beta blockers post-TIPS can increase the risk of hepatic encephalopathy. But we need more data on this. And some experts advise that if you're using a smaller diameter stent, for example 8 mm stent, to reduce chances of hepatic encephalopathy, then continuation of a beta blocker would actually improve the patency of TIPS. But even this is not proven yet. But in our practice, we stop beta blockers post-TIPS, and we continue other antihypertensive, systemic hypertensive, antihypertensive agents if patients are already on dose.
So back to the case. So this patient had a good control of ascites, needing only one large volume paracentis post the procedure, and he has been largely dry. On day 25 post-TIPS, he had increased sleepiness, reported to the emergency services, no constipation or any precipitant cause of hepatic encephalopathy, and his arterial ammonia was 179. So how will you proceed now? We have 2 minutes to go, so I request the panelists to make quick answers.
I think we have already looked at some of the precipitants. In this case, I would assume that the patient was dry, so maybe I would fill him up and see. Now after that, try medical management, lactulose, rifaximin, etc. And if all that fails, then I don't know whether we need to consider stent closure. But going back, this is exactly the worry in this situation. And I wanted to ask Dr. Baijal, maybe in this patient we would have gone with an 8 mm stent and then expanded it over time.
That's a question for him in the next part. I think he will take it from there. So this is for both the radiologist and the panel. So do you routinely do a redo shunt size reduction in refractory HE post-TIPS? Or like how many episodes of HE would make you want to intervene? And what are the IR strategies in this setting that you have? Because after giving nutrition, probably withholding diuretic or a beta blocker, there is not much left in the medical armamentarium. So what do you resort to?
So like you exactly said, if you've run out of whatever you could do, like which you just enumerated, we would definitely look towards shunt reduction. Upfront, we are not occluding our tips on the first shot, but we are certainly reducing them. The important thing to I'll give a short message is, diameter does not reflect blood volume. So to really half the blood volume through a TIPS, you should actually reduce diameter by nearly 60 to 70%. So when you're sizing your stents, be aware of that fact. This is for the IRs to optimally decide how much they be.
Just going back to the question, normally in our practice for last 6 years, we have been using only 8 mm stent for ascites and 10 mm stent. As far as encephalopathy is concerned, then we wait for it to be refractory in nature, where a patient is coming time and again, and then only we go for reduction.
Okay. With the permission of the chair, could I finish off the last question? I think we are short of time.
I don't know, we are short of time. Maybe we should stop.
So I'll just get this 30-second answer from Abhi, and then we'll finish. So can you give a word about the prediction of survival?
This again, in short, we don't have actual good scoring systems to predict this, even though the Freiberg score index is what is currently latest published. But even then, this is not validated externally. So I think again, this goes case by case, and there are a lot of factors involved in predicting a poor outcome post-TIPS, and I think we wait for better data to generalize this in our practice.
Okay. One last word about the other novel biomarkers which are there for TIPS survival. And lastly, to sum it up, earlier studies said that TIPS and LVP are equal in terms of survival, but now recent studies say that there is improved OLT-free survival and TIPS is more effective in controlling ascites up to the tune of 70 to 23%. And there is around 7 times reduction in the TENS ascites. And the flip side being 26 to 40% may develop post-TIPS HE. And using a small diameter stent may decrease HE, and MELD around 12 was the ideal candidate. Higher MELD are being taken up increasingly. Patient selection is packed, and pre-TIPS bilirubin infections, sodium and age are important predictors. Thank you all panelists, and thank you chair. We can take questions if any as.
No, In the interest of time, I think we'll not take questions. Thank you. Thank you.
Thank you. Thank you, everyone.
Thank you, doctors. I request the presence of the next speaker, Dr. Salil Karkhanis, to talk about expanding role of TIPS. Chairs to remain, please. The chairpersons to remain, please. The chairpersons to remain, please. Thank you, doctors.
Good morning to everyone. First of all, a big thank you to radiologists in Birmingham, and I'm talking on the expanding transfusions. Say, for a diagnosis so niche, the evidence out there is not that much. So whatever you do have, it goes to confirm that the role of TIPS in managing this condition is purely in the refractory setting, once you've exhausted all medical option. And in that setting, TIPS has been shown to reduce the need for recurrent transfusions, but that's about it. At the moment, we've got nothing else to go beyond that. Moving on to the topic which was quite extensively discussed in the case-based discussion, refractory or recurrent ascites, we already defined that. If you ignore the previous RCTs that focused on the older studies, which had talked about bare metal stents, so we can just gloss over all that. If you come to the more recent RCTs that at least with up-to-date technology, you have an improved transplant-free survival with TIPS versus large volume paracentesis. However, we know about the increased HE risk, and that was seen in both these studies that I've highlighted there. We still don't know what the optimum portal pressure gradient is. Again, if we had to use maintaining the patency as well as the overall survival. Needless to say, if you don't have a already has sequelae of portal hypertension, that's when you would proceed to any shunting procedures with the TIPS or DIPS. This is a study from Amar and team in 2018, and that went quite far as to highlight the role of recanalization versus DIPS. And essentially in the 136 patients, one of the take-home messages from the study was that where possible, try and recanalize the hepatic vein because it's more physiological, less chances of giving hepatic encephalopathy, and it maintains liver synthetic function. Needless to say, if you have to do a shunt, you have to do a shunt. And the studies in the table up there go on to highlight that whatever's out there has been published quite heterogeneously, but whatever outcome criteria have been used have always shown good results if you have selected your patients carefully. At the other end of the spectrum in Budd-Chiari syndrome, if you have the Budd-Chiari specific scores of Rotterdam index or BCS TIPS score, if they go above 7 or above class 3, you may as well consider early transplant rather than putting them through a shunt and having poor prognosis. Moving on to chronic portal vein thrombosis, obviously I'll leave the acute thrombosis for a later talk. I'll talk about chronic portal vein thrombosis with or without cirrhosis. And essentially Thornburg et al., the first paper is what paved the way for doing TIPS pre-transplant to optimize for surgery, and that's become a thing now. The second paper essentially is a randomized controlled trial comparing covered TIPS with band ligation for thrombosis in cirrhotic patients. Once again, TIPS scored with reduced rebleeding rates compared to band ligation. So definitely is a role over there. If you look at systemic reviews that have been published, you have a variable technical success rate, but by and large, good success rate. If you look at the lower systemic success rate, that's probably highlighted by the difficulty in doing a TIPS in a chronic thrombosed portal vein. If you had heard Dr. Begel's talk before yesterday, you would have taken that message from there. But once you get the TIPS in and you follow coagulation as would be required or anything else, you get good 12-month patency, and that seemed to be the overarching take-home message from the systems. Pre-surgical TIPS. Now, this is a bit of a controversial topic. Now, using complication rate when you have patients with cirrhosis who need to undergo extrahepatic surgery, primarily bowel surgery. And from the back of that, our institute as well as other institutes, we get asked to do TIPS preemptively, not preemptive, sorry, prophylactically. That's a bit surgically or prophylactically. If you look at the published data and the systematic review that is there by Lahat et al., there were 19 studies included in that, and the technical success was 100%. Well, it would be. Why wouldn't it? Because you don't, so it should be 100%. And 100% proceeded to surgery in the systematic review, which is good, which means that the
Consider this patient was extremely severe, or child B of 7, 8, and 9 points, plus active bleeding at the time of the diagnostic endoscopy. And listen to that, despite this patient were already receiving vasoactive agents such as somatostatin or terlipressin. And the first important fact here was to observe that the control group, the standard of care group, has really a very high mortality, and that we have done a very good selection. And what was very important from this study is to show that those patients receiving preemptive tips within 72 hours, most of them in the initial 24 hours, improve the control of bleeding, prevent failure of bleeding, but also, more importantly, were able to improve survival in comparison to those that were submitted to a standard of care. And after this study, several other studies showed a robust effect of preemptive tips, improving the control of bleeding and reducing rebleeding and ascites without significantly increasing the incidence of hepatic encephalopathy in this special severe cohort of patients. But however, the improvement in survival, although in most studies was quite clear for child C patients, was not so clear for patients with child B plus active bleeding, and they make us to do an individual patient data meta-analysis, including the studies that were published until that time, some of them randomized clinical trials, some of them observational controlled studies, that we were able to collect more than 1,000 patients with high-risk criteria as defined before. Of those, then, we were able, in this individual patient data meta-analysis, to confirm the improvement in survival and the fact that there was a reduction in bleeding, preventing rebleeding, and ascites without increasing hepatic encephalopathy. And this effect was observed very clearly in child C patients, was because it was not so clear in child B patients. In other studies, we analyzed in child B, and again, in child B, there was also a benefit in survival. But we wanted to analyze more carefully child B because, of course, the benefit of survival was less than the one that we observed in child C. And we were able to identify in this last cohort of patients that actually the effect in survival was only observed in child B plus active bleeding more than 7, that is, child B of 8 and 9, but not in those child B patients that are with better liver function, that is child B. But more recently, there appeared another study, randomized clinical trial, the Dunn study from UK, that we decided to do anew, that is now accepted and it's now in PubMed, doing a new randomized clinical individual patient data meta-analysis, including this study, and doing the analysis separating the randomized clinical trials and the observational studies. And as you can see here, the benefit in survival was observed either in the randomized clinical trials, in the observational studies, of course, when we plot together all the available studies in this setting. Then, however, one of the questions that I got when I present the results, okay, but child C patients are very sick. Are you really sure that there is a benefit on child C? And of course, as I mentioned before in the case clinic, we can, when we look 310 patients that have received a preemptive tips, the survival was different if the preemptive tip was done in a child C or in a child B patient, and that was a statistical analysis that we did, finding these 3 parameters that allow us to stratify our tips, preemptive tips patients in 3 different categories. And as you can see here, there was some patients that were received preemptive tips that had an excellent, what we call low risk in high risk, and also others that have a worse survival than the other ones. But when you look what happened to the same patient if instead of doing a preemptive tips, you do the standard of care, this is the next slide. Look at here. In whatever the stratification risk the patient belongs, the preemptive tips always was improving survival in relation to the same category of patients that receive in preemptive tips improve 1-year survival in all risk groups depending on the stratification we did. One other question is, of course, okay, but doing a preemptive tips in 72 hours, that I think that is the best selection that we can do for our very difficult. Can we extend the time frame? Well, what is clear is that if we look those patients that do not receive a tips, the mortality accumulates in the first weeks, in the first days after arriving to the hospital. We are talking of child C and child B of 8 and 9. No, we are not talking about child A or child B of 7. And as you can see here, the early we do something here, the more probability that we have to prevent this mortality. If we do a tips here after 50 days, after 28 days, probably there is no mortality in the standard of care group, and then really the outcome of this mortality at 1 year of 30%, that is a mortality that is very similar to the one that we observe in child B of 8 and 9 with active bleeding. That is a population in whom preemptive tips has shown to improve survival, and we think that maybe this is a place, a scenario, there is a room to perform a randomized clinical trial in this specific population. And thank you.
Thank you, Dr. Garcia. I have one question. This is you are risk stratifying without catheterizing the patient, without wedge pressure. Is that right?
When we designed the study, we thought able to be done in different hospitals,
correct,
in different settings, and that's why the reason to select a clinical criteria in every hospital, in every center, and when the endoscopy is performed about the activity. But activity means oozing overabarics or jet overabarics, despite the patient is already receiving vasoactive agents, wherever you are.
Early tips even for in a child face cirrhosis, what I from your last slide. So since the survival is increasing, definitely the chances of hepatic encephalopathy in such patients would also increase. So how to tackle such situations where patients is having a higher survival but getting encephalopathy, because chances would be more. So this is the first question. Second question, since we are diverting...
Wait for the second.
I'm not sure if I can understand very well.
Neither can I hear clearly. Can you come closer and just...
Because there is a
while you're coming, this is really a game changer. I know it's taken up more than the time which is required, but this is a game changer.
Well, regarding the first problem is that the fact that if you do it earlier, you have more hepatic encephalopathy. Not true. The individual patient data meta-analysis clearly show another group. You cannot compare with all the cirrhotics. If you compare the hepatic encephalopathy in a child C receiving a TIPS with a child A treated with standard of care, of course, the hepatic encephalopathy risk is much higher in your child C. But if you compare with a child C not receiving TIPS, rebleeding is higher. We all know that rebleeding is a cause of hepatic encephalopathy. The probability of developing ascites during the follow-up is much higher. The need of diuretics is much higher. All of those are causes of developing hepatic encephalopathy. The risk of developing SBP, of coming to the hospital are higher. And then the increased risk of hepatic encephalopathy promoted by TIPS, that of course, I agree with you, is counterbalanced. Risk of SBP, higher risk of rebleeding, higher risks, and then sarcopenia, developing sarcopenia during follow-up. We need to think that we are talking about all cirrhotic patients, not a child A, that as we mentioned, the risk is very low. And then the risk is probably counterbalanced. The risk of hepatic because of TIPS is counterbalanced because of the risk of rebleeding, ascites, need of diuretics, sarcopenia, and so on.
Thank you.
And the second question?
Yeah. Oh, shall we stop? Maybe we can discuss later because I think we are running out of time. This requires a lot of discussion. You have really put forward something which is a game changer. You are saying deal with a bleeder like cardiologists deal with a myocardial infarction, and neurologists deal with a cerebral infarct, which has never been. This is a game changer.
And we try to convince our administration that where we have the code of heart attack code, that they be managed and transferred very quickly, and also the ictus code for the brain, but we don't have this kind of code, and probably we need it.
Yeah, we need a lot of discussion, and I'm sure we need to take it forward. Thank you very much.
Thank you, doctors. Thank you. Thank you for that amazing session. We move on to the next session, which is about splanchnic venous thrombosis. And I invite the chairpersons, Dr. Sunil Kumar K, Dr. Tom Kurian, Dr. Vaibhav Pratap. I also request the presence of the speaker, Dr. Amar Mukund, to talk about acute portomesenteric venous thrombosis. How do I manage?
So after a very thought-provoking talk by Dr. Pagan, so again moving to another direction, acute portomesenteric venous thrombosis, my way. Anyway, it's not actually my way, it will be along with the data, so nothing to disclose. Just quickly, portal vein thrombosis may be benign or malignant. Again, it may be acute or chronic, and it may be in a setting of chronic liver disease or in a normal liver. So portal vein thrombosis is a common complication which we see in cirrhosis. However, it is also seen in absence of liver disease, and the presentations may be acute or chronic, where acute may present as abdominal pain, diarrhea, bleeding, distension, nausea, so there are various presentations, whereas chronic may remain silent for pretty long and may present with splenomegaly, low pancytopenia, and so on. So there are various etiology, mostly associated with local factors, but systemic factors also account for 30% of the cases. Won't go into the detail. And diagnosis is mostly made on ultrasound, and it is the investigation of choice. Nicely demonstrates solid and hyperechoic material into the distended portal vein, but you need CT or MRI to actually see the extent of thrombus and then stratify your way of treating it. Similarly, CT will also give you the status of the bowel.
Which is what most of us follow in this part of the lateral, which is amendable to recanalization, and the aim is to restore. Decades ago, it's not possible in symptomatic patients. Shunt is the way to go. So we should suspect it, and our follow-up includes anticoagulation. And while you may need reintervention, them still tend to. Yeah, I'll stop with that. Thank you.
Thanks for the excellent presentation. The topic is open for discussion.
I have a question. You said if you...
We pass a wire, we catch this wire, snare it, and then continue stenting. All these options are not working, then only we go for transjugular intrahepatic portosystemic shunt. So on your left side, you can see it's a regular dips, whereas on your right side, you see a dips. In this dips case, there is no hepatic vein where we can get inside. So we go to the region of ostium, or we can even come little caudally, couple of centimeters below, if the hepatic parenchyma is grossly swollen, so that the length of the stent can be reduced. This is how we position. We use ultrasound and fluoroscopy alternatively. And the technical and medium-term clinical outcomes we have explained in a recent article. And this is how we perform. We can see the IVC as well as the right branch of portal vein. And this is how we aim from the IVC to the portal vein. And once we get into the portal vein, we pass the wire inside, and rest of the steps are same as regular tips. Only thing is, here we see the tract is quite long. If you count this number of dots, it's nearly 10 centimeters. We angioplasty it. One stent is not adequate. We place a second stent sometimes, and that's how we perform a dips. We realized that the amount of radiation what we get by using ultrasound is significantly less. it reduces to about 1/3 of what we do only by fluoroscopy. I'll show a case example who came to our hospital multiple times. This is how he was when he initially presented in 2006. Multiple collaterals in the liver. IVC was patent. These are accessory collateral veins, which are very small. So these kind of small veins, even if you plasty or stent, they do not last long. Instead, we have to go a reasonably big hepatic vein. Can anybody identify which vein is this? This vein is directed downwards towards the leg, and it is from the left side. It is a caudate vein. So caudate vein we can plasty if it is reasonably big. So we plastied, we stented. Subsequently, he was doing well on and off. He developed IVC stenosis. We plastied, and he required IVC stenting. So his disease was progressing, and he was coming for follow-up. Subsequently, he developed gross distension. I'll skip some of the steps to save time. Here, we need to do a DIPS procedure for him, but this segment of the IVC is already stented. So we have to go through the wall of the stent, plasty the stent wall, and then continue. The rest of the steps are similar. So as we can plasty the wall of the IVC stent, you can see there is a constrained portion of the balloon. So we have to break it, then only the dip stent will stay inside. So he has got long-term follow-up, and he is doing reasonably well. This is another case example. Young lady, ascites, no repairable hepatic veins, IVC is patent, and she was planned for an elective TIPS. As she was waiting, she presented with significant abdominal pain, and we can see that there is acute thrombosis in the portal vein. Why this has happened? Partly because her anticoagulation was stopped with the planned TIPS. So this stoppage of anticoagulation itself would have resulted in thrombosis of the portal vein. So here you can see the liver is swollen, acute thrombus in the portal vein, and this thrombus is also extending into the superior mesenteric vein. So this kind of patients require immediate attention. So we have done venogram. Here you can see extensive compression on the IVC. The only difference here is when we take the needle inside, get into the portal vein, there will not be any backflow of the blood because portal vein is filled with blood clots. There is no blood to come back. So here we heavily depend on ultrasound. So once we got into the portal vein, we pass the wire. When the thrombus is very soft, it allows the wire to go. This is also called guide wire traverse test. And as we blindly pass the wire, we reach the wire to the left side of the patient. This is inferior mesenteric vein. We reposition the catheter into the splenic vein. We angioplasted, and we mechanically removed the thrombus, and we placed the stent in that area. So what we believe is, for any thrombus segment to remain open, we have to remove the clot. There should be a good inflow. Similarly, there should be a good outflow also. Otherwise, whatever clot we remove, it may not give a long-lasting result. This lady has been coming for follow-up. I have written is 2 years, and she has come for longer than that also. So in a case of thrombosed hepatic vein as well as thrombosed portal vein, if we place a stent and do thrombectomy, it's a treatment for both. So we have published our experience in a couple of articles. This particular article says about clinical imaging and long-term follow-up. This is an unusual case where patient had renal function deranged, but she was not on dialysis. What we have done is, there is a focal stenosis of the IVC. We performed this procedure under ultrasound guidance and fluoroscopy with no iodinated contrast. And we are successful, but remember, whenever we try something like this, we have to be continuously monitoring, and we could re-establish the flow. So just to summarize the imaging findings, some of them represent acute changes, and some of them represent chronic changes. Re-intervention, which was mentioned by Dr. Uday Zakaria, it is common and it has to be kept in mind when you are doing intervention. This may be due to multiple factors, and when we perform intervention, the intervention should be in such a way that future intervention should be possible. For example, if you are placing a stent in the IVC, you have to remember that that particular patient will be coming for tips in the later stage. So we play a chess game rather than hitting a sixer in the management of Budd-Chiari syndrome. So this is to summarize. By using ultrasound, we increase the safety of the procedure when we perform intervention in the Budd-Chiari syndrome. Thank you for your attention.
Sir, your advice on a young female post-DIPS in a Budd-Chiari syndrome whose prothrombotic workup is negative and who's on lifelong anticoagulation either with warfarin or rivaroxaban. They want to plan pregnancy, and if we have to stop warfarin or rivaxa, how well they do without anticoagulation, or they can plan pregnancy or hold it?
Understand, you're telling about
prior to pregnancy coagulation parameter setting. We want to ask if patient want to pregnancy after DIPS or TIPS hepatic vein, if want pregnancy, then how to plan anticoagulation parameter?
Okay, you are telling about anticoagulation. Okay, I'll perhaps ask Dr. Uday to respond to that, because he's the one who takes care of that.
Thank you. I don't think there's a very good answer. So actually, if the patient comes to me, my first advice to the family would be to very strongly reconsider their decision of pregnancy. I know it's an individual family decision, but as physicians, we are due to, we are duty bound to advise them. So that's my first advice. The second, in spite of that, if they do wish, then I guess we have no choice but to put the patient on low molecular weight heparin for a little bit of time, and maybe in the second trimester shift back to oral anticoagulation. It's a tricky game. I don't think we have had too many patients. There is some data from Shalimar's group on these patients. So I would say that if the setting was the patient had achieved recanalization, that's a physiological liver, then I'm less worried about pregnancy. A patient who has had TIPS, it's not a physiological system, and I'll be more worried. I hope that clarifies.
Thank you, sir.
Sir, nice, excellent demonstration of cases. Sir, one short question. What is the ideal hepatic vein diameter in Indian scenario to attempt recanalization prior to switch to DIPS? Ideal hepatic vein diameter to plan recanalization.
Ideal hepatic
vein diameter.
Okay. We take it for a regular adult patient, we to see about a 6 to 7 millimeter as a suitable diameter of the hepatic vein. If it is smaller than that, we attempt plasty and see whether it is doing good, and we don't give good prognosis about that.
Thank you. Thank you.
Hi, thank you so much. I just wanted to ask an unrelated question, basically. So have you had experience with thrombolysis for SMV and portal vein thrombosis patients?
Yeah.
How was your experience with that?
Yes, it's a common scenario and very important question. If the thrombus extends to the portal vein, we get into the portal vein, we do mechanical thrombectomy, we reduce the pharmacological usage, we more look into the removal of the thrombus. If the thrombus is limited to superior mesenteric vein, but patient is symptomatic, in such situation we go into the superior mesenteric artery and we give pharmacological thrombolysis. But so in all this we see that patient is symptomatic.
Transhepatic for the vein and then arterial as well, both routes,
No,
is it?
if it is in the main portal vein, we go transjugular. Okay. We go transjugular, then go to portal vein.
The SMV you go to the artery.
If SMV alone, then we go SMA and give mechanical, we give pharmacological thrombolysis.
Do you find the results okay, satisfactory? Are the results satisfactory?
Results are good. We are yet to publish.
Thank you.
But this is our management approach for that.
Thank you, doctors. Thank you. We move on to the next session, which is about biliary endoscopy. I request the chairpersons Dr. Nandakumar R, Dr. Ramesh M, Dr. Karan Anand Para, Dr. Shaurav Bhatnagar, and Dr. Deepak Verma to please be on stage. I request the presence of the speaker, Dr. Saurav Mukhevar, on stage to talk about peroral cholangioscopy, what's new.
Thank you. All right, very good afternoon, all of you. Thank you, Dr. Philip Augustine and team, for having me in here. It's indeed a pleasure to be here. And we are switching gears now. So we are moving from our vascular interventions to the biliary system. So today I'll be talking about cholangioscopy, or peroral cholangioscopy, and what's new. So if you look at cholangioscopy and the history, the initial evaluation of the bile duct with an optical choledocoscope was performed way back in 1941. And then in the 1970s, there was the mother-baby fiber optic system, and direct peroral cholangioscopy was performed as well. And moving forward, the progress wasn't really made until 2015 with the spyglass DS system, which is what we use now. So if you really see peroral cholangioscopy, types can be direct, where the scope is directly inserted into the bile duct, or indirect with the help of a duodenoscope, a dual operator system, or a single operator system. And this is what we essentially use nowadays. So direct cholangioscopy has limitations. It's a larger scope, technically more difficult. You cannot traverse tight strictures, and requires a dilated bile duct. So what's really new in this era with direct cholangioscopy? There are several accessories which will assist the scope to be inserted directly inside the bile duct. For example, this is a guiding probe of CATS, not really available in the market, but essentially this is a stiffening device, and it's advanced into the bile duct, and the direct pediatric endoscope is then advanced over this inside the bile duct. Now we have interesting double bending cholangioscope, and this is again not in the market yet, but just to illustrate the point, because entering into the bile duct can be quite challenging, and therefore this double bending scope can facilitate when you have two areas of bending in the endoscope. But this is again not used much, and mother-baby cholangioscopy system, which was initially there, had a lot of limitations in terms of image quality, and the main problem was extreme fragility of the system. And therefore, single-operator cholangioscopy with digital spyglass has come into play and become very, very popular. It's a 10 French instrument with a 1.2 millimeters working channel. And now Olympus is also coming up with its own system, the CHF B290, not available in India yet, but this is supposed to have higher durability and strength. And the advantage is getting more depth of vision and enhanced imaging, which wasn't possible till now. There are several other newer cholangioscopes. Microtech, the Chinese company, has come up with this cholangioscope with two variations. One with a larger working channel of 2 millimeters, which allows you to put larger biopsy forceps and potentially get larger tissue specimen. Another Japanese company is coming up with another cholangioscope. Again, the Microtech is available in market, this Japanese one not yet. Indian company Biorad is also coming up with its own cholangioscope, so a lot of activity in the field. If you see the comparison between all of these, direct cholangioscopy, as you can imagine, has a larger diameter, but a larger accessory channel, four-way angulation, as most of us who have used SPY understands that you can't really bend it beyond a certain degree, and then image-enhanced functioning is also available with direct cholangioscopy. So that's really the difference between indirect and direct cholangioscopy. Several accessories are now in the market, especially from Boston SPY. These are SPY Bites, SPY Snares, SPY Basket Forceps. The snares can be used for stent retrieval. We've done this in quite a few cases. You can also use the snare for polypectomy. This is a patient with a large intraductal polyp, and we are using a SPY snare for performing intraductal polypectomy of the biliary polyp. Right here, it's removed successfully with the snare right there. Stone removal, now this is one of my older videos. Here, a SPY basket is being used to specifically grasp the stone. In this case, it was a residual gallbladder post-lap cholecystectomy, and we are using the SPY basket to remove the stone from this small residual gallbladder. New SpyBite Max forceps. This picture is of the old forceps, which have a plane without any serrations, and you see the newer forceps are much more stronger and have serrations. And overall, there's not much clinical data, but then overall satisfaction is higher amongst all the endoscopists with regards to these forceps. I was part of the team helping them design it, as these were designed in India. Let's move, switching gears, let's talk about stone management and how we can do with cholangioscopy now. So what's new? This is radiation-free ERCP for management of CBD stones. This is a study of 40 patients in which they did ERCP with cholangioscopy, and stones were removed with a 100% success rate. Now, they basically did cannulation with the bile aspiration, sphincterotomy, cholangioscopy to see and identify the location of stones, and they measured the distance from the ampulla, and then did balloon sweeps and removed the stones. They performed a multi-center study. The authors went on to replicate this in other centers, and what they could see is 90% almost fluoroscopy-free cannulation rates and fluoroscopy-free complete stone clearance of 82.6%, and a pretty safe procedure with 2% risk of pancreatitis. Applying all of this, this is an illustrative example of a patient, pregnant patient with multiple CBD stones. Here the cholangioscopy is being used to basically gain access inside the bile duct, and these stones are now being removed with the help of a spy basket, preventing any radiation exposure to the pregnant lady. So this is certainly changed in terms of what we can do for these patients. How about cholangioscopy versus standard stone removal techniques? This is a randomized controlled trial showing greater duct clearance with cholangioscopy and laser lithotripsy versus conventional therapy with mechanical lithotripsy. So CBD stones more than 1 centimeter were considered, no difference in adverse event rates, and you can see success rates much higher with cholangioscopy and laser lithotripsy. It was a longer procedure time, but it was more successful. Another randomized controlled trial comparing cholangioscopy laser lithotripsy with endoscopic papillary large balloon dilation. In patients, they could not remove stones with basket or balloons, 33 patients in each arm. Overall, higher treatment success rate with cholangioscopy and laser versus EPLBD. What the authors could see also was that a ratio of stone to CBD less than 1 and having a non-tapered duct was associated with higher success rates. So they went on to propose that if you have a ratio of stone to CBD more than 1, you should be performing lithotripsy directly. If the ratio is less than 1, you can start with EPLBD, and if not successful, then you can do laser lithotripsy. So a reasonable approach in terms of deciding which patient should get cholangioscopy. And putting it all together, this is a meta-analysis, network meta-analysis, where cholangioscopy outperformed all the other methods for stone removal. How about laser lithotripsy versus EHL? Always a question asked. Meta-analysis, almost 726 patients. Overall higher success rates with laser lithotripsy versus EHL. So that answers that question, I guess. How about cholangioscopy to confirm duct clearance? Now it's very interesting. 36 patients who had quote-unquote duct clearance on standard balloon occlusion cholangiogram, for instance, multiple stones, duct is cleared. The authors went on to perform direct cholangioscopy, and what could see is patients were either having no stones or some residual stones. And if you see the data, they were successfully able to do it in 86%, and 22.5% patients had some residual stones. Cystic duct remnant syndrome, another entity where stones were in residual GB or cystic duct. This is our case report in which we did laser lithotripsy in cystic duct remnant stones causing symptoms. And this is another study from Dr. Sanjay Rajput's group, 22 patients with cystic duct stones. They eventually managed to get in 90% access to the cystic duct and almost 100% clearance in all those stones. I'll just skip this one in the interest of time. Let's move on, talk about strictures. What we know from biliary strictures is brushings and intraductal biopsies through fluoroscopy is inadequate in terms of sampling. And therefore, randomized controlled trial. This is a recent study comparing brushings versus cholangioscopy biopsy for indeterminate stricture. You could see the much higher sensitivity with the cholangioscopy of 68% with biopsies. Earlier studies, this is from 2015, Cholangioscopic appearance was 60% sensitive in picking up malignancy. And more recent data, this is increased due to higher quality imaging with the DS2 that's available with 88% sensitivity with spyglass findings. So we are making progress. Now this is another data comparing visualization versus biopsy, almost 290 cases. Overall sensitivity of visualization was superior to biopsy, 86% versus 75% in terms of diagnosing malignancy. So therefore, there is ambiguity and this is not absolutely clear. So some authors sat together to come up with a criteria to decide on visualization how to determine malignant strictures. So they identified ulceration, papillary projections, and lesions to be associated with malignancy. But of course, you can see the numbers are not high. We end at 50 to 60% in malignant lesions. But the problem was the inter-observer variability wasn't too good. So this is the problem with identifying malignant strictures. So they came up with another classification now, most recent publication, where they found 5 different criteria: dilated tortuous vessels, irregular nodules, raised intraductal lesions, and irregular surface with ulcerations, and friability. And what they could see is they had much better inter-observer agreement, and these were largely associated with neoplastic lesions. So fine when you have a nodular lesion, but for flat strictures which are not having nodular lesions, I guess it's still a problem. So that's where artificial intelligence is coming into picture here. This is AI for cholangioscopy, training with almost 12,000 images to classify between benign versus malignant, and they can see almost a high 95% sensitivity in picking up malignant lesions. This is just an illustration from another study here, where basically what you can see is with artificial intelligence, it can label whether a lesion is benign or malignant as you're performing cholangioscopy in real time. So high sensitivity compared to standard methods. And then this is another study where they actually did prospective study and applied it in real time, and they could see high sensitivity above 95% with AI. So that's really coming into picture. A few little case reports here: bile duct tissue acquisition with cryobiopsy, that's coming into vogue. Now with direct cholangioscopy with the Olympus scope, potentially we can do enhanced imaging. Now this is a texture and color enhanced imaging inside the bile duct for better characterization of lesions. You can do it for biliary IPMNs. It's a RDI for biliary IPMN, characterizing the margins very well, and that can lead to change in surgical management. And this is about 34% patients, there was a change in surgical management based on findings in cholangioscopy, either less or more extensive surgery. So I'll just end it quick in maybe another 30 seconds. We can also use cholangioscopy for access to the bile ducts and tight strictures. This is a case here which was extremely difficult stricture. Even the contrast was not going across, and here we use cholangioscopy to basically gain access to the proximal ducts and eventually place a metal stent across. So when we look at it, benign strictures, high success rate for tight strictures to gain access, malignant not so much so, but still, it's still better than not having access. I'm just going to skip this slide here. We can do ablations. This is RFA, and this is APC of the gallbladder IPMN. So we can really go and do very novel things with cholangioscopy now. So in conclusion, there are several neurocholangioscopes available with newer devices and newer accessories. Cholangioscopic guided lithotripsy is superior to other modalities for difficult CBD stones. Radiation-free ERCP and stone removal is feasible with cholangioscopy. There's improved imaging, improved specimen tissue acquisition. AI has really transformed, will probably transform the field of cholangioscopy, and then we can use it for novel indications and use in various biliary conditions. So thank you so much. Sorry I exceeded the time a little bit. Happy to take any questions here.
Yeah, nice talk.
Thank you.
You covered almost everything. Since you showed that when you did ERCP, you removed the stones, did an occlusion, still 1/5 of cases you can have stones. So taking cost into account.
I'm sorry?
Taking actually, when you do a spyglass in those cases, you did in ERCP, you had negative this occlusion, but still the sedation showed that up to 1/5 you can still have some stones left behind. Yeah. So when in those situations, when will you do a spyglass? As a routine or because always cost is a factor? So when you do
I think you make a good point. I think the study really illustrates the point that our gold standard of a negative balloon occlusion cholangiogram is not probably the real gold standard, because there could be some patients with residual stones. Now, what kind of clinical implications does it have needs to be understood, because in our center, before lap chole, we do put a plastic stent in place, and then they come back after lap chole, and then we remove the stent, and there's sometimes we see stones, and whether they are new stones or there were stones that were not cleared the first setting, we don't know. And then at that time, we clear it. Now, very rarely have we had these patients, post-lap chole, stent removed, stones removed, having clinical problems from these stones. Now, that's really infrequent. Maybe because we do it twice, maybe that's why. But it's still an eye-opening number, because these stones remaining there sometimes may pass off spontaneously because you did a sphincterotomy, and other times they may lead to occlusion. So if you're not putting a stent prior to lap chole, you need to be aware that occlusion cholangiogram can actually miss some stones. Yeah.
And secondly, two scenes when you use is when you have a migrated stent. I think probably this thing you have the stent migration.
Stent migration.
Migration. I think this is quite useful, and obscure hemophilia occasionally it might help when you see can find some causes of spyglass. Yeah. Any questions?
Great.
Thank you, Doctor. There has been a slight change in the program, and the next speaker on stage is going to be Dr. Sandeep Nijavan, and he's going to talk about difficult to tackle biliary stones.
Good morning, ladies and gentlemen, Chairman. At the outset, I'd like to thank Dr. Philip for the kind invitation. I bring greetings from Indian Society of Gastroenterology, and I'm very sorry that I couldn't make it to the inaugural function yesterday. I could reach Kochi, but couldn't reach here because of the traffic. Today, I'm going to discuss about the difficult CBD stones. What is a large stone? A large stone is defined as a stone which is more than 1.5 centimeter, but a smaller stone can be difficult and a larger stone can be actually easy to remove. So there are certain characteristics of the stone which are responsible to make it difficult. The location of the stone, the anatomical situations while doing ERCP, and the patient factors. As far as the character of the stone is concerned, the larger the stone, it is difficult. The more the number of stones are more than 10 millimeter size, it is difficult. The harder the stones, they are difficult to crack. And strange shape of the stone, like square stones or barrel-shaped stones, they actually the corners get stuck while removing, and the impacted stones, because the basket cannot capture the stone, so it makes it difficult. So there's a need for lithotripsy for the success. If it is a location is intrahepatic, very proximal, there it is difficult to reach different ducts, and stones above a stricture, again it is difficult to actually reach that area. So unless until you tackle the stricture, you can't remove the stone. An impacted stone in the bile duct, you can't do many of the procedures on impaction, and a stone in the cystic duct leading to Meredith syndrome, again, they are actually impacted stone in the cystic duct, so you cannot go there and reach there easily. So these are difficult to assess stones. Then bile ducts is very important. Narrow distal common bile duct, that means around 3.5 centimeter of the duct. If it is narrow, you can't remove even a smaller stone. So a narrow, physiological narrowing of the common bile duct is also very important. It makes even the smaller stones to be removed with difficulty. Anatomical situations, alter anatomies, Bilrod 2, Roux-en-Y, gastric bypass surgery, periampullary diverticulum, these actually are makes the procedure very difficult. At times you have to use different scopes and accessories like endoscopes and accessories to remove the stone. Then patient factors are there. You have like old age, poor general condition of the patient, unstable vitals, bleeding tendencies, making more of the adverse events. The larger the stones, then we have got two approaches. Either you increase the diameter of the sphincter by doing a wide sphincterotomy or a large balloon sphincteroplasty, or reduce the size of the stones by breaking them. As far as actually breaking them is concern either you do it mechanically or by lithotripsy or electrohydraulic, or external device by shock wave lithotripsy. Then the ESG recommends a limited sphincterotomy combined with large balloon dilatation as the first line approach for a difficult common mild drug stone. I'll take it like this, that RCTs comparing EP-BLD with versus EST alone, the success rate, the adverse events, everything looks to be similar, but the requirement of doing a mechanical lithotripsy is far lower down if you combine EP balloon dilatation with sphincteroplasty, with sphincterotomy. So there's a meta-analysis in which endoscopic sphincterotomy versus including large balloon dilatation along with, and it has been shown in 6 randomized trials, almost actually 835 patients, and it has been shown that combination of EST and balloon dilatation leads to more effective approach in removal of difficult CBD stones, the larger CBD stones with fewer complications. Indications are dilated CBD with single or multiple large stones. Usually we use 12 to 20 millimeter balloon. Ideally we use 13 to 15 millimeter balloon. Relative contraindication is a CBD stricture. It can lead to perforation if we dilate it. So the tricks are do a small sphincterotomy, use a balloon according to the size of the CBD diameter and the size of calculus, and inflation time usually do 1 minute, but 30 versus 60 there is no difference. Inflate slowly, deflate slowly, it leads to less of the hemorrhage. As far as mechanical lithotripsy is concerned, actually don't drag down and then actually crack it, because you can actually injure the papilla. So it has always to be done in mid part of the CBD, and multiple stones, remove the distal stone first. At times you are stuck up, your stone gets stuck up at the lower end, then you have to actually take care. So every unit should have a Sohindra lithotripter to crush the stone. So in this photograph, you are seeing that we have a stone, the basket removed, only the wires are there. Then you railroad the Sohindra lithotripter and crush the stone. Either you actually break the stone or you break the wire and come out. Mechanical lithotripsy less than 2 centimeter, 100% success rate of mechanical lithotripsy. As the size becomes larger, 2 to 3 centimeter, 90%. More than 3 centimeter, you hardly can remove such big stones. Then what are the predictors for mechanical lithotripsy? Impacted stone, difficult to actually do a mechanical lithotripsy. Stone more than 3 centimeter size and a CBD ratio of more than 1. That means stone is bigger than the size of the CBD. Types of cholangioscope, Saurav has actually gone into details. Mother-baby scopes, nowadays we don't use. Then single operator cholangioscope, there are many uses. One of them is removal of the difficult stones. And the procedure is either you do a laser breaking it or electrohydraulic. Mother-baby is out of the vogue now. And in EHL, again, electrohydraulic, the results are not that good as compared to the laser lithotripsy, and the success rate by electrohydraulic lithotripsy is only 75 to 98% in difficult stones. That's how you do it actually. You take a spy scope up, then you actually break the stones by giving electrohydraulic lithotripsy. Then we have laser lithotripsy, helium laser is there. Success rate is better than the electrohydraulic, 93 to 97% success. Complication rate is to the tune of 4 to 13% only. And cholangioscope in extrahepatic stones, there is a decreased need for mechanical lithotripsy, and a prospective study, 92% of the stones with the stone disease achieved the complete stone clearance. And if you compare cholangioscopy guided laser lithotripsy versus conventional, it is more effective, 93% versus 67%. And if you see many studies, the clearance rate in difficult stones are to the tune of 74 to 100%, and most of them actually combine laser lithotripsy with cholangioscopy. If you compare laser with EHL, laser has got a higher completion rate as compared to EHL, so it is more effective in complete removal of difficult stones. Cholangioscopy guided electrohydraulic lithotripsy, complete success rate is around 91% in this study. And so ESG recommends EHL should be done in patients when the conventional techniques fail to achieve the complete bile duct clearance and intraluminal lithotripsy techniques are not available. So ESWL should be used only when the cholangioscopes are not available. The clearance is around 65 to 90%, and there are few complications. There are mean number of sessions required is around 3.6, and you need to have in ESWL, you have to have multiple sessions. You need to push in an NBD in this. You have to create a negative shadow, and then you actually break down the stones. The adverse events are to the tune of 9 to 35%, like cholangitis, pancreatitis, and purpuric spots on the skin, and even hematoma. Intrahepatic stones, you can do wire-guided removal by Domia basket, per oral cholangioscopy with intraductal lithotripsy, or you can do a percutaneous transhepatic cholangioscopic lithotripsy. US guided also is a help, and at times actually multiple intrahepatic strictures are there, so you take a use of surgery. CBD stenting, in case of incomplete drainage, you use multiple plastic stents, double better than the single stent. 7 French is equal to 10 French for breakage of the stones. So you actually keep the stent inside for 3 to 6 months to avoid infection as well. And because of the friction between the stone and the stent, there can be actually fragmentation of the stent. So my final slide is common bile duct stones. Normally, what we do is conventional method of sphincterotomy and removal by basket. In difficult settings, prediction of failed extraction by sphincterotomy plus balloon or basket. If the stone size is more than 1.5 centimeter, there are multiple large stones. Narrow lower end of the CBD, angled common bile duct. So you actually predict it before. You do a limited sphincterotomy and EP and balloon dilatation in the same session, or most of the patients have undergone ERCP before, with the sphincterotomy before, then you do directly balloon dilatation. And if it's a failed extraction, you then go ahead and do mechanical lithotripsy in these patients, and then use cholangioscopy guided removal of the stones by doing direct lithotripsy by laser, or you can take use of ESWL if the cholangioscopy procedure is not available. If it fails, all the procedures are failed and they are not readily available, then you must actually insert temporary plastic stents, preferably multiple, and refer to a tertiary care center to consider for the final answer, that is surgery. Thank you for your kind attention.
Excellent presentation. Topic is open for discussion. Any role for placing metal stent, removable metal stent in CBD? Yeah? Removal metal stent in CBD.
Removal?
Metal stent.
Remove the metal stents in this? Yeah. No, we don't use it actually. Metal stents are being used for, fully covered metal stents are being used for benign biliary strictures, dilatation, and we had one such patient in whom actually, we had suspicion of a stricture and we actually placed the stent. And after a few months, patient came with proximal CBD stones. So we were not sure that the patient had CBD stones before and it was a wrong incision of stent. But we could remove all the stones and then we could remove the fully covered. But the ideal indication of a fully covered stent is benign biliary stricture.
Thank you, doctors. Thank you.
Thank you.
We now break for lunch. Everyone, please be back for the next session at 1:45 p.m. Thank you. Welcome back to Light Update 2023. I request everyone to please come back inside. We are about to start the next session. I request everyone to please come back and take their seats. Welcome back to Light Update 2023. We are starting the next session. I request the chairpersons, Jismon Jose, Dr. Jismon Jose, Dr. Nitesh Agarwal, Dr. Manish Nair, and Dr. Tom George to please be on stage. I also request the presence of the speaker, Dr. Salil Karkhanis, to talk about percutaneous biliary endoscopy, an underutilized problem-solving tool.
Good afternoon. I'm Dr. Karkhanis, Consultant Intervention Radiologist. Thanks for the invite. I am here to speak on percutaneous biliary endoscopy, an underutilized problem-solving tool. Now, if you had seen the talk in the previous session, where they had talked about per-oral cholangioscopy, realistically, we are trying to achieve the same or similar results as far as patient outcomes are concerned. All the difference is that we're doing it from a percutaneous route. And I hope through my talk, I can focus more on setting up this service and how to go about doing this percutaneously. Those are my disclosures. So with this, I'm hoping to go through the what, whys, when, hows, and who of percutaneous biliary endoscopy, show some cases, and highlight some future plans. So clearly the name is self-explanatory. It is endoscopy of the biliary tree, or cholangioscopy, whatever you wish to call it, through a percutaneous route. So you think this is an innovative new technology, but if you look at this publication from JVIR from 1995, it talks about percutaneous biliary endoscopy as a commonly used aid to remove retained calculi, also to diagnose biliary strictures. It also talks about use of electrohydraulic lithotripsy, as well as basket, graspers, and biopsy forceps. So really, it's not that innovative a tool, that new tool. The first flexible choledocoscope done percutaneously was done in 1965, and the profile of that was around 20 French, or 6.5 millimeters. So what's changed? Why are we talking about this in 2023? So the main changes have been that in the profile of the device. Essentially, we have gone down from 20 French to 10 and a bit French. The screen clarity on which you can see the images has significantly improved since then. The ergonomy of the device, obviously. The diameter of the main channel is wide enough now to accommodate proprietary graspers, forceps, baskets, and lithotripsy catheters. It's single use now, which is a good thing or a bad thing. That depends on your perspective. So why would you use percutaneous cholangioscopy? Essentially, the indications, to make it simple, can be broken down into cholelithiasis, choledocholithiasis, investigating biliary strictures, and others. So as far as cholelithiasis is concerned, if you look at any of the percutaneous cholangioscopy papers published, you won't have many, and they'll be mostly a small to medium-sized case series. But whatever there is out there talks of fairly good stone clearance rate. The complications are also quite low, so appears to be a safe and effective approach to dealing with gallbladder stones. It's needless to say that some of the patients which you'll be asked to deal with could be frail and elderly patients, so you have to take it with a pinch of salt if you want to go around doing lithotripsy of stones in 80, 90-year-old patients, if they can tolerate it. As far as choledocholithiasis is concerned, clearly you have to still manage the underlying stricture and may need to do a balloon sphincterotomy. But once again, if you look at the published literature, medium to slightly large size series, good clearance of the stones from the CBD. You may have to use adjuncts such as lithotripsy with a sphincterotomy and a stent placement in the end. But once again, fairly safe, no major complications as such. This group, biliary stricture investigation, that's the group that I'm most interested in. I feel this is where cholangioscopy is really going to take off now. If you look at the two papers published, fairly large size ones, 95 patients and 177 patients, both of them, these are some tables that were taken from the papers. So both of them, as you must have noted in the previous lecture, focus on approaching biliary stricture not only as through the imaging, but also through biopsy. So if they looked at imaging, what they found was tumor vessels, irregularity, and color change. If you took these three criteria, tumor vessel was the most sensitive in being able to predict malignant change. Now, if you were to just take biopsy in isolation or tumor vessel in isolation, the PPV and NPV were whatever they are. But the moment you add the two, imaging plus biopsy, your PPV and NPV goes right up at 100% and 98.4%. And when you start comparing it to non-invasive diagnostic imaging such as CT and MRCP, it just blows them out of the water. So you essentially are right up there with 96% and 100%. If you look at this endoscopy paper, a prospective study from 2012, which basically sampled patients in 3 ways: cytology, breast cytology, standard fluoroscopic biopsy, and cholangioscopy. Once again, cholangioscopy scored way over the other modalities. So the other uses you can use, essentially what you have is a camera. So you can essentially use it to place guide wires past strictures or past narrowings which you otherwise can't get past. If you look at these papers published, 15 patients with anastomotic strictures that they couldn't be crossed. Within that, you were able to cross 60%. I don't think that's a bad number, considering that you had 15 patients to start with. You could use that for foreign body retrievals, not just in the biliary tree, but also elsewhere in other systems in the body. So realistically, when would you use it? And so we had to be very clear when it is that we want to start using percutaneous biliary endoscopy. And really, we're not trying to take over the world. There are fairly established treatment pathways for cholelithiasis, bile duct stones, biliary strictures, and so on. So we are trying to find the cohort of patients where the standard of care is difficult to implement and see if we are able to help them out. So in a cholelithiasis patient, essentially patients who have had high-risk acute cholecystitis that are requiring cholecystostomy, they were deemed not fit for surgery, and if they are not that frail that they could tolerate a 1.5 hour procedure, we would go ahead and offer this procedure. Otherwise, we'd offer other alternatives like ureteric stents to try and stent the cystic duct. Similarly, in bile duct stones, if you had an altered biliary anatomy post-transplant or HEPGEG, and if you had a preserved biliary anatomy, if there's a failed ERCP, or patient already has cholangitis that requires biliary drainage. So in those indications, we would put our hand up and say, yeah, we can help over there. Same thing with biliary strictures. Obviously, if you have a preserved biliary tree, obviously these things are best managed through per-oral cholangioscopy. But if it's an altered biliary anatomy, HEPGEG or post-transplant, percutaneously we can help. Or if patients who you've tried to do an ERCP, but for whatever reason, whether it's inflammatory stricturing, you just can't get past. And the same thing applies to the other group. So how would you do it? The first thing is to understand the product, the actual device. Now we use the Boston Spyglass Discover, which is the shorter percutaneous version compared to the Spyglass DS, which is the endoscopic version. I found it very lightweight, ergonomic, easy to use for someone who's new to the whole thing. The device was not very intimidating. You just plug and play into the device with a controller on the right, you just plug it in and everything just turns on. So for someone who's not using it very frequently, that's quite helpful. How did we go about setting up a service? So obviously, I told you about the patient cohort that we identified. That's the cohort we're going to target to start off with. No point opening your doors too wide and you can't deal with the traffic. In MDT settings, we started putting our hands up more and more to say that, yeah, we can help you with that situation. And before we knew it, within 6 months, we started realizing that the clinicians were asking for this pretty much on their own without being reinforced. There was some admin work because we had to put business cases to get the catheters, the Spyglass catheters and so on. And then obviously never do anything alone, always have a partner in crime so you can double the joy and half the pain. So I have an IR colleague who helps me with this so that if I'm away, he can manage. And we have a gastroenterology colleague who does spyglasses all the time, who became our proctor and our Yoda, who basically helped us with the initial understanding. Because our aim was to be able to progress to independent cholangioscopy, which is what we have achieved now. Because the purpose of this, which I'll tell you afterwards, was that we were struggling to find common room space. And that's what triggered this whole process. So with a quick service snapshot, with what we had done within the first year after starting in around February 2021, we were able to treat around 12 patients with 14 procedures, 93% technical success rate because one patient we just simply could not cross a complex post-cholecystectomy biliary injury stricture. All our procedures then were performed as two-stage, where you did a PTC and internal-external drain and brought the patient back for the procedure. And we had a short procedure time. Majority indications were for cholelithiasis, but that's changed now. Who to do it, IR or gastro? Gastro no doubt has the skill set, but IR, we have already developed the skill set. So I can safely say after going through the learning curve that it can be achieved. For gastro, it will be the additional workload. These patients are already on our books, so we just have to crack on and do it. And sometimes we can schedule collaborative procedures. trying to schedule combined procedures before, where we give the percutaneous access and they did the cholangioscopy, was very difficult because we just couldn't get the time. Quick case reviews. I've got 3 cases to show you which highlight its importance. First case, post-PPPD, developed a benign anastomotic stricture, came in septic, did PTC, 2 separate attempts at trying to cross it with a wire and catheter. Both times resulted in patients going to ITU with cholangitis. We had to wait till it settled down. We did the spyglass, and I don't have the pictures because this was the first one we did, and we didn't know how to save pictures at that time. But we could barely see the opening as a small freckle. We put the wire through, it just swam through the opening. We were able to plaster it and then put an internal-external drain. We removed that drain after 3 months. We haven't seen the patient since, so no news is good news. Case 2 is a patient with painless jaundice. I want you to keep a note of the timelines of this patient. Presented in January, had PTC, attempted endobiliary biopsy in late January, came back negative. We said to the surgeons, we can offer spyglass. They said, oh no, it's the new technique, we don't really want to try it. EUS FNA in February, came back negative again. We said again, we can offer. They re-went, attempted the PTC endobiliary biopsy by March, again negative. Finally, when we had to convince them that spyglass biopsy will work in this case, at the end of March from January is when we finally convinced them to let us offer the spyglass. And those images are from the spyglass technique. You can see the tumor vessels where the hilar stricture is there. And in a bit, as I keep talking, you'll see a forceps coming out, taking a biopsy. You literally are able to take a biopsy under direct vision as opposed to fluoroscopic stricturing. Patient could have a PVE and went on to have resection. Last case, patient with a benign biliary stricture post-complex pancreatitis, went on to have PTC. Multiple attempts were made to place a covered stent across the stricture, but it kept migrating. They finally placed an uncovered stent, which eventually, as you'd expect in a year's time, blocked off and came back with big concretions. A PTC was placed to take care of the sepsis, but they couldn't get past the stricture. So this was a cholangioscope, and you can see the large stones sitting right there on top of, and that's why we couldn't get past it. We were then able to go in and place our EHL probe and blast the stones into small pieces, and we had to work our way through the entire stent and then reline it with a covered metal stent, and that way we were able to take care of the patient's benign biliary stricture. Now, as you can see, just one picture before I move on, that's the probe coming in, and that's the lithotripsy, and that's how it looks like when you just blast the stones. So what are our future plans? We want the service to be more responsive. We've dug our own grave, so to speak, shot ourselves in the foot. We have got so much demand now that 2 of us can't deal with it. We have to rope in more people. We hope to have extended indications, hopefully import in more technology like AI in cholangioscopy, improve communication with referring teams and outside hospitals. So the learning points are that percutaneous cholangioscopy is a safe and effective modality. It's a very useful adjunct in any HPB IR practice. It's labor intensive to set up, but once you get past the learning curve, you can help a lot of patients who are otherwise can't be helped by the standard of care. You have to identify that patient cohort. You need buy-in from gastro, liver surgery, and there are courses you can attend. There are industry-specific courses, so maybe organized by individual companies, but there's a percutaneous course in Düsseldorf, I know about that. So these will help you to get your skills up to scratch. Sorry, and that's me. Thank you very much.
Thank you, Doctor. I request the next speaker, Dr. Shahnawaz B. Kalu, to please come on stage to talk about cutting balloons and biodegradable stents.
Good afternoon, everybody. I begin with thanking the organizers for the opportunity. I'm Dr. Shahnawaz from Max Hospital, New Delhi, and I will be talking about cutting balloons and biodegradable stents and their role in the benign biliary strictures. We all know that biliary strictures are broadly classified into benign and malignant strictures, and benign biliary strictures still represent a major challenge for the treatment, both for the patient as well as the physicians. The treatment duration is long. There are multiple admissions required and multiple interventions are required, and even after that their recurrence rates are still sizable. The treatment we are talking right now is the endoscopic treatment, like what we call ERCP. It is preferred because it is less invasive and it can be done when there is no biliary dilatation, like in bile leaks. And PTBD, it is preferred in cases which have multiple anastomosis, the systems are separated, and cases where the ERCP fails, and the cases which have hepaticojejunostomy where the endoscopic approach is quite complex. The conventional tools in our armamentarium, both for the endoscopic and percutaneous route, are balloons, plastic stents, self-expanding metallic stents covered, and percutaneous catheters. And the treatment's principle remains the same for the endoscopic as well as for the percutaneous route. The principle is sustained dilatation of the stricture, which continues for many weeks to months. This can be achieved by percutaneous catheters, or multiple plastic stents, or by placement of covered stents. And this principle has shown efficacy, a success rate of more than 80% in the literature. But there are multiple challenges which remain. The first challenge I am discussing here is resistant strictures, are those strictures which are not yielding to the conventional balloon dilatation and catheter placements. For these strictures, cutting balloon is an excellent choice. This is a picture of a cutting balloon in its inflated state. We can see that there are longitudinal atherotomes, these are called as, basically these are microsurgical blades placed on its surface. With these atherotomes, when the balloon is inflated, it creates a small nick or a micro incision on the wall of the duct, and this helps in dilating it even at very low pressures. Subsequent to the dilatation by a cutting balloon, a conventional balloon can be used to make the diameter of an adequate size. This method has allowed us for the dilatation of the strictures more easily to a larger diameter that can be achieved with the conventional balloons. And there are multiple studies to support this. This study, one of the earliest, shows that the success rate with cutting balloons is more than 90% in patients who had liver transplant recipients. Another study, this is from ILBS, and they showed that cutting balloons are successful in almost all cases without any major complication, and the patient population was those who had edge strictures. So the advantage with cutting balloon is that it can be used for refractory benign biliary strictures where the fibrotic burden is huge, and it doesn't have any major complication. There are no reported cases of biliary ruptures or major hemophilia. However, there are limitations, like there can be minor hemophilia which may need catheter external drainage for a few days, and it is only suitable for percutaneous route. There are no endoscopic balloons available. Next, we come to the biodegradable stents, which are a newer thing and probably a little more exciting. We just talked about the challenges in the benign biliary strictures, and specifically if we talk about the percutaneous route, the challenges are manifold. The catheter is dangling from the body of the patient, which causes discomfort, pain, and patients who are traveling, it might hamper their security check-ins and other things. Patients need repeating dressings, and if these catheters, there is pericatheter leak, this is quite bothersome. This bothers the patients most, and sometimes it even causes skin induration and cellulites and there is no way to go except to remove the catheter. But all these challenges can probably be addressed with the covered stents. But then there is another challenge. Most of the biliary strictures we are seeing in our practice are post-transplant strictures. And these are the high biliary strictures or hilar biliary strictures. And covered stents are not suitable for hilar biliary strictures because they can cause obstruction or jailing of the side branches like this, and which leads to the cholangitis. And we go back to the plastic stents, but we know they are small diameter, need frequent changing. Here comes the idea of the biodegradable stent. The idea basically is that a stent, once it completes its mission, should disappear in the body, and there should be no need to remove it. This will help us in many ways. There will be less number of hospital admissions, less number of interventions required, and there will be no external catheter dangling from the body of the patient. This might also be suitable for the hilar strictures because these stents are made of mesh and does not jail the side branches. So the indications which are still evolving and expanding are resistant and recurrent biliary strictures, for which there are multiple studies available. In our practice, we have also used these stents for patients who showed poor tolerance to the percutaneous catheters or who didn't want to have a repeat procedure. This is our protocol we follow in our hospital. So, is there a pointer? So in our practice, if we come across a biliary stricture, if it is hepaticojejunostomy stricture, we usually go for PTBD. Very uncommonly, we may go for a redo HJ. After PTBD is done, we go for serial upsizing, and mostly it does the job. But many a times, the patient may not tolerate once the catheter size increases, especially after 14 French. Or there may be a residual stricture even after we achieve the highest size of the catheter. In these two categories of the patients, we are offering biodegradable stents. These patients who have duct-to-duct anastomosis with ductal strictures, these many a times go for ERCP and some go to PTBD as case-to-case basis. After PTBD is done, we go for a serial upsizing of the catheters, and most of the patients tolerate it well and the treatment is completed. But there can be patients who do not tolerate it, or there are residual strictures even after the highest size of catheter is utilized. For patients not tolerating it, we are currently offering them the plastic stents, which are placed percutaneously and planned to be removed or exchanged after 3 months endoscopically. But these patients can also be offered biodegradable stents. The only challenge in our practice is the cost. But those patients who have residual stricture, even after using the largest bore catheter, we are offering them biodegradable stents. These are. So, there are 2 biodegradable stents we have used which are currently available. Though there are more upcoming stents, but in our practice we have used these 2. One is DV stent by LR. This is the stent, and the other is the Archimedes developed by the Q3 Medical. DV-LR is a self-expanding stent. It is made of polydioxanone, which is basically the same material which is used for manufacturing the surgical sutures. And the stent integrity and its force is maintained for 6 to 8 weeks, and the degradation is complete by 3 to 6 months. One thing to note here is that this stent is not visible under X-ray, under fluoroscopy. So there are 2 gold markers at each end of the stent like this, which help us localizing the stent. Once I will show you the images, so it will become more clear. Additionally, this stent comes separately packed, not in the delivery system, so you have to load it manually on the delivery system and deploy it. The largest diameter is 8 and 10 mm available, and lengths are available up to 8 centimeter. The delivery system is bulky. It is more than 11 French. This makes it non-compatible to the endoscopy. There is another stent. This is Archimedes stent. This is make a polymer called as polylactic acid. It is a helically shaped stent, and the bile flow is in the crevices between the ridges. It is compatible with the endoscope, and it has better fluoroscopic visibility. And it comes in 3 strengths which last from 12 days to 11 weeks, depending upon their strength. I present briefly our experience. We have done 5 patients with bioabsorbable stents, and we placed 6 stents in them. In 3 patients, we placed DVLR stent. In 2 patients, we placed Archimedes. All these patients were post-transplant strictures. 3 patients had edge strictures, and 2 patients had duct anastomotic stricture. Mean follow-up was 15 months. We didn't encounter any case of recurrence till now. We didn't see any major complication or any major episode of cholangitis. This is one case. This gentleman had undergone PTBD, which had been there serially upsized and was kept for 9 months. Still the stricture was there. Then we placed this stent, and he is doing fine. Another gentleman with a left lobe graft. This is a post-transplant where we did this DVLR stent. This gentleman has duct-to-duct anastomotic site stenosis, and there were 2 anastomoses. So we had to place 2 stents. The stent itself cannot be seen, but the contrast in the lumen of the stent can be seen. And yes, these stents, because they are made of mesh, so we expect them that they will be helpful even if the side branches are jailed. There are multiple studies to prove their efficacy. This study has 18 patients post-liver transplant. They showed a complete resolution rate of strictures in 72% patients. Another study with edge strictures showed complete resolution in 84%, more than 84% cases. Another study which had pediatric as well as the adult liver transplant recipients, they showed an anastomotic stricture group had 81% of efficacy, and non-anastomotic stricture is around 50%, which is decent. And there are smaller case reports and studies which are again show their efficacy. There have been a minor concern of cholangitis because once these stents break, they do not dissolve in the body actually. They break and fragment, and they can cause clumping and occasional episode of cholangitis. That is the only concern. So I summarize that biodegradable stents can provide at least the same results with our standard treatment, but with a lesser number of hospital admissions, lesser annoyance to the patient, and much better patient tolerance. There are still limitations with episodes of acute cholangitis, and cost is a major concern. These stents cost almost 5 times the cost of a routine stent. In future, we may see drug-eluting biodegradable biliary stents, and paclitaxel is being studied in this role. I thank you all. Thank you very much.
Thank you, Doctor. Due to the lack of time, we are moving on to the next speaker. Dr. L. Venkatakrishnan, I request you to please come on stage to talk about biliary interventional endoscopy when things go wrong.
Can I ask a question, please? Dr. Shanavas, I have a question.
Yes, please.
Yeah, so you're telling that biodegradable stent is not visible on X-ray. How is the visibility on ultrasound? And
we haven't done any ultrasound on this because all these patients were post-transplant patients. We didn't do it, but we don't even expect to see them because in the hilum of a post-transplant patient, there are so many clips and so much stuff. So I don't really expect to have a great visibility there. But yeah, on fluoroscopy, the stent itself is not visible. But there are gold markers at the end of the stent, so you can make an idea from which place the stent begins and where it ends. But yeah, you cannot see the stent itself.
okay, and one more thing, like there is a concern for the stent to get fragmented and possibly it can come and cause transfer obstruction. Okay.
Yeah, but it has been reported less than 10% of the cases. Yeah, it can happen and it may require a reintervention.
Thank you, doctor. Really sorry to cut you, but we have very less time.
At the outset, my heartfelt thanks to Dr. Philip Augustine, my mentor, and my good friend, Dr. Ajit, for having given me the opportunity to discuss the endobiliary intervention. Since the topic is too large, I thought I would confine myself to the complications of diagnostic and therapeutic EUS. Endoscopic ultrasound, as we know, has established itself as a very vital technology in the field of endoscopy. Way back, it started as a diagnostic procedure performed mainly with the radial echo endoscopes, primarily to stage GI cancers. And when endoscopic ultrasound, fine needle aspiration was introduced, it takes the endoscopies to the next level of expertise, but at the same time poses additional challenges and complications. It could be that you are going in from a sterile area, you're going through an unsterile area interesting when you do an FNAC, so there's a small chance of introducing infection. You're primarily invading sterile areas. Sometimes you inject liquids for tattooing and solid agents like pancreatic fiducial implantation. And of course, when you do a procedure like endoscopic celiac block or neurolysis, you may have to take care of the adjacent structures. So once the therapeutic interventions was introduced, there was increasing degree of technical difficulties. But still, comparing to the peer of surgical and percutaneous, it has been now recommended that endoscopic ultrasound guided interventions are feasible and less invasive compared to peers in percutaneous and radiological interventions. The endoscopic ultrasound related complications could be related to procedure related. It could be related to a specific intervention. It could be operator related. Most of the interventions had complications when the operator was less than 2 years in the field. It also depends upon the general health of the condition and disease per se, and what is the sedation you have given to the patients to get the recovery. The most usual complications in any endoscopic intervention will be bleeding, perforation, infection, and some of the complications are related to the specific intervention. Complications of US diagnostic it's because most of the echo endoscopes or US have a very, they have a very non-flexible tip so that the terminal 5 centimeters becomes very, very rigid, unlike an endoscopy. So the terminal part is more rigid than the standard endoscopes. The second problem is the view is kept at an oblique view. So when you're introducing or you're taking through the echo endoscope, sometimes the maneuvers are very semi-blind. And you can cause, because of these maneuvers, you can cause perforations at the natural narrowing segments of GI tract. This could be either at the cervical esophagus or the D1, D2 junction. But of late, with more of these diagnostic being done with the linear scopes, the complications have come down. And in about 24,000 procedures, when we had a cervical esophageal perforations, only 0.3% was reported by Shyam's group. And in this particular group, more patients are mostly more than 65 years of age. And most of these patients had a difficult intubation by endoscopy. And most of the perforations occurred when there was a radial endoscope used, and the operator experience was less than 1 year. Esophageal cancer and strictures also increase the incidence of perforations when you are doing a diagnostic US. This could be overcome by either a repeated Buji dilatation with 16 millimeters, but that also has got 10% risk of perforation. Miniscopes could be other alternative structures. The complications of US guided fine needle aspiration, the morbidity is around 2.5%. Death is very rare. The complications were predominantly infectious complications, pancreatitis and hemorrhage. Infectious complications generally occurred not in the solid US FNA, but when you are dealing as FNA from a cystic lesions, infections were more. When you do a US FNA of either a mediastinal node or a pancreatic mass, the infection count is very less. At this point, there is no particular recommendation to give prophylactic antibiotics when you do a US FNA, except when you are doing an FNA from a cystic lesion. The pancreatitis is commonly seen when you are doing US FNA and it hits the normal intervening pancreas, and it has been shown that the pancreatitis is more common if the tumor is less than 2 centimeters and if you are doing a pancreatic net. So patients who have got a pancreatic net have more common complications of pancreatitis. Hemorrhage in US FNA is very, very rare. Most often it is a minor hemorrhage, but which can spontaneously heal. Occasionally, there may be a small unknown collateral or unknown artery which could happen. It causes bleeding, but most of these patients have a spontaneous stoppage of bleed. Tumor seeding has been reported only in one case when patients, they did pancreatic peritoneal carcinomatosis, and in bile peritonitis was reported much earlier when they failed to take an FNAC from the gallbladder mass, instead punctured the gallbladder wall. In US FNA pancreas, the risk is only 2%. Injury is to normal intervening pancreatic or ductal injury. So it is logical to reach pancreas using the shortest distance. In about 100 concentrations, only 2% develop pancreatitis, and as I said, tumors less than 20 millimeters, pancreatic net intervening pancreas are a highest risk. When you use celiac plexus blockade, it can either be a blockade or it can be neurolysis. The complications usually are orthostatic hypotension, diarrhea, transient decree in pain, and there was one report of abscess formation. Neurological complications have become very rare when you do neurolysis, as this is an anterior approach, but still there was one patient who was reported to have a spinal cord infarction. If you look at the US pancreatic fluid collection drainage, technical success is now more than 90%. Shams group says they have a technical success of more than 94% and treatment success of 85%. The complications rates are 4 to 7%. Complications are commonly seen are perforation. Perforation commonly occurs when there is a rapid emptying of the cyst and the stents move away. That is one cause of perforation. The second cause of perforation could be use of an electrocautery. The third is probably using non-axial puncture systems when you don't. So they generally recommend don't use electrocautery or don't use needle knife. Instead of that, you can go have a wire-guided coaxial system with a graded balloon dilatation. Bleeding can occur in pancreatic drainages, especially when you have an unknown collateral or when you have left a stent. The stent, after the collapse of stent, there can be follow-up of a pseudoaneurysm. Majority of the bleeds occur in the site of the entry, and most of this could be controlled with electrocoagulation. But occasionally, people have used adrenal injection as well as over-the-scope clips and hemostatic powder. In about 2% of patients from Shams group, they had a massive bleed and they identified pseudoaneurysm for which embolization was done. Stent migration was commonly seen when stent was placed closer to the G junction, and it is already said that this stent migration, to prevent stent migration, you may have to have used a longer stent, or now with bilateral flange stents, stent migration has come down. Infections in pseudocyst commonly says when you have a sterile pseudocyst, the success rate of US pancreatic fluid drainage is about 90%, but if you have an infected pancreatitis, it's only about 65%, and your complication rate should be 16%, and most of them are related to pancreatic necrosectomy. Air embolism is very rare in the era where we use carbon dioxide. US pancreatic drainage is an extremely technically demanding. It is generally done either pancreaticogastrostomy or we can do US guided rendezvous technique. The rate of complications can range from 5 to 43%, and most of the complications are either be bleeding, could be pancreatitis when you have ruptured a pancreatic duct, fever because of abscess formation, and there can be a pancreatic duct leak. In a multi-center studies, they have divided the complications of pancreatic duct US as immediate adverse event which will occur within 24 hours, delayed adverse event which will occur after 24 hours. The minor AE and major AE. Minor AE is a post-procedure pain or bleed which requires no intervention, but major EE may include pancreatitis, bleed, pancreatic abscess, perforation, or a main pancreatic duct leak, which may require a multidisciplinary approach and treatment. US guided bleed region has also already been discussed. Comparing to common choledochoduodenostomy, US guided hepatogastrostomy tends to have more complications. The common thing could be bile leak, perforations, pneumoperitoneum, cholangitis, and stent migration. Stent migration is more common with hepatogastrostomy, and it is always advised that you keep at least 5 centimeters of the stent when you do a hepatogastrostomy into the gastric lumen. So what are the practice points? It is to be remembered that US is both diagnostic and guided. FNA are very safe despite complications which occur anywhere between 2.5 to 3%. Adverse events are perforation, bleed, and infection. And US FNA, when I came to hemorrhage, I need to say that all patients with anticoagulants should not undergo an FNA. If the patient is on aspirin, he can go upon it. Clopidogrel, if patients on clopidogrel, you have to refrain from doing it before stopping it. And if you are doing a pancreatic cyst, you should always stop. Any type of anticoagulation should be stopped. Prophylactic antibiotics are not needed for solid lesions, but when you are doing a cystic lesion, you need to give prophylactic antibiotics. Even cardiac patients, to prevent endocarditis, it is not recommended. For pancreatic fluid collections, it is better to use a biluminal flange metallic stents rather than fully expandable stents. And complications, as I said, are bleed, perforation, infection, stent migration. PD drainage is technically challenging procedure with major and minor complications, including a PD leak. So US and US guided intervention can be associated with complications, more commonly during early phase of career. Some complications are unique to procedure like PFC drainage. Most adverse effects are minor. All complications, but even though it is rare and less common, all should be systematically recorded and should be collaborated with peers. Major complications with a massive bleed or an abscess or an infection may require a multidisciplinary support. Thank you.
Thank you, Doctor. Thank you, doctors. We move on to the next session, which is about portosystemic shunt occlusion. I invite on stage the chairpersons, Dr. Yashwant Patidar, Dr. Prashant Sarda, Dr. Santosh Balakrishnan, Dr. Gino Thomas, and Dr. Dharav Kheredia. I request the presence of the speaker, Dr. Jasim Koya, to talk about closing spontaneous PSS for HE in cirrhosis.
Okay. Good afternoon, everyone. At the onset, I'd like to thank the organizers of this wonderfully organized program. I am Dr. Jasim. I'm stepping in for my head, Dr. Jagdish Singh. So we are going to talk about closure of portosystemic shunts in HE. HE, as you all know, it's the neuropsychiatric disorder which is seen in cirrhosis with portal hypertension and also in non-cirrhotic patients with acute liver failure, hepatitis, or congenital portosystemic shunts. the medical management options are limited, and for recurrent and persistent HE particularly. So we can, there are a couple of definitions to keep in mind. The first being episodic HE, that is those that have resolved spontaneously with no recurrence for up to 6 months. And recurrent HE is when there are more than 2 bouts within 6 months of duration. Persistent HE being dementia-like alteration of consciousness with no resolution. Again, this can be clinically classified as minimal to grade 4, being covert HE and overt HE. So the pathophysiology, you're well aware of this. When there is CLD, increase in portal pressure, there's an increase in the portosystemic gradient, and that results in the diversion of blood flow into the lower resistance portosystemic circulation. This results in the pathology of portosystemic shunts. Coming on to the physics behind it. Now this is the famous electrical circuit theory by Kim and Lee, which was proposed in 2016. This slide looks a little busy, but let me just draw your attention to this place here. So you can see that the portal pressure, there is flow in, within the portal, within the hepatic channels, and there's also shunt flow. So when there is an increase in the portal pressure per se, there is a relative increase in flow towards the shunt. So the occlusion can take place in any of these places. You can either occlude it in the inflow, in the shunt proper, or the outflow. And then there's the subsequent, so you're going into the systemic venous circulation. So essentially, you can say that the shunt flow can be increased by one of two things. Number one, it can be increased by increasing the portal pressure, and it can also be increased by the relative decrease in the shunt resistance. And that is what's called the spontaneous type of portosystemic shunt. So essentially, you can have multiple inflow channels or afferent channels, the common ones being the coronary or the left gastric vein, the posterior gastric vein, and the short gastric veins. And then you can have many efferent channels as well, the common being the gastrorenal shunt and the gastrocaval shunt, among many. So this was an interesting paper which was published in the Journal of Hepatology, which found that the total area of the spontaneous portosystemic shunts is an independent predictor of hepatic encephalopathy and mortality in cirrhosis. So it goes to say that the total surface area, the TSA, predicts the survival in chronic liver disease, and the cutoff was taken as more than 10 millimeters. So if you take a true axial section in a coronal reformatted image, in a curved reformatted image, you take a true axial of the shunt proper, you take that diameter. If it is more than 10 millimeters, it is quite significant. So again, it goes to say that you're talking about the total surface area, not the diameter per se. So the addition of 2 smaller or 5 millimeter shunts does not necessarily translate into a larger area, as you can see in this example. So there's a total surface area of 220 and 280. It does not necessarily translate that 5 plus 5 equals 10. So the clinical significance of shunts, I'll just skip this, it's not all that important, it's quite evident. But in 2005, it was found that the large portosystemic shunts was related to chronic HE and also recurrent HE. Now, this is a quite important one related to patient selection. Now, when you take all the patients with cirrhosis who have developed HE, it was found that the incidence of spontaneous portosystemic shunt was as high as 46 to 71%, quite significant. And most of these patients have recurrent or persistent HE, which are refractory to medical management. And those patients, this is ideal for patient selection. When you have those cirrhotic patients early on in disease who develop HE, those are the ideal candidates for closure of shunt. The portosystemic shunt syndrome, which was defined by Kumamoto, essentially it has to do with the pathophysiology of the portosystemic shunts. When you have large portosystemic shunts, in 2 ways it can affect it can cause HE. Number one, it is shunting away of the blood, impure blood away from the liver. Number two, it essentially deprives the liver of essential portal flow and thereby reducing the hepatic reserve. So, based on the mechanisms of HE, again you can divide HE into 2 types, one being hepatic failure per se, the second related to the shunt proper. That is, it can either be iatrogenic due to TIPS or it can be spontaneous. So this is the patient selection criteria. When you have a large, the so-called large, if it is more than 8 millimeters or ideally 10 millimeters, and if you have lower MELD score, it will be better. But of course, beggars cannot be choosers. We cannot always wait for patients to have a lower MELD score, or to essentially, you cannot select too much based on this criteria. So recurrence is based on other factors too. It's not, the HE is not essentially purely based on the shunt per se. It can be so many other things. We know that sarcopenia can be one of the factors, like unnecessary use of diuretics or excessive use of diuretics, among others. So I'll just go into a couple of cases quickly. So again, you can have occlusions on any of these three levels, the afferent and efferent channels essentially, okay? So you have this patient who has quite a high MELD 22, but this patient had a large splenorenal shunt. So this, wherever possible, the red arrow would indicate to the afferent channel and the blue would indicate the efferent channel. So that's the shunt, and you can see the shunt proper, and this is the efferent into the left renal vein. There was also a smaller shunt, which is, there is also a smaller efferent, which is draining directly into the IVC. And this was the procedure that was done. So a transhepatic approach was taken directly into the afferent channel, and it was coiled off, and also glue was injected. So this was the occluded afferent channel. Coming on to the second case, this was a 40-year-old CLD type 2 diabetes, and the ammonia was 32. Now in this case, there were multiple complex shunts with afferents from splenic vein draining into the left renal vein. So you have multiple sort of channels which are draining into the left renal vein. The afferents were also multiple, and the efferents were multiple as well. So this was the one of the efferent channels. You can see the left renal vein, a curved reformat image. Here you can see again multiple efferent channels draining into the left renal vein. This is from the portal circulation. This is just one of the channels entering the shunt proper. But this is what it looked like from the splenic vein. You can see that the afferents per se are not specifically delineable. You're not able to say that this is the specific afferent that I want to occlude. So we went through the transfemoral approach into the IVC, into the left renal vein, and we occluded these renal vein efferent channels. And some of these actually, this coil was actually quite proximal. We tried oversizing whenever possible. Very honestly, what happened here was when one of these channels were occluded, it migrated off, but luckily for us, it stopped right at the ostium of the efferent channel. And this was another case, MELD 13, ammonia was 100, and post-procedure it was 32. In this case, there were two shunts, the left paraumbilical shunt draining into the left external iliac vein, and a lenorenal shunt. The lenorenal, of course, being a direct lenorenal shunt. So, this was a gastrorenal shunt. So you have the paraumbilical vein draining into the left external iliac vein, and the gastrorenal shunt depicted here. So these are the corresponding CT images. I'm just going through quickly. So that's the left external iliac, the efferent channel, and that's the gastrorenal shunt. So this was taken through an IVC access. It is quite similar. It was just plugged off. The efferent channel of the large GRS was plugged off, and a direct puncture under ultrasound guidance of the superficial shunt, the paraumbilical vein, was done, and it was coiled off. So a significant amount of coil was put so as to occlude the shunt completely. Now this was another case in which this was a MELD 10 and type 2 diabetes NASH related CLD. In this case, there were two shunts, a left paraumbilical shunt draining into the superior epigastric vein, which is a smaller shunt, and a large lenorenal shunt. So in this case, again, the selection becomes important. When you have small shunts, generally it may not contribute to the HE proper. So the problematic one was this one, the gastrorenal shunt. The smaller one you could ignore. So that's the smaller one here, and that's the gastrorenal shunt. So in this case, again, we took a transfemoral approach, the left renal vein, and here you can see that it was plugged off. So this was the plug there. And then this is another case in which there were other added problems. There's also IVC thrombosis and main portal vein partial thrombosis with 2 shunts, a linorenal as well as a mesocaval shunt. So IVC plasty was done along with the shunt embolization. So here you have IVC stenosis, which is not depicted here, and IVC thrombi. And these are the shunts which are shown here. So you have a mesocaval shunt as well as a splenorenal shunt. That's the portal vein thrombosis, partial portal vein thrombosis. These are the efferent channels. So you have a mesocaval as well as a going into the left renal. That's the IVC thrombus which is depicted here. So this was what was done. So this is showing the minaret sign, what was described earlier. IVC plasty was done. You can see some residual thrombi still. And this was the, through the same axis, the linorenal shunt was cannulated and it was coiled. And the mesocaval shunt was also cannulated through the same axis and it was coiled off. So this is the last case. There were multiple, large channels opening into from the IMV into the internal iliac vein. So this was again an antegrade approach into the left iliac vein, into the inferior mesenteric vein and into the collateral and coiled off. And while coming out also, it was closed. So shunt embolization is a safe and effective procedure, sometimes with as high as 100% technical success. And post-shunt embolization, aggravation of portal hypertension can be related to higher MELD score. And multiple shunts, ideal selection criteria is 8 millimeters or preferably 10 millimeters. And ideally leave out those with less than or equal to 4 millimeters. Recurrence can be based on several factors, and shunt embolization is relatively safe for portal vein thrombosis patients as well. Thank you so much for a patient hearing.
Do we have any time for questions?
Yes, sir.
Any questions from the house? Thank you very much, Dr. Yatish, for a lovely talk. I just have one question. One of the concerns, especially when we take out large shunts, is the aggravation of portal pressure, as you said. What proportion of these patients who had encephalopathy but didn't bleed start bleeding after this procedure, especially when it comes to the left-sided spontaneous shunts like the linorenal and those lot? They do tend to have hypersplenism-related problems sometimes, but bleeds aggravating after this. What is the incidence?
So I'm not sure what the exact proportion of patients have, but we don't have data regarding the same. Like, as in, we don't have data regarding those patients who have had, an accentuation of portal pressure, whereby there has been recurrent, variceal bleeds or so on.
But it's not really a practical problem. You don't see it often happening, do you?
Yeah. No, we don't have data regarding the same. I cannot negate it altogether.
Let me just answer that for you.
Thank you.
Post shunt embolizations, all of these patients are kept on endoscopy follow-up 6 monthly, and the incidence of bleed is around 5 to 10% after 2 years of shunt embolization. So immediately they usually don't bleed, but many of these patients who had pre-existing esophageal varices, most of them are banded prior to occlusion, and even after that we keep them on endoscopy follow-up 6 monthly.
Thank you very much for that.
Thank you.
Thank you, doctors. We have the next speaker on stage, Dr. Shyam Kumar in Keshwa. He's talking about Abernathy malformation, endovascular management.
Good afternoon, everybody. I thank Dr. Philippe Augustin for giving me this opportunity. This is a relatively less addressed topic, Abernathy malformation, congenital portosystemic shunts. I'll show a couple of case examples. This is a 41-year-old patient who had progressive exertional dyspnea, cyanosis, and he was significantly restricted quality of life, and he was oxygen cylinder dependent, and he also had infertility problem, and he had cyanosis, grade 4 clubbing, and he had pedal edema. On imaging, he had normal chest radiograph. Echocardiogram was unremarkable. He also had undergone pulmonary angiogram elsewhere. That was unremarkable. And someone suggested him for HRCT thorax. So when HRCT was being reported, somebody observed dilated abnormal vessels in the upper abdomen. Subsequently, he was suggested to undergo a proper CT abdomen. These are the venous faces of the CT abdomen, which I am showing you. So if you look at the inferior vena cava, it is large. And if you look at the portal vein, it is smaller in caliber. And if you see the spleen, it's unremarkable. And as we come caudally, large IVC again, renal veins are distended. And in addition, see, like how these small bowel loops are looking like, you can see one extra structure here, very hard to quickly notice. And this is a large dilated vein, what you see on your left side. This is an abnormal channel which is there, whereas these are bowel loops on the left side of the patient. So when we create a 3D kind of structure for this, we'll see that small portal vein for the patient, inferior vena cava which is dilated, and a tortuous, grossly dilated vein sitting in the lower abdomen. Its diameter is something like 2.5 centimeters. And this is an example of Abernathy malformation, congenital portosystemic shunt. If you look at his lab parameters, only one thing abnormal was bilirubin, which was elevated. And this was the first case we saw of Abernathy malformation about 20 years ago. And these are the treatment options which came to our mind during immunity discussion. Then, how to treat this patient? We thought we'll cannulate this vein from the jugular axis, which is almost parallel to the IVC. You can see it here. And we measured the pressure, which was very low. Then we thought we'll inflate a balloon there. Let us see what happens. And we did not know how long to keep this balloon inflated. We thought we'll keep it for a few hours or 24 hours like that. Following that, patient said he was feeling better. And when we went to see him in the ward after 1 hour, the balloon was accidentally deflated. Somebody thought that they'll clear the side arm, thinking that it's an IV access, and inadvertently balloon was deflated. We did a bedside ultrasound. There was no flow in the shunt, surprisingly. This patient responded very well. In fact, what has happened, when he inflated this balloon, in a tortuous vein, but the balloon was straight, because we did not have suitable balloon of that size. We accidentally damaged the epithelium of that vein, and that resulted in the thrombus formation, and it completely occluded the vein. Clinically, he did excellent. You can see that over a period of 2 years, the portal vein, which was so small, it has grown in size, and IVC, which was so large, it has become small in size. And this was the region of the shunt. There is no vein which you can find there now. It is totally atrophied. This patient is one of the best examples we ever had, and his walking improved. I did not know that grade 4 clubbing can disappear completely. If I knew earlier, I could have taken a photograph of that. And volumetry improved very well. And he told that he sold his oxygen cylinder in second hand. We have followed up for more than 18 years. And last time when he came, he said that his son joined MBBS. Going on to another case, 8-year-old child. Child was okay during the first year. Subsequently, diagnosed autism, and patient was undergoing support. Somebody who was known to this patient said that, why don't you get on ultrasound abdomen? We really don't know the reason for ultrasound abdomen, but ultrasound abdomen picked up something unusual. You can see there is a dilated vein which is connecting between the IVC to the portal vein, and that is showing the flow. So this is a portocaval shunt. This patient had elevated alkaline phosphatase. All other, including ammonia, were normal. We had to do a CT, though it's a child, because we need to know what exactly was going on. And this is the venous face. you can see there is a shunt between the portal vein and the IVC. It is almost like a ductus venosus which has not resolved, which has not disappeared. And you can see that portal vein peripheral to that is not visible much. We did an MRI brain. There is something interesting finding here. In this coronal image, medial part of the basal ganglia here, the globus pallidus, it is showing high signal intensity on T1. This is a finding what we see in hepatic encephalopathy. So this child was having chronic hepatic encephalopathy due to a persistent shunt since birth. It is almost like the tip shunt what we create. And that's why this child is having the problem and what was misdiagnosed as autism. So we cannulated this vein and we saw there is abrupt flow into the IVC. We did not have a suitable balloon which is atraumatic, but it could occlude this large shunt because we wanted to demonstrate the presence of portal vein. So when we forcibly injected here, we can see small branches of portal vein here. Okay, so it gives us confidence that this shunt can be closed. But we were scared because in case if the child develops some acute problem like hepatic failure, what to do next? Prophylactically, we placed a tip shunt. You can see that this, what we see here is a tip shunt, which is like 4 millimeter or 6 millimeters. It is an uncovered shunt, uncovered stent, because we wanted the shunt to close over a period of time. Following that, we placed a cover stent in the IVC at the outflow tract of the vein. You can see 2 stents parallel. So that has successfully closed the shunt. During follow-up, we can see the portal vein has started growing. This is the shunt which is present. And child showed marked clinical improvement. Patient was listening to parents, and what the dad told was, child is looking at the parents' eyes and talking, and conversation significantly increased. So this is the type of Abernethy malformation what we have. This has been classified as type 1, A, B, and type 2. So what we have seen are the one where there is a connection from portal vein to the IVC. But there are types described here. The portal vein is joining the IVC, but there is no presence of portal venous branch in the liver. So this kind of pattern we have not seen. Perhaps this is not compatible with life, and this patient we may not be able to see. But these are described in the literature. So basically what is happening is catecholamines which are there in the portal vein, they are directly reaching the systemic circulation. The first hit is into the pulmonary artery, which can cause pulmonary arterial constriction and patient develop pulmonary arterial hypertension, like we saw case example number 1. So he presented with cyanosis and grade 4 clubbing, and he was being seen by a cardiologist and pulmonologist. So he did not directly come to a hepatologist to say that I'm having Abernethy malformation. Whereas case 2 was being managed by pediatricians and psychiatrists, and it took a lot of time in diagnosing the problem. We had cases about 10. We are not able to present it because number is still small. So we joined along with a group, and this was published as part of this large group. So where they have noticed different patients, they were examined. Some of these patients had developed hepatocellular carcinoma. Shunt closure was done in about 15 patients. And what they have noticed is over a period of time, these patients can develop complications. Abernethy malformation per se may not cause problem, but the complications can be of significant issue. And shunt closure should be considered. That was the recommendation from this large study. So just to summarize, in congenital portocaval shunt, we saw a delay in the diagnosis, mainly because it's a rare condition, and the symptoms what these patients have may be overlapping with many other common conditions. The patients may be going to different departments who are not related to this kind of problem. So just to address that, summarize that, this is an abnormality which presents, and we have to be aware of this condition. And I sometimes keep wondering what is the difference between the shunt, which is naturally present, versus the shunt what we create as tips. Both are functionally similar. These shunts do not close on their own, they keep growing. Whereas the tip shunt when we create, which is functionally similar, over a period of time, they get closed. Thank you very much for your attention. I have some time for discussion.
Thank you, sir. Very nice demonstration of cases. Now house is open for any question. No any question for house, then sir, I want to, any experience of occlusion of shunt in type 1A or B with creation of tips? If patient is not having intrahepatic portal radical, you have any experience of closure of shunt with creation of one artificial shunt?
Yeah. So this is an important question. What if it is purely type 1 and there is no intrahepatic portal?
Controlled shunt creation with uncontrolled shunt occlusion.
So far we have not seen a condition where there is no existence of portal vein, because the existence of portal vein inside the liver is very important. And if somebody has got the experience, kindly share. So whenever, in these 10 patients, whenever we attempted to demonstrate some part of portal vein, intrahepatic, we could always see. Sometimes there could be as thin as a pencil line or as thin as a hair, but they grow over a period of time once they are put under stress and we block the shunt.
I want to add something, sir. In our institute, ILBS, we first we plan biopsy in one type 1 or A and B, liver biopsy to confirm that it is not showing any portal radicals. If biopsy in imaging not show, but biopsy shows some small portal radical, we give chance to occlusion of the shunt.
Yep.
With consideration of transplant, a patient underwent some. So if biopsy show small portal radical, then there is chance of development of portal radicals.
Yeah, I think that's a good idea. I feel that type 1, which was discovered originally, that time we did not have much access for imaging. That could be the reason why the type 1 idea was introduced in this classification. We also did biopsy in some of the patients, and we measured HVPG also, those in the initial cases. Subsequently, we are directly demonstrating the intrahepatic portal radicals.
Sir, one technical question. What is the largest size shunt you have occluded? Like we have plug up to 22 millimeter, but like sometimes shunt can be larger. So any patient you have sent for surgery or where intervention is not possible?
Correct. So up to 22 millimeters we have occluded. And especially the ones which are got a long length and of any diameter up to 22 millimeter, we used amplexer plug and blocked. And diameter more than this, as the diameter becomes large, perhaps surgical occlusion is better, because these embolic materials are difficult to get in that range, and suddenly they should not migrate and get dislodged from that place. So that is a concern. And similarly, if the shunt is very short, like the ductus venosus type what we saw, perhaps surgery is better because it will give a long-term safe option. As far as possible, we do not want to keep any embolic material in the normal veins, normal vessels. Whereas in this abnormal connection, whatever you place, anyway it is going to be occluded.
Sir, one question, sir. Sir, if a congenital portosystemic shunt is diagnosed during the infancy or up to 2 years of life, should we give a chance of spontaneous closure, or should upfront treatment be considered?
Okay, I do not have any experience of identifying in the internatal life. Have you come across any case like that? You have anything to share?
Yes, sir. Actually, we had 2 cases with the age group of around 8 months and 2 months. So in that age group, we checked up the data and they said that up to 2 years, there is reported incidence of spontaneous closure. And so a watchful waiting, if the shunt is not leading to any cardiovascular compromise, it can be considered.
Okay, okay. That'll be fine. Perhaps at birth, some change in the hemodynamics can take place. This is what I'm thinking when you're, as a response to your comment.
Thank you very much, sir. That was a wonderful talk, I think. Thanks everyone for this lovely session. Thank you.
Thank you, doctors. We move on to the next session. It is about portal hypertension miscellaneous. I request the chairpersons, Dr. Bhanu V. Pillai, Dr. Jacob Philip, Dr. Joseph John, Dr. Jasim Koya, and Dr. Saloni Desai on stage. I request the presence of the speaker, Dr. Uday Kumar Mari, to talk about radiological management of sinistral portal hypertension.
A very good afternoon, everyone. I'm Dr. Uday Kumar, IR consultant at AAG Hospitals, Hyderabad. At the outset, I would like to thank the organizers, especially Dr. Rajesh sir, for this wonderful opportunity to participate in this conference. So I'm going to talk about radiological management of sinistral portal hypertension. So I've divided the talk into the following headings. First, the definition, what is sinistral portal hypertension, the etiopathogenesis and management options, role of interventional radiologist, and finally a brief note on how we approach a case of sinistral portal hypertension. So sinistral portal hypertension is defined as splenic vein occlusion leading to formation of isolated gastric varices. It is also known as left-sided portal hypertension or segmental portal hypertension. It is a rare but serious cause of upper GA bleed. It contributes to less than 5% of portal hypertension cases. It is important to distinguish that it is a separate entity from cirrhotic portal hypertension. In contrast to cirrhotic portal hypertension, portal venous pressures and liver functions are normal here. So coming to the etiology, because of the close anatomic relation between the spleen, splenic vein and the pancreas, pancreatitis is the most common cause of sinistral portal hypertension, contributing to more than 2/3 of the cases. The other uncommon causes include pancreatic neoplasms, pancreatic surgeries, splenic vein aneurysms, and renal masses. So coming to the pathogenesis, this is a schematic diagram showing the portal circulation and two important collateral systems arising from the splenic vein tributaries. One is between the short gastric vein and the left gastric vein, and the another one is between left epiploic vein and this SMV. Both of these collateral systems run through submucosal veins of the stomach. So whenever there is outflow obstruction to the splenic vein, the venous outflow from the splenic parenchyma redirected into these collateral systems, resulting in increased pressure in these collateral systems and formation of the gastric varices. So how do these patients present? The majority are asymptomatic and diagnosed incidentally. Among the symptomatic population, the most common presentation is acute or chronic upper GA bleed, and less commonly they can present with pancytopenia associated with hypersplenism or splenic pain. So how to treat them? So since the patient is presenting with upper GA bleed, the first step in the management is to do endoscopy. Endoscopy helps us in diagnosing the gastric varices as well as tiding over the acute crisis of active bleed with glue injection or coiling. Patients who fail to respond with endoscopic management are usually sent for splenectomy. However, splenectomy is associated with several complications like high operative morbidity, unfavorable operative field due to previous pancreatitis, and decreased immunity after splenectomy makes these patients susceptible for life-threatening OPSI infections. So to avoid splenectomy and its associated complications, in the recent years, intervention radiology has come up with few minimally invasive spleen-sparing endovascular alternatives. So what are they? So two most commonly performed techniques in cirrhotic portal hypertension are TIPS and BRTO, but these two are not useful here because the portal venous pressures are not elevated and the varices which are formed are portoportal and usually there is no portosystemic shunt here. So what do we do? So these are the three endovascular alternatives to splenectomy. The first is splenic artery embolization, variceal embolization, and splenic vein stenting. So let us see these interventions one by one. The first is splenic artery embolization. So the principle of splenic artery embolization is essentially the same as splenectomy. In splenectomy, we are removing the spleen so that there is no flow into these collateral systems. In splenic artery embolization, we are embolizing part of the splenic parenchyma so that significantly reducing the flow into the collateral circulation and decreasing the pressure in these varices, thereby decreasing the risk of bleeding. So there are two types of splenic artery embolization, partial and proximal splenic artery embolization. For sinistral portal hypertension, we usually use partial splenic artery embolization. So what is partial, what is proximal? The first one, partial splenic artery embolization is embolization of part of splenic parenchyma using particulate or liquid embolizing agents. There are several ways to go about it. About 30 to 80% of the parenchyma is usually embolized. Sometimes we do it in one go, and sometimes we do it in a staged manner to decrease the complications. And there is a debate about lower pole versus upper pole embolization. There are advantages and disadvantages to the both. Finally, it comes down to the operator preference. So this is an example case. On the coronal MIP images, we can see the splenic vein is not seen. There are multiple gastric varices here. So we planned splenic artery embolization. This is the pre-embolization delayed phase splenic angiogram, and this is a post-embolization. We embolized it using 300 to 500 micron PVA particles. On the post-embolization splenic angiogram, we can see about 80% reduction in the parenchymal blush. And this patient showed very good response on endoscopy. 3 months after the procedure, we can see there is complete disappearance of the varices. Another interesting finding here is this case highlights the importance of diagnosing this entity, because this patient was treated elsewhere before, 1 month back, where they diagnosed it as cirrhotic portal hypertension and placed a stent. Obviously, patient did not respond to the tips, so he was referred to us. The second, the same procedure can be done with glue embolization. Usually we use 20% glue here. The only advantage of glue is the procedure becomes much faster with glue. The second one is proximal splenic artery embolization. The advantage of using proximal splenic artery embolization is it is associated with less complications like abscess, rupture, or post-embolization syndrome. But the anecdotal evidence suggests that doing proximal splenic artery embolization is less effective, and it increases the rebleeding rates compared to the partial splenic artery embolization. Here, we usually use coils or Amplanzer plug. We place them after the origin of all the pancreatic branches. So what are the advantages of splenic artery embolization? It is technically easy. It can be done in all patients of sinistral portal hypertension without any difficulty. And apart from helping us in gastric varices, it also helps us in hypersplenism-associated pancytopenia. And what are the disadvantages? It can result in complications like splenic abscess formation, and the reported rebleed rates vary very widely, 0 to 50%, and a commonly encountered post-embolization syndrome. So coming to the second technique, that is variceal embolization. The anatomy on CT photogram is very important to plan this procedure, because you need access into the varices, either from the afferent side or the efferent side. So the embolizing materials commonly used are sclerosant, glue, and coils. So the advantage of this procedure is it gives better control on the bleeding. Why? Because we are directly addressing the varices, and there is no post-embolization syndrome here. The disadvantage is it is associated with puncture site bleeding complications. So here is an example case. These are the coronal MIP images. We can see the splenic vein is not seen. There are multiple dilated gastric varices here, and we can see one collateral which we can use as an access to enter. So ultrasound guided puncture of the intrasplenic vein was done, and with using catheter and guide wire combination, we entered into the collateral, and we embolized the collaterals and the varices using 20% glue. And we always do a non-contrast CT scan after the procedure to confirm that all the varices were covered. This is again similar case, but this patient did not have access from the splenic side, but he had access from the portal side. So ultrasound guided puncture of the portal vein was done. We entered into the coronary vein, which was the access. And since we are injecting the contrast from the efferent side, we need to close it using the balloon, just like BRTO. So after closing it, we embolize the entire varices using a cetrol sclerosant mixture. So the third intervention is splenic vein stenting. We can do it using transhepatic, transsplenic, and sometimes using transjugular route to decrease the bleeding complications. So after placing the stent, it significantly diverts the flow through the normal splenic vein, so that reducing the pressure in the gastric varices and decreasing the risk of bleeding. So this is an example case where this patient had a short segment splenic vein stenosis. This is a splenic venogram which was taken after transhepatic access, and there were multiple collaterals which are supplying the enlarged gastric varices. So this is a 10 into 40 mm bare metal stent was placed here. After stent placement, the splenic vein shows normal flow with complete disappearance of the collaterals and the varices. So the advantage of splenic vein stenting is it establishes the normal hemodynamics in the portal system. But the disadvantage is it is associated with puncture site bleeding, it has low technical success rate, and it is not possible in occlusions involving splenic vein tributaries at the hilum. And there is concerns about the stent patency rates and requirement of long-term anticoagulation. So which one is the most effective? What does the evidence say? So these are the several recent studies on splenic artery embolization. They reported the rebleeding rates ranging from 0 to 10.5%. And the major complications were seen in about 14%. And these are some recent studies on splenic vein stenting. The first two retrospective studies suggested that the failure rate was from about 27 to 40%. And none of the studies showed rebleeds. The study by V et al. Is the only study which compared two endovascular techniques. They compared splenic vein stenting with partial splenic artery embolization. The rebleeding rates were significantly less in splenic vein stenting group. It was 7.1%, 47.8%. However, this study results need to be interpreted very cautiously because the reported rebleeding rates after partial splenic artery embolization were significantly higher compared to the rest of the studies. And they have not explained their technique very clearly in their study. So in overall, there is inadequate evidence to draw any conclusions or formulate recommendations. So how we approach a case of sinistral portal hypertension? If the patient is an acute bleeder, the first step is to do endoscopy for diagnosis as well as to tide over the acute crisis. All the stable patients suspected of sinistral portal hypertension will undergo triple phase CT abdomen. And the anatomy on CT photogram determines what is the next step. If the occlusion is not involving the splenic vein tributaries, a splenic vein recanalization plus stenting is considered first. If it is not feasible or unsuccessful, then gastric varices are accessible through the transsplenic or transhepatic route, then variceal embolization is considered. If the afferents and deferents are too small and not accessible through percutaneous routes, then partial splenic artery embolization is offered. And however, if the patient at the initial presentation, apart from the gastric varices, he also has hypersplenism and pancytopenia, then splenic artery embolization is the first choice. So to conclude, upper GI bleed plus splenomegaly plus normal liver functions, we should suspect sinistral portal hypertension. It is important to differentiate it from cirrhotic portal hypertension to avoid unnecessary workup and procedures. And there is limited literature on the topic, and there are no clear guidelines on the management. So this was the pre-endovascular treatment algorithm of these patients. With the emergence of several minimally invasive endovascular technique, now IR has and continue to play a very important role and in avoiding the splenectomies and associated complications. Thank you.
Thank you very much, Dr. Yes. Any questions from the floor?
Any questions for him?
This is quite an exciting thing. May I know, in your center, since you are a very high volume center, how many cases you have encountered where you could actually do splenic vein recanalization or stenting?
Sorry, sir, I didn't get your question.
I will repeat it. Since you are a very high volume center, my question is how many cases you have encountered and you were successfully able to recanalize the splenic vein or stented?
Sir, in last 5 years, we did about 5 cases. It is very rare to get these cases, sir, because most of them are asymptomatic.
True.
To begin with, it's a rare entity, and many of them are asymptomatic. And if some cases were diagnosed on endoscopy, usually they do glue injection and coiling, and they don't send for IR management. So we have seen in last 5 years, 5 to 6 cases.
That's a good number, given the thing that it is a novel thing, and there is very little education about it.
Yes. And none of the cases had short segment involvement. All the cases had involvement of the splenic vein tributaries as well. So none of the cases we did stenting. We did only variceal embolization and splenic artery embolization.
Okay.
Thank you, doctors. Yes. Thank you. I request the next speaker, Dr. Rakesh Kumbar Adi, to please come on stage to talk about bleeding junctional varices and endoscopic quandary.
Respected Chair, seniors and colleagues, a very good afternoon. At the outset, I would like to thank the organizers for the kind invite, and also I want to congratulate them for such a standout event. And I'm sure yesterday you had quite a extensive discussion about the gastric varices. So today they wanted me to talk about something slightly offbeat, that is the junctional varices, and how are they an endoscopic conundrum. We all know that, variceal bleed, although in the last 2 decades there has been a significant improvement in the treatment modalities for addressing this issue, but still variceal bleed is still probably the most serious complication of the portal hypertension and the chronic liver disease. If you look at the gastric and the esophageal varices, although the gastric varices probably are less in incidence compared to esophageal, probably you can say the general rule that 1 out of 5 of your cirrhotic patients usually have gastric varices. And most of these gastric varices, they tend to have a less incidence of bleed when compared to esophageal varices. But when they do bleed, they usually have very serious and a severe blood loss, poorer prognosis, higher rebleeding chances, and of course, usually associated with quite a high mortality. And in spite of all the treatment modalities that we have been discussing yesterday and today, the rebleeding rate from gastric varices has been noted to be as low as 10 to as high as 40%. So needless to say that whenever we have these gastric variceal patients in our endoscopic room, I think most of us are on the edge given the high chances of rebleed. Well, Dr. Sarin's classification has stood the test of the time. It's been more than 3 decades, and his classification is probably the most widely accepted and used system. It's recommended by almost all the hepatic societies and the Baveno guidelines. The reason being that it's very easy to use, has a good correlation with the pathophysiology, and in most of the time it guides the therapy appropriately. And as we are all aware, they are divided into gastroesophageal GOV1, 2, IGV1 and IGV2. So what I am interested probably to discuss today is about GOV1 and how they are similar or dissimilar with the junctional varices. A little bit about the management. As we have all, we started endoscopic therapy as a primary modality. It started with sclerotherapy. Then we moved on to, glue injection. And then of late, we have a lot of EUS-guided glue and coil therapy going on. But right from the morning, we have been seeing the interventional radiologists coming in a big way. And the IR-based therapies, the balloon-occluded transvenous obliteration or the coil-assisted or the plug-assisted, have been really changing the way how we treat these patients, and they have significantly improved the treatment outcomes and reduced the rebleed significantly. And apart from that, the tips and the antegrade obliteration has also been very effective. So what has happened in the last 2 decades is that there has been a better understanding of the spontaneous portosystemic shunts. And with these deeper anatomical insights, now we are able to plan in a better way using our interventional radiologist's opinion. We can offer the patient a better treatment modality. So unless your patient is having an active variceal bleed, where obviously endoscopic therapy in the form of glue and coil helps you. But in other cases where your patient is relatively stable, I think before you contemplate to offer a patient a treatment, either endoscopic or interventional radiology-based therapy, I think what we need to do is that we need to assess 3 things. The first thing is try to locate your gastric varices, whether it is GOV1, 2, IGV1 or 2, and then if possible, using a good CT, try to find out what is the inflow tract and what's the outflow tract. I think this is very important for us, is that because now more and more we are doing US-based coil and glue. And if you know the literature, the GOV2 and IGV1, 80% of them, they are associated with a significant gastrorenal shunt. So if there is a big shunt that is patent and you end up giving a glue and a coil, there is always a big chance that you might end up embolizing it. So I think the current treatment for gastric varices, unless the patient has come to you with the acute variceal bleed, I think you should take time, get a good CT, understand the inflow and the outflow track for the varix, and then decide the appropriate line of management. So taking this cognizance, I think the standard classification of Sarin sir falls short on this aspect. So now we have more and more hemodynamic classifications coming up in big way, especially the SAD-Cadwell classification, which is very useful in planning the best treatment modality to be offered to these patients of gastric varices. Now coming to junctional varices, well, the first note of these junctional varices was done probably way back in 1990. I think this was the same time when Dr. Sarin sir was coming up with his classification. And then back then, the only treatment modality available was sclerotherapy. And it didn't have a great results for gastric varices. So Dr. Korulan et al., they followed up their patients of gastric varices over a period of 7 years. And what he did was that he divided his gastric varices into simply two categories, type 1 and type 2. So any gastric varix that on the lesser curvature side, just below the GE junction, he labeled them as junctional varices, and anything on the fundic side, he labeled them as type 2 or the fundal varices. So this was Dr. Korula's observation. So anything on the lesser curvature, he labeled them as type 1, anything on the fundal side as type 2. So the observation was very important at that time because he proposed that patients who had junctional varices, probably they responded well to sclerotherapy, unlike the fundal varices. So this was the classification back then, but very soon we had the Dr. Sarin's classification, which led to the, this particular classification going out of vogue. And then, of course, the glue injection became a big thing, and we were able to tackle more and more of these fundal varices endoscopically. But then, sometime later, people wanted to know whether glue is the only best modality to answer these gastric varices. So herein comes a very good paper from Egypt, wherein they followed up more than 150 of their patients over a period of 2 years. So what they did is that first they decided to define what are junctional varices. So they said that any gastroesophageal varices type 1 that is extending 2 to 5 centimeters beyond the GE junction on the lesser curvature, it constitutes as the junctional varices. So what they did is that they randomized all their patients of junctional varices into two groups, one receiving the banding and the other receiving the glue injection. And they followed them up. So what they found is that traditionally, it's always thought that if you have a gastric varix, glue is the treatment of choice. But this paper or the authors propose that, if you have junctional varices or the GOV1 type, varicose obliteration can be achieved with equal efficacy with banding as you can do with a glue injection. And also they reported that probably the number of complications when using the banded treatment for the gastric varices on the GOV type 1 was much less when compared to the glue injection. So this was their paper, and they said that there was no major difference in the mortality rates. So they went on to sum up that banding for the bleeding junctional varices, that is type 1, is as good as the glue injection. And also they reported that the complication rates are much less when compared to the glue injection. So this was one interesting paper that came across. But the important point here is that, is it that easy to put a band on a gastric varix when compared to the glue? Because we're all used to using glue injection as a therapy for gastric varices. Well, putting a band has its own challenges. Unlike the esophageal mucosa, the gastric mucosa is very thick, so suction may be very difficult for us. The varix size may be very big sometimes, so getting into the suction, into the hood of the EVL channel may not be possible always. And the overall high rate of rebleed and reappearance is very high if you are using EVL. That was the reason why in the previous paper, the authors required more sessions to achieve complete obliteration when compared to the glue injection. So what we can probably say is that if you have a junctional varix or GOE1 type of varix, and if you're trying to use band as a modality to treat them, maybe anything less than 2 centimeters might be the ideal choice. And if it is more than 2 centimeters, probably a combination of band and glue might offer you a better success compared to either of it alone. And why junctional varices have become little more important for us, I think this was a paper that has shown that the unique thing about junctional varices is that there is a high tendency for them to rebleed. Like this paper again from Egypt, again they followed up there more than 170 patients, and the first thing they noticed was that junctional varices are very common. They are seen in 50% of the patients, and the rate of early rebleed and the total incidence of rebleed is very high when compared to the other type of fundal varices or the gastric varices. So the authors of this paper went on to say that probably junctional varices have a significantly high rate of rebleeding. And the other important observation they made was that the blood flow at the Z junction can be bidirectional. That is, a obliteration of the esophageal varices doesn't necessarily mean that the GOE1 or the junctional varices will disappear. You need to treat them as you keep treating the esophageal varices. And of course, this is another good paper. I think this is from Dr. Abe and Dr. Rizwan and Dr. Rajesh. I think it's the residents out there. I think this is a very comprehensive paper which actually tried to look at the gastric varices more, keeping the hemodynamic circulation into view. I think if it's a good read, if you have time, just go through it. Even they propose the same thing. If you have a bleed from the gastric varices, if it is GOE1, banding is as good as the glue injection. And if you have a rebleed, I think you should do a good CT, understand the varix, efferent and afferent pathways before you offer the next modality of treatment. So you might be wondering at the end, what am I saying? Am I saying the GOE1 and junctional varices are different, or are they similar? So although anatomically GOE1 and junctional varices, they fall in the same bracket, what some authors and experts are trying to emphasize is the fact that junctional varices can be given enough stress in certain unique situations. For example, if you have a patient who does not have fundal varix, and you have successfully irradiated all his esophageal varices, and if the patient keeps coming back with a rebleed, I think these are the subset of patient where you should diligently look for the junctional varices, which might be the cause why he is having rebleed. And as I already mentioned, most of the time they are very small, multiple, so the chance that you keep missing them and assume them to be a gastric fold. And as I've already mentioned, recurrent bleed is also something that comes along with these junctional varices. So when it comes to managing these, the previous 2-3 papers which I've mentioned have clearly shown that banding is as good a treatment modality for them as the glue injection. And if you have a larger junctional varix, probably a combination therapy might give you a better option in treating them. I would be probably interested to have the inputs of the organizing team who have done the last paper which I have just mentioned on the same topic. Thank you.
Thank you, Dr. Rakesh. So you recommended band plus glue injection for junctional varices. So which one first? How do you go? So how is that recommendation? Is it which you band first or then glue? You recommended band plus glue injection.
Sir, if you are coming across a big varix, I mean, if you feel that the varix is more than 2 centimeters, where you feel that, your band is not sufficient to suck the entire varix into the wound, I think doing a glue injection first might be a better option, sir. And the remnant, whatever is left out, can be taken up with the band.
So it's generally understood that band causes early rebleed, more of early rebleed than glue, and more sittings to eradicate the varices. So that's true about junctional varices also, no? In gastric varices.
Sir, I think the point which we wanted to bring forward is that, as I mentioned that, junctional varices have a high tendency of being missed during routine examination. 2, and because they have a high chance of causing rebleed, and we tend to miss them a lot, that's probably the reasons why, you should be giving extra focus to them.
So only the varices along the lesser curvature are called junctional varices, or can it be close to the G junction on the greater curvature also?
Sir, if you look at the definition that has been given by few of the authors, they have clearly mentioned that any varix that is below the Z line, extending not more than 5 centimeters along the lesser curvature. Anything on the greater curvature on the fundal side will assume to be as fundal varix.
Thank you all.
Thank you.
Thank you.
We move on to the next session, and that is the last session. It is a case-based discussion about HCC. I request the chairpersons on stage, Dr. Sanju Suryak, Dr. Harikumar Nair, Dr. Sunil Matthew, and Dr. Praveen Singhal. I also request the moderator, Dr. Charles Panakil, and the panelists, Dr. Sudhindran S., Dr. John Menacheri, Dr. Abhishek Bansal, Dr. Dayanand Lingagowda, and Dr. Jos Paul to please be on stage.
Good evening all, and thank you Philip sir and the RAJAGIRI team for this opportunity. And I have my esteemed panelists with me, and they need no introduction. So I go forward directly to the case. So we discuss a case of a 64-year-old female with type 2 diabetes, coronary artery disease, who's post-PTCA. She was diagnosed of NAFLD in 2016, and she presented with abdominal pain of 3 days duration. Ultrasound done in the local hospital showed a coarse liver. There was a SOL of 3 centimeter with segmental portal vein thrombus. There was no ascites, and she was advised a cross-sectional imaging. And this is a CT that was taken in the local hospital and followed by an MR that was done. And Dr. Abhishek, what would be your diagnosis after looking at the CT and MR?
Right. So on a background of clinical history and imaging, so this definitely looks to be a sinister, I would say, malignant mass. And we have a triple phase imaging in front of us that shows a abnormal arterial phase hyperenhancement and some venous washout as well. And we also see a streak of enhancing tumor going along a segmental portal vein, the right posterior one in this particular case. So based on these findings, I'm pretty sure I would put this as LR5 or a upfront HCC in terms of.
And what about the portal vein thrombus? How do you differentiate a tumor thrombus from a bland thrombus? Do you think it's a tumor thrombus here?
Right. So that's a very good question, rather, and that's a question that all the radiologists face day in and day out. So I think the tumor thrombus would be the one that would be more enhancing. Rather, that would be the one that would be enhancing. The bland thrombus would not be an enhancing thrombus. Also, you can see the vein being overly dilated and some ragged margins of the vein. So those are the indicators towards a portal vein thrombus. Also, if you get a PET CT done, the portal thrombus will show PET uptake and bland thrombus will not show the uptake. So I think these are important markers where we can differentiate how a tumor thrombus looks like from a portal vein thrombus, a bland thrombus.
Yeah. Nowadays we are doing more and more MRIs for hepatocellular carcinomas, and as clinicians we see chemical shift imagings and diffusion restriction. Can you just explain something on that?
Right. So these newer sequences help a lot in terms of narrowing the differential diagnosis. Chemical shift imaging, especially the in-phase, out-of-phase imaging, is very important in terms of, we know the LARET's criteria in the 2017 incorporated in presence of intracellular fat as one of the ancillary findings for labeling is at a LR5 finding. And so whenever we do a in-phase, opposite phase imaging in the chemical shift imaging, if there is a presence of intracellular fat or lipid, it will show suppression on the outer phase imaging. And that can actually help in differentiating between malignant tumors, liver per se, from HCC from other malignant tumors in the liver. So that is one of the important findings. If you're able to find fat and that suppresses on the outer phase imaging, that's a very good indicator towards HCC. And yeah, so just one more sense. So in terms of diffusion imaging, personally, it's a very good marker in terms of assessing the extent of the tumor, especially for the infiltrative HCCs. We have seen that whenever we see a HCC on a CT or MR on contrast imaging, doesn't look like to be really invading, but moment you see it on DWI sequences, you would see small micro nodules in the entire liver or scattered micrometastases, and even a lot of infiltration going into the surrounding parenchyma, and especially patients who can't undergo contrast imaging. So those are the patients in whom diffusion imaging helps a lot. And not just that, for diagnosis, even for prognosis and even for treatment response. So I think all these sequences play a big role in terms of diagnosis, prognosis, and treatment assessment for HCC.
Thank you. And Dr. Sudhi, you're the transplant surgeon
No, I
from
just want to
Amarga.
ask a question actually. So as surgeons, we find CT is much more easier to read than, but I mean, from a radiologist point of view, which one has got more sensitivity? What would you prefer between a CT and MRI?
So definitely MR scores over CT in a lot of factors where you can play around with all these sequences like chemical shift imaging diffusion. And as I told, especially for infiltrative HCC, I think MR is a game changer. And especially when we look for venous thrombosis, many times on CT we see some attenuation differences in terms of contrast enhancement. So I think that's where MR plays a big role. And even for response assessments, especially if you go for example, I think I'm overshooting the discussion, but if you go for lipidol taste assessment, I think MR scores big way over CT.
One small point for tumor thrombus was the AFP and PIFCA markers. They're high, they're more likely to be tumor thrombus.
Yeah, right. Thank you. And Dr. John, as a hepatologist, are you happy with the radiological diagnosis? Because most other tumors, you need a biopsy proof. If you take any other tumor other than HCC, you need a biopsy proof. Are you happy with the radiological diagnosis? Would you biopsy in any situations?
No, Charles. I would accept that, and I wouldn't go for a biopsy because according to the guideline statements, if you can confidently diagnose on CT or MR, if it's an LR5 lesion, then you don't need a biopsy. You only do biopsies if there is a non-cirrhotic background. NAFLD can cause HCC without cirrhosis. And in case of LR4 observations, ASLD advises either follow-up imaging or biopsy. So if you have to make an immediate treatment decision, you may go ahead with a biopsy.
Yeah, thank you. And how do you stage this patient in your practice?
Well, you got a lesion here and you got macroscopic portal vein involvement. So according to BCLC, he goes straight away into stage C, advanced. In INASIL classification, it again subdivides into C1 and C2. Assuming that there is no distant mets, we would say it is C1 according to INASIL and according to BCLC, C stage, advanced.
Hari, as a hepatologist, what would be your choice for classification? Do you go by BCLC or would you go by the Eastern classifications, which are more liberal in choosing treatments?
Well, you mean whether I go by INASL or BCLC?
Yeah.
Well, BCLC traditionally I think is designed by oncologists, isn't it? Honestly speaking, we can go beyond all these. An individualized decision can be taken for a patient, even bypassing this.
And Dr. Sudhi, would you agree with that? Do you think BCLC is too restrictive and you go beyond?
Definitely, because particularly the last bit, where a child sees status, they straight away treating it as a palliative thing. And if you read deep into it, if you read the small lines, they do say you can go to transplantation. But that forms a major part of our patients who need transplantation. Child C patients, so it needs. I think even the upgraded version also needs. The INASL classification is actually much better that way. I think they really fine-tuned it much better.
So the INASL has tried to club what is best of East and West and to come out with a better staging. But again, that also needs further modifications and refinements. So coming back to the case, this lab parameters, she had childless cirrhosis, AFP was 9,047, the PIPCA was 2,064. She had a high AFP and a high PIPCA, and OGD showed grade 1-2 varices, 3 columns. And we did a PET, which showed a single lesion with segmental portal vein thrombus that was petavid, and maximum SCV was 5.6, favoring more in favor of a tumor thrombus. There was no extrahepatic disease. So, Dr. Sudhindran, in this patient, would you consider any surgical treatments? Would you consider resection or transplant here?
So resection, I think that the varices suggest there is portal hypertension. And that, I think it's a significant criteria because for our patients, they don't withstand resection as to other patients. If it's hepatitis B, then they may actually do better. But otherwise, NASH-related cirrhosis, elderly patients with esophageal varices, we very rarely do resection these days. But nowadays, because of laparoscopic and robotic thing, if it's a very easily resectable lesion like in segment 5 or 6, which is exophytic hanging out, which can be done like in 1 hour, then we may do it. Otherwise, we do not consider resection. Transplantation, because of vascular invasion, we will not do straight away. We won't do it.
So, would you consider downstaging this patient, the segmental portal vein thrombus? Would you consider downstaging and do a transplant in your center, or you would outright say no?
We'll definitely try downstaging. How many of them will reach transplantation? I think very few numbers, but we'll definitely try.
So, any patient with extrahepatic mets of portal vein thrombus is a contraindication for a transplant?
Yeah, yes.
Thank you. And Dr. Dayanand is an eye specialist from Mumbai. You've seen the MR and you've seen the portal vein thrombus. In your practice, how do you classify portal vein thrombus? And does the classification matter in the choice of treatment as well as the prognosis?
Yeah, portal vein thrombus play a very critical role. Actually, one of the criticism for like BCLC is actually oversimplifies the BCLCC. Actually, it is very heterogeneous group, and it is not looked into the details of the degree of portal vein thrombosis. The portal vein thrombosis can be divided into V1 to V4. V1 is a subsegmental, and again to V4 is a main portal vein thrombus, the main portal vein. So V2, V3 is the right portal vein thrombus, and V2 is actually again the portal vein thrombus segment to segmental segmental veins. This is not just an anatomical classification. Actually, its impact is great. Like a V1 can, the survival maybe varies from 33 months to V4 is somewhere in 2 to 3 months. Or it can be a single group according to BCLCC. This is the major criticism. This is a very heterogeneous group, and I think who are treating these SCC should look into this, what is the degree of portal vein thrombus, and it greatly impacts the what is the treatment decision taken. And also, like can go to next slide. Like this is the survival difference. Next slide, please. So because the BCLCC simplifies this, so that also there is created a confusion in the therapeutic recommendations from various groups. So there is some associations still considers considers the heterogeneous groups and give a lot of scope for other treatment other than this just systemic therapy. This is a very confusion area, require a lot of improvement, lot of subclassifications. That is my take.
And Dr. Sudeep, suppose there was no portal hypertension here. It's a 3.6 centimeter lesion with a segmental VP1, VP2 portal vein thrombus. Would you consider resection?
Cirrhotic patients,
non-cirrhotic. No, even if it's cirrhotic, no clinically significant portal hypertension.
Cirrhotic patients, child A without portal hypertension, I still wouldn't, because I think the risk of recurrence is very, very, very high. So unless they really push for it, we will not do it.
Yeah, thank you. And Dr. Abhishek, you've seen the case, and now Dr. Sudhir doesn't want to do a resection. There's no option for transplant. What treatment modalities would you consider here in this patient?
So this is a very good candidate for local regional therapy. We can do transarterial therapies, and because it is I think a VP1 and a VP2 invasion, so we can even do a TACE also in this patient. But a very high segmentectomy sort of a dose can be given through TARE also in this particular patient. So I think both options are suitable. TARE will definitely score in terms of giving a better tumor response even into the venous invasion, and I think for a better surgical options at a later date. Otherwise, TACE can also be very easily done in this particular patient without really harming the normal liver parenchyma. That would be my take.
What would be better, TACE versus TARE, which would give a better curative?
So TARE will have a better loco-regional control, and there's good enough data now that suggests that post 590, especially with the tumor in vein appearance, it is got a better loco-regional response and a better number of patients reaching to transplant or to resection at a later date. So I think as a bridge to transplant, TARE scores much over TACE.
And in your center, how do you select patients for TARE, and what are the prerequisites that are needed before you select a patient for TARE?
Yeah, so I think the gist of it has been laid down by Dr. Dayanand, whereas it is when he's talked about a heterogeneity of the group of BCLCC. But yes, there are certain parameters that we need to look into account before opting a patient for TARE. One is a child PUA status is something that I would prefer for a patients, and if not, then early B also, but not, I would be skeptical in taking patients late B or C, definite no for C patients. So I think ALB score is being talked about a lot these days, and even the bilirubin level of, I think, less than 2 is something that is found, that is being followed across the guidelines across the globe, where you would want to choose these patients for TARE. But in this particular patient, because it is still towards the periphery, so I would be okay even if the bilirubin level is up to 2.5, I would be okay in doing a TARE for this patient. Otherwise, child PUA and early B status is one of the major prerequisites offering a patient for TARE. Apart from that, we all know that we have to do a planning scan with a surrogate of Y90, which is a macro aggregated albumin, because we know eventually the lot of dose will go through the lungs and may cause radiation pneumonitis. So lung shunt fraction should be less than 20%, and in one sitting we don't want to go beyond 30 grays for the lungs, and an overall cumulative dose of less than 50 grays in the overall lifetime of the patient. Also, during the planning scan, I would want to rule out any extrahepatic supply, as well as coil or block any collaterals that may be taking the supply outside the liver. Maybe this is in the right lobe in the periphery. I'm not much worried about the extrahepatic supply, but we have to go through it in detail. So those are my planning scan is the one that is very, very important, where I think all the hard work goes for planning a patient for TARE.
Dr. Dayan, do you want to add anything on TARE? Do you do anything differently? Do you go beyond child status or CTP of 8 or bilirubin of 2?
Actually, I look into imaging. There are some features which shows the aggressiveness. There may be 3 centimeter lesion or 2 centimeter lesion, which is an infiltrative type of appearance, or it is not enhancing. Even though it's by category wise, actually we are tempted to use the RFA. They are showing that there are features which shows that these aggressive lesions which require a bigger, a stronger modality, which like probably like something like a mimic the surgery, something like a radiation lobectomy, radiation segmentectomy, all kind of symptoms. We need to not just anatomical thing, we need to look into the more detail into the how it's appearing, whether it's looking aggressive or it is not looking aggressive. These features also to be taken. So that's why now TARE is coming into role of BCLCA, also BCLCB, now also BCLCB. Initially started with BCLCC. Now people are more and more using, because of we are trying to diagnose more and more aggressive lesions which not amenable for the so-called the initial recommended treatments.
Yeah, thank you. And Dr. Jose is our radiation oncologist at RAJAGIRI Hospital. And Dr. Jose, you heard about TARE, and one of the new modalities that is coming up in a big way is SBRT. So do you think this ideal lesion for SBRT, and what's your experience with SBRT in PVTs?
This guy is somebody who's an ideal candidate for SBRT. I mean, small lesion, good child status, portal vein thrombus, somebody who's an ideal candidate for SBRT, and that forms the bulk of SBRT practice nowadays. Now, if you, I don't want to get too much into SBRT, but if you look at the data, Charles, next slide. Yeah, if you look at this particular data, Prince of Margaret data, this was about 128 patients from Toronto, and 87% of them were child day, and SBRT plus sorafenib, the median overall survival was about 18 months, which is previously unheard of. So for patients with MVA, SBRT plus TK has a, I mean, we probably won't cure most of them, except unless we downstage somebody good enough so that they get into a transplant. But otherwise, we will meaningfully prolong the survival for most of these patients. Now, I'll skip the next slide, the slide after. This 2 agitation studies that shows that SBRT is beneficial. Next slide, please. Now, this is a pooled analysis. There's no head-on comparison between SBRT and TARE. So that's one thing which we have to realize. And it's a pooled study which looked at a lot of data. And the local control with SBRT was far better when compared to TARE. Although this patient could also go in for a TARE. There are a lot of reasons to choose between either modality. Next slide. Now, there are 3 studies which showed that the TARE data, the TARE versus TK data, the survivals are similar. 3 randomized studies which showed that the SARAS, sirvenib, and soramic. Whereas, yeah, Charles, next slide. If you look at this randomized trial, RTOG 1112, which has been reported, say about 6 months back. They had about 193 patients, child book A. The median tumor size was about 8 centimeter, and 75% of them had vascular invasion. They were not suitable for surgery or other local regional treatment options. The comparison was between SBRT plus sorafenib versus sorafenib alone, because this was randomized in the pre-immunotherapy era. Yeah, next slide. So there's a median survival improvement of 3 months when compared to sorafenib alone. And if you look at the overall survival, at 24 months you have a 33% overall survival versus 33% versus 23%. So, I mean, there's no head-on data between SBRT and TARE to the best of my knowledge. But if you look at randomized trials, so there's one modality which has shown that it's almost equal to TK, whereas SBRT has shown, at least on a population basis, SBRT has shown a survival advantage when compared to TK alone. So that's where I would put it. It's a relatively safe modality. The risk of decompensation or, I mean, the toxicities associated could be a decompensation or a hollow visceral bleed. The toxicity percentages would be about 5% in a child A patient. Higher, obviously, with a child B patient.
Dr. Abhishek, you wanted to add something? Yeah.
So for this particular lesion, yes, SBRT is a very, very valid option. But yes, when we go for a tumor that is more of infiltrative, and especially for VP3 or VP4 tumors. So practically in our clinical practice, we would want to start the patient with TARE and then supplement with SBRT for the VP4 tumor thrombus, because I think that's the best that we can offer the patient. But in terms of any of the real world practice that we see, a lot of infiltrative tumors, micrometastases, I think those are patients which would be difficult to, opt for SBRT upfront. So that would be my take. So we do a lot of combination therapies in our practice, and we start with TARE first and put the patient on SBRT and then continue further with further treatments.
Jose?
Yeah, see, for most tumors, you look at the RTOG data, their median survival, the median size is about 8 centimeter. For most tumors, we don't need to compare TARE with SBRT. It can be taken by SBRT alone. Now, if you are combining TARE with SBRT, we need to realize that the chance of a radiation-induced liver disease is much higher. So we are taking an unnecessary risk for no obvious survival benefit. So that's where I would put it. The RALD risk is much higher with all reported data when you combine TARE plus SBRT. So you do one modality and finish it off. If you are doing TARE and you feel you can confidently deal with both the PVT as well as the primary, fair enough. Otherwise, SBRT can do it in one sitting without actually combining. So you'll probably combine with TACE if there's a recurrence or those sort of things, but I don't think we'll combine it in a planned manner.
Jose, what Dr. Abhishek was mentioning is if you have a diffuse infiltrative lesion of the liver and VP3, VP4 tumor, you treat the VP3, VP4 tumor with SBRT and the diffuse infiltrative lesion with TARE. That's what you meant, Dr. Abhishek, right? And that's what practice in most of the centers in North are, who take the patient up for transplant. So they would treat the diffuse infiltrative lesions with TARE and the portal vein with SBRT and then take them up for transplant.
Charles, treating the PVT alone with SBRT is something which is actually seen only in our country. If you look at all the international data, they treat both the primary as well as the PVT. If it is a good liver, you can do it quite safely. And one more thing is, HCC does not require an extremely high dose for control. If you look at the Loradosin data, their median dose was only 33 gray, and they still had an 87.5% local control. So for most livers, you would be able to give 33 gray. You don't need to give the sort of 100, 120 or 150 gray which you can give with that. You can do it, but that's probably not actually required. Above 50 gray, the incremental benefit that you will get in terms of local control would be very minimal. And because these patients have a high propensity for systemic metastasis, that incremental benefit, that would be a very minimal incremental benefit in terms of local control. That's very unlikely to translate to a survival benefit.
What about CyberKnife? Is that?
CyberKnife is one of the modalities for delivering SBRT. It's essentially the same. So you can deliver it with a LINAC, you can deliver it with an MR LINAC.
Is it better?
There's no data to show that CyberKnife would be better. If at all there's anything that would be better, that would be an MR-Linac. Because your verification would be far better with an MR-Linac when compared to all the other modalities.
Proton beam?
Yeah, proton, yes, provided they have the finance for it. I mean, it's probably as costly as a transplant.
Thank you. And Dr. Sanchu, you are the medical oncologist in here, and it's advanced HCC with PVT. Do you think the newer immunotherapies, they can do as well as the TARE or TACE with SBRT?
So I think, as you all know, the systemic therapy has evolved over time. Now we routinely use immunotherapy wherever it is feasible, but immunotherapy has got some challenges. One, the main issue is that the financial aspect. So it is extremely costly. For 6 injections, probably costing around 12 lakhs. And the other issue is, as you all know, probably it may not work well in alcoholic or NAFLD patients. It works very well in viral hepatitis related cirrhosis patients. And the third issue what we face is most of our patients will end up with the child B status where they straight away becomes ineligible for immunotherapy. So, but in spite of that, we do see patients responding very well. The only issue is, if you see the trial, the IM-BRAVE trial, if you compare it with the SHARP trial, the survival has improved. The one reason what I thought was that the local regional treatments also have improved over time. And if you see the number of local regional treatments in the IM-BRAVE trial is much more compared to the SHARP trial. So probably that has contributed. So I would rather prefer to start with the local regional treatment, and then depending on the extent of disease, a patient like this, I may not institute immunotherapy straight away. Probably I might add the TKI based on whatever data we have, based on the meta-analysis, the ILBS data, the tactics data. Though it's, there is a debate going on, but probably I might consider, because the patient has PVT, we know that there is high chance of failure. Post SBRT or TARE or TACE, whatever procedures my colleagues are performing, I might add TKI and will reserve immunotherapy as second line treatment for this patient.
Yeah, thank you. And Dr. John, can you, what is, if suppose the patient, our patient has undergone TARE, and do you think adjuvant systemic therapy is warranted? And if so, what are the systemic therapeutic options that are there now?
Okay, systemic therapy, when you look at adjuvant setting, so initially, first thing which comes into mind is the STORM trial, which was with sorafenib. And they showed that post-resection or ablation, when you give sorafenib, it doesn't give any added benefit in recurrence-free survival. So till this year, it was found that it was recommended that there is no role of adjuvant systemic therapy post-resection or ablation to reduce the risk of recurrence. But that has changed with checkpoint inhibitors. So this year, IMBRAVE 050 trial has come, and it has shown that the interim analysis has shown that there is a definite reduction in recurrences. That is, there is improvement in recurrence-free survival. So ASLD this year has given a strong recommendation that systemic therapy can be used as an adjuvant post-resection or ablation so as to reduce the risk of recurrence. Now, coming as an adjunct therapy to TACE. In that setting, the studies available are with sorafenib, TKI inhibitors, TKIs. So, the first thing that comes to mind is the tactics trial, in which they showed that when you add sorafenib with TACE, there is a definite improvement in progression-free survival, which was later confirmed in a case-controlled study from ILBS, and meta-analysis which came in 2022 also confirmed these findings. So sorafenib or a TKI has a definite role as an adjuvant therapy with TACE. Now ongoing trials are there with Emerald 1 and Emerald 2. The results should be out the next year, and then we'll be able to know whether immunotherapy is beneficial in these settings.
Thank you. And Dr. Dayanand, our patient had undergone a TARE. And how do you follow up these patients who have undergone tear or immunotherapy? How frequently do you do the CT and how do you follow them up?
Because the response take a lot of time, I think we take scan after 3 months only. The scan which is done before 3 months actually be very difficult to interpret or is misguide your like a result of this thing, tear. So there are so many classifications which for assessment of the loco-regional treatment, and each has its own problems. Like somebody if I'm doing a curative procedure like ablation, if somebody reports it's a LAIRADS, it's okay, it makes sense. But if I'm doing a TACE and somebody reports a LAIRADS, it makes no sense. If I'm doing a 60% necrosis or 80% necrosis or 90% necrosis, with a sequence of this thing, reports will be same. So each classification has their own problem, and we have to use judicially. And for a tear especially, and as far as radiation, there is no system which actually gives a proper guidance what way to report. So only way I think is to predict the tear failure or something is if the lesion is growing after maybe after 6 months, or if it is enhancement is again not a criteria. If there is a size increase as a progression, then only we can interpret it as a tear failure. Otherwise, if it is size is same, enhancement doesn't matter. So it will be a big problem. So it has to use all this experience to report a post-tear imaging. It's same with the radiation.
Yeah. This is CT at 3 months, and would you like to comment on 3 months post-tear?
Yeah, it's 3 months, 6 months, and this is a typical protocol I think most of the institutes follows. Fortunately, in the 3 months, I think this scan is not showing enhancement, and in 6 months scan, it's showing a significant reduction, and enhancement is also not there, and almost there is no, at the end of 1 year, absolutely the lesion is also not seen, and there is no enhancement. And it is easy to interpret in this case, but this will not be a same case each case. I think this is like a palliative case. Now is almost like it is look like it is cured from the disease.
So, Dr. Sudhi, we have the CT from 1 year, AFP is 45, DCP 110. Would you consider transplant here?
So, I mean, it's definitely the biology is better. But if you look at the good, the bad, the ugly classification, still the bad. It's not ugly, but still bad. So I think the risk of recurrence is still high. So you'll have to counsel them really well. They have to take all the risks that the tumor may come back. You can't list them because they will be beyond the listing criteria. So we are talking about a live donor transplantation. So are they willing for that? All the money, a live donor, and the chance of recurrence, like almost 50%, 60% recurrence in 2 years' time. So if they agree with that, yes.
Thank you all, and you agree that to manage hepatocellular carcinoma, you need a multidisciplinary team, and that should include a hepatologist, the transplant surgeon, the radiation oncologist, the IR, the medical oncologist, and most importantly, the palliative care physician also. Because most of these patients progress from BCLC A to B to C to D, and at the end, there should be a plan for end of care management in these patients. Thank you. And chairpersons, you want to add something?
Is there anything else? And questions from the house? Anybody else?
Thank you, doctors.
Okay.
Thank you.
Thank you.
I request Dr. Philip Augustine to please come on stage for the closing remarks.
Members of the faculty and delegates, Light Update 2023 has come to an end, and everybody told me that it was a very well conducted meeting. Everything went on well, on time, and I'm glad to agree with that opinion. And I thought I'll tell you the success story behind this. As you know, Light Update is a private initiative. It's not under the auspice of any organization, but we had the blessings of the Indian Society of Gastroenterology at the national level and state level, Society of Gastrointestinal Endoscopy of India, Indian National Association for Study of the Liver, and the Interventional Radiology Society of India. And we had blessings from the institute, RAJAGIRI Hospital, where we are working now. And the concept of organizing such a meeting is actually my concept. I've been seeing the growth of interventional therapeutic endoscopy over the decades, and I've been part of that, especially pancreatobiliary endoscopy, ERCP. Then endosono and all the other interventions came. But I was really surprised with the growth of interventional endoscopic procedures. I came to know the potential only after Dr. S. Rajesh joined our team as the interventional radiologist. Now he is an assistant too. Tremendous possibilities, helping patients day in, day out, managing emergency situations. It was a wonderful information for me. And I knew the general gastroenterology community probably doesn't realize the potential of this. So I thought we will have both interventions. They are doing it for the benefit of the patients separately, but to have a concept of interdisciplinary work, I thought it will be a good thing to organize this. So once the concept was developed, we had field marshals to implement it. My role stopped with developing this concept. We had 4 field marshals, 2 organizing secretaries, Abhi and Dr. Rajesh himself. And then chairman of the organizing committee, Dr. Ajit Taragan, and Dr. Rizwan, vice chairman of the organizing committee. So they decided all the topics, wonderful topics, and they fixed all the speakers, very knowledgeable, wonderful speakers. And I, of course, told them to bring in senior level faculty. I knew Professor Peter Cotton had expressed his desire to see Kerala. He heard of Kerala very much, but never had an opportunity to come. During one of the conferences, I was told that he would like to visit Kerala. So I told we will take him as a principal faculty, and he was glad to come. In fact, he came 1 week in advance, and he has seen Kerala and will be leaving tonight. And I also wanted senior people like Dr. Nilavari, Dr. Rama Pivenu, Dr. Brewer, and of course Sarin and Reddy. All the others, the effective speakers, were selected by this team. And they all readily agreed, and you've seen what they have delivered. And then we wanted a venue. This was the venue, wonderful venue, good food, everybody agreed. Then we wanted someone to carry out this. Mr. Raju Kannampura with his executive event management group have been supporting us over the years. And you have seen the wonderful infrastructure, even including this wonderful screen they have developed. It's all marvelous development. This is the background technological advances for a conference. I think we have given a benchmark for audiovisuals in this. And then you need support to implement it. We need financial support. I knew the pharma industry had a lot of restrictions and reservations. In spite of that, they wholeheartedly came forward to support us. And I thank all the people who supported us in this initiative. And of course, the final effectiveness of a conference is from the faculty. Very eminent global leaders actually, national and global leaders, who can authoritatively deliver speeches on their subjects. Many of them are pioneers in the field. So you could hear the best talent around the globe. And then finally, unless we have the delegates, what will be the success of the conference? We are targeting about 350 delegates. I think we have overshot that. So I thank all the delegates and faculty who are present here and already left from the bottom of our heart from the Liver Institute of Rajagiri Hospital for a successful conference. And I think I have mentioned everybody, the photographer, the MC, Master of Ceremony, keeping time. That is a wonderful experience for everyone to have things moving on time. So I thank all the support we receive for this conference. Maybe in future we'll conduct conferences of this type. Thank you very much.
Thank you, Doctor. And thus it comes to an end. Light Update 2023. Liver Institute, Gastroenterology, Hepatology and Technology Update. Thank you everyone once again. Thanks. Everyone, please come forward for the group photo. Can the entire team come to the stage for the group photo? Can the entire team please come to the stage for the group photo? Thank you.